I know we start morning. So first session in the morning is a little bit difficult to start, but we have a brilliant speaker today, Dr. D.S. Ray. And to chair this session, we have Dr. S.B. Raut, who is ex-professor and head Department of Nephrology at SCB Medical College, Cuttack. We are also joined by Dr. Upal Sengupta. He's senior consultant nephrologist at Fortis Hospital, Kolkata. I would also request Professor Om Kumar, head Department of Nephrology, IGMS, Patna, and senior consultant nephrologist, Dr. Hemant Kumar, sir, to please chair this session.
Dr. Upal is there?
Yeah, I'm here.
So I will request Dr. Upal to introduce our learned speaker, Professor D.S. Ray, sir.
So, can you hear me?
Yeah, you are audible.
Yeah, thank you. So, Dr. Roy doesn't need any introduction. He's an alumnus of AIMS building MD and DM, and he is FIS and FISOT and fellowship in nephrology from St. James University Hospital, Leeds, UK. He is presently the head department of the nephrology and transplantation in R.N.Tagore International Institute of Cardiac Sciences. So you know that this is one of the leading institutions in India, which is carrying ahead with the operation of transplants, different variety of transplantations, and with the huge experience. And he has published and presented more than 70 papers in international and national forums, and he has guided DNB theses, and a number of successful nephrologists has been trained under him. So he has successfully organized many conferences, and we know that his special interest is ABO incompatible transplantation, for he had an experience of more than 180. But today we are going to hear from you, Dr. Roy, about how to go ahead with ABO incompatible transplantation resource constrained settings in small, comparatively small settings as compared to the hospitals you practice. Will guide us through the protocols through your experience. Welcome you, sir, on the conference, and eager to hear you on this. Thank you.
Thank you, Dr. Upal. And now we are here to hear the biggest name in ABO incompatible transplant in the country. I think he has organized many meetings related to ABOI, and he is very well connected internationally. He has called Dr. Tanabe many times to interact with the nephrologist of India. Very dear friend of all of us, Dr. D.S. Ray, sir, please.
Yeah, yes. Chairman sirs, friends and seniors, I am thankful to the organizing committee for organizing the conference so beautifully, and Dr. Hemant Kumar, Om, and Harshvardhan, they have done very well. People who have not come here, they will be missing the hospitality. And I am also thankful to the scientific committee for inviting me to give a lecture which is on a topic which is close to me. Without any delay, we'll start straight away. See, we started ABO incompatible transplant in June 2013, and over the period, we are doing around 30 transplants in a year, except for the COVID time when it dipped down to 15. And till today, we have done, if we include yesterday's transplant, we have done 232 transplants of ABO incompatible situations. What is the advantage? Advantage is there is a reduced waiting list time, expansion of living donor pool. There is improvement of patient's prognosis and lifestyle, and excellent graft survival. It is comparable with ABO compatible transplantation. What are the apprehension? In spite of ABO incompatible transplantation being good, there are a lot of hospitals now doing ABO incompatible transplant, but till now it has not become that common, especially in East. So there are apprehensions. The apprehensions encountered are desensitization can be troublesome, graft function may not be good, there may be higher incidence of rejection, higher incidence of infection, there may be more bleeding, and long-term outcome may not be good, and the cost is very high. So I'll deal one by one points or apprehensions, and I'll tell you why it is a wrong apprehension, and then we can decide whether it can be done in a limited resource situation. See, before desensitization, I'll give you the desensitization protocol of some of the leading institutes of world. This is a protocol which is done by Professor Tanabe, which is very well known. He uses little higher dose of rituximab. He does mostly DFPP, double filtration plasmapheresis, and he uses basiliximab as an induction therapy. Another center which does good number of ABOI is Germany's Fever University Hospital. They use a higher dose of rituximab, around 500 milligram per person. And they use also basiliximab as an induction therapy. And they do immunoadsorption, which is more expensive than the other variety of desensitization, which we will come to later on. The Mayo Clinic protocol, they do plasmapheresis, but they use a ATG in a longer or higher dose than normally we use. This is our protocol in Rabindranath Tagore. You might be knowing this has been published many times, and I have spoken about this. We start giving rituximab 14 days prior to the date of transplantation. We give a dose of low rituximab, 100 milligram if the antibody titer is 256 or less. 512 or more antibody titer, we give it is a dose of 200 milligram. We simultaneously start steroid, tacrolimus, and mycophenolate. Admit the patient 7 days prior to the date of transplantation. We do plasmapheresis if antibody titer is high. And we do the transplant when it comes down to 1:64 on 2 consecutive days. And like our compatible transplants, in incompatible transplant, we also use ATG in a low dose, that is 3 milligram per kg in 2 divided doses on the day of surgery and next day. Gradually, we drop down in mycophenolate to 1.5 gram, 1 gram per day, and steroid to 5 milligram, and the tacrolimus level to 4 to 6. Over the time, with the experience, we have tailored our preconditioning. Initially, our target antibody titer before transplant was 1:8, which increased to 1:16, and now we are accepting 1:64. Initially, we are giving a higher dose of prednisolone, 50 milligram, and now we have reduced to 20 milligram and then tailored down to 5 milligram like ABO compatibles. And as I said, because we have increased the antibody titer, we are accepting a titer of 1:64. Our plasma pheresis numbers have come down. For B cell depletion, the rituximab we use nowadays 100 milligram when the antibody titer is 256 or less, and 200 milligram when it is 512 or more. This not only reduces cost, this also reduces the infections. Initially, we had done conventional tube method. Now we are doing column agglutination method. There are 2 types, gel or bead. Both are cheap. Both are possible to be done in the blood banks of any hospital, and it costs hardly 200 rupees. Then coming to graft survival, the apprehension about graft survival, there are various studies. These are earlier studies where they have shown long and short-term graft survival of ABO incompatible and ABO compatible are to be similar. These are relatively recent studies, and the 5 and 10-year graft survival from Japan, from Germany, and different places have been shown to be similar, whether it is abiocompatible and abioincompatible. In fact, even though statistically not significant, Japan shows a better graft survival in abioincompatible ones. We did a short-term study. It's a prospective study between abiocompatible and abioincompatible transplants. And we found the creatinine, the GFR, the rate of rejections, and post-transplant hospital stay to be similar in both the groups. This is recently concluded a retrospective long-term study with a average mean follow-up period of around 5 years. And we found there are no difference between abiocompatible and abioincompatible one as far as the creatinine level, as far as the death of the patient and rejection rates are concerned. This is under publication. Then come infection. There are studies showing that viral infection to be more common in abioincompatible transplants, both BK virus, varicella zoster virus, CMV virus. And this is another data from US where the infection rate has been shown to be higher. But there are also data which shows infection rate is similar as abiocompatible. Our belief is it depends on the amount of immunosuppression you give. If you are giving too much of induction therapy, if you are giving a higher dose of rituximab or a higher dose of steroid, there is more chance of infection. Now our immunosuppression protocol is absolutely similar as abiocompatible one, except for the rituximab dose, low dose rituximab we use. So our infection rates are similar to the abiocompatible one. This is an interesting paper of a meta-analysis of some 26 centers, but not necessarily all centers had experience of doing good number of abioincompatible transplant. This shows there is a significant higher rate of infection in abioincompatible one. The cause for increased infection are thought to be because of the additional immunosuppressants like rituximab, plasma exchanges, which can cause hypogammaglobulinemia, and rituximab can also increase the risk of pneumocystis pneumonia, CMV disease, and other fungal infections. And Dr. Tanabe has shown because of rituximab, there can be neutropenia in 30% of patients. But our result, because we do use a low dose of rituximab, both in the shorter term and longer term, the infection rates are similar to the compatible one. So what strategies you can adopt to reduce the infective complication, reduce the dose of rituximab, and lower the anti-proliferative agent. We normally use, because we use tacrolimus, we use normally 1.5 gram of mycophenolate, and then we drop it down to 1 gram post 6 months. In fact, if the patient is poor, we start azathioprine in a dose of 50 milligrams. So our anti-proliferative agent dose is less. Now that we are doing, our target antibody titer is 64, we are doing less number of plasma exchanges. And of course, we give in any patient long-term prophylaxis like cotrimoxazole and valganciclovir. This is a paper published where we compared between 100 and 200 milligram of rituximab in with the initial antibody titer of 256 and lower. We continued for 1 year to count the see the CD20 count. We found the CD20 number to be similar in 100 and 200 milligram, and infection rate is significantly lower in the low rituximab group. There are some apprehension, even though not much, of bleeding complications, but the strategies, we in our institution have not documented any increased risk of bleeding. That's because the bleeding complication can happen if you are doing plasmapheresis, because the plasma, with the plasma, the clotting factor goes, and if you are replenishing only with albumin. So we replenish with FFP, so the bleeding bleeding doesn't occur. But if you are using albumin, at least in last 1 or 2 plasmapheresis, use at FFP for 2 to 3 units of FFP, so that during surgery bleeding will not happen. Then the major apprehension is the increased risk or increased expenditure of transplantation. See, the additional expenses is incurred because of desensitization requiring rituximab, requiring plasmapheresis, replacement fluid, IV immunoglobulin, and regular monitoring of antibody titer. There are very few studies about the cost. This is a study from US, where they have shown in ABO incompatible transplant, the cost of transplant is just double the ABO compatible one. And over the years, in first, second, and third year, the cost of ABO incompatible transplant is higher. That is possibly because they use higher immunosuppression and higher number of infection and hospitalization because of the infection. This is from Japan, from Tanabe's Tokyo Women's University, where they found slightly higher cost of ABO incompatible transplant during transplantation, but over the period, the cost has remained similar to the ABO compatible one. We have our patients are actually, they come from a middle economic group, so we have to make it affordable. We have made it affordable by using low dose of rituximab. We do a plasma exchange of 30 ml per kg. We don't do a very high plasma exchange, 30 ml per kg. We use FFP instead of albumin, which is cheaper. We use low dose IVIG, and we have now targeted our antibody titer to be 1:64, requiring lesser number of IVIG and lesser plasma exchanges. The isoagglutination measurement is done by column agglutination, which costs to the hospital 200 rupees per test. And we do not do, there is no point in following up with antibody titer, because it doesn't help you in treatment unless there is a clinical indication. There is no point in doing antibody titer post-transplant in a follow-up situation. And post-transplant, we do not do like some of the centers doing plasma exchange. They continue plasma exchange or immunoadsorption. We do not do, because it is not required. And we switch over to 1 gram MMF after 6 months, as I said. It got stuck. Can somebody help? Okay. Say in a resource limited situation, you can do plasmapheresis. You don't have to do DFPP. You don't have to do immunoadsorption, and plasmapheresis can be done by our own dialysis machine. Our technicians are trained to do plasmapheresis, or if they are not, it takes very few minutes. I will take 2 minutes more. And this is how the plasmapheresis is done. And you can use lower dose of rituximab, which hardly costs 4,000 to 5,000 rupees. Normally, when we increased our antibody titer, target antibody titer to 64, our patients require 3 to 4 plasmapheresis in a majority of cases. The IVIG required is 15 to 20 grams. And you can do column agglutination technique, which is reliable, reproducible, and it can be done in any blood bank. The cost, as we calculated, is the plasma filter cost around 8,000 rupees. FFP per bag is 1,000. Every plasmapheresis you will need around 8 FFP, so 8,000 rupees. IVIG 12.5 thousand per 5 gram. Rituximab 4.5 thousand per 100 milligram. Plasma filtration procedure 1,500 per procedure. And so expenses of 5 sessions of plasma exchange is around 1.3 lakhs. And if you are doing 10, it will be 2.6 lakhs. It's not very high. So to conclude, ABO incompatible renal transplantation with plasmapheresis, single dose rituximab, low dose IVIG in combination with standard triple immunosuppression can be performed with excellent result in any hospital which does transplantation. Results are comparable with ABO compatible transplants. Only moderate escalation of cost. No additional infrastructure is required. That's very important. And we can expand the donor pool from the family by 30 to 35%. I'll end with an invitation to the transplant colloquium we are doing on 14th and 15th of May in ITC Royal Bengal, Kolkata. We have two international speakers, Professor Stanley Jordan from Cedars-Sinai, Los Angeles. He has maximum work in HLA desensitization. This time we are stressing more on the immunology part of it. Then Professor Dennis Gloss from St. Louis Hospital, Paris. He has a lot of work in antibody AMR treatments. And this will be done in the beautiful hotel of ITC Royal Bengal. We never had a nephrology conference there. So I welcome you to the conference. Thank you. Thank you very much.
Thank you, Dr. Rai, for your comprehensive talk on low-cost model of ABO incompatible transplantation. And then there is a question from Dr. Bhala, whether your ABMI rate has increased after your target is 1:64.
Pardon?
After your 1:64, you have made it lowest level. Whether rejection rate has increased, ABMI rate?
No, not at all. In fact, if the antibody titer is around 32, we do not do any plasmapheresis. We give rituximab and we straight away go for transplant.
Okay. Have you done anything without doing plasmapheresis? If level is less, 1:8.
Yes.
Any other question from the audience?
Morning, sir. So my question is, sir, as your baseline titer is 1:64, do we have data from our own country, whether 1:64 versus the lower titers and the outcomes, sir? Because
we have no data from our country, but from Japan, they are doing 1:64 IgG titer.
Okay.
So there are papers on that.
Okay.
But from our country, I think nobody uses 1:64. We are using this. And once we have more number, we can have a data. Majority of patients, actually, if you start, suppose they have come with a 1:128, you give a couple of plasmapheresis that drop down below 32. So you can't take them. So we have to take only 64 ones.
Right. Because there were some reviews and literature, sir, which was suggested that lower the value, better is the outcome.
Now that is on proof. We have another paper under publication. Lower the pre-value or lower the initial value?
Lower the pre-value, sir.
There is no truth on it.
Okay. Thank you, sir.
Thank you, Dr. DSA, for your excellent talk on the challenging area of renal transplantation. Thank you.
Thank you very much. Thank you, Chairman.
Thank you.
Thank you, sir, for an excellent presentation, sir. Thank you. So moving on to the next session, I would like to invite the chairperson, Professor D. Bhaumik, who is a professor of nephrology at All India Institute of Medical Sciences, New Delhi, Dr. Anup Burman. He is the Director of Medical Education, Government of Assam, and Professor Anupma Kaul from SGPGIMS, Lucknow.
Good morning. Am I audible? I'm unable to start my video. but in any case, so
You're audible, sir.
yeah, fine. So now it's a pleasure to start the next session in which we'll be talking about the expanded criteria donors. And first talk is by Dr. Shubha Banerjee on expanded criteria donors. Can you expand more? He is an associate professor of nephrology at IKDRC Ahmedabad, and he has several publications to his credit. Would love to hear from you what are the expanded criteria which are being followed now, how you can expand more, and this will be followed by a talk by Dr. Bhalla on the clinical outcomes of expanded criteria donor. Dr. Shubha Banerjee, without wasting further time, the floor is yours. Please go ahead. You're not very audible, Shubha. Can you just speak into the microphone? The slides are visible, but you're not very audible.
Am I audible, sir?
Yeah, now you're audible. Yeah. Go ahead.
Okay. So, very good morning. And first of all, I would like to thank my chairpersons for this introduction. And I'd like to thank the scientific committee of the ISOT, the organizers of the midterm ISOT at Patna, for giving me this opportunity to be here. So the topic that has been given to me is expanded criteria donors. How far can we go? And can we expand more? So this picture alongside is from the pig to heart human transplant, pig heart to human transplant. And that shows that we need to break the boundaries and we need to go ahead because of this large supply and demand gap in transplantation. So what are we going to discuss today? The global CKD burden, the big supply and demand gap, global and national data, the definition of expanded criteria donors, the benefit to expect from such expanded criteria donation, who should expect such a benefit, making the best use of ECD kidneys in our setups, and the global and Indian experience with the ECD kidneys. What we're not going to discuss, unfortunately, is the DCD donors, which also constitute the marginal donors, but are a little out of scope of the ECD donation. So we have been discussing this all throughout yesterday, that there is a huge increase in the number of CKD patients across the world, and India is no different. So this is probably because of the increasing numbers of diabetes and hypertension overall. So just to put some numbers in, so there has been a 30% increase of prevalence of CKD and at least a 40% increase of attributable mortality because of CKD. So these are the graphs from the GBD chronic kidney disease collaboration coming up in Lancet 2020. So what is important is if we adjust these the burden for age, we see that there is an incremental burden as the population ages, with the highest numbers being around at least 3 to 4 times higher in the elderly population. And why is transplantation the only viable choice in low medium income countries? Because it is the only form of treatment we can afford because of the costs. So we have been seeing these graphs and these numbers throughout yesterday. So India in absolute numbers is ranked 2nd or 3rd in the transplantation list. But once we normalize it for our population, the numbers are very low for living as well as for deceased donors. So just a statement of the supply demand gap in India. The annual rate of increase is around 229 to 230 persons per million, which is around 13% growth of total ESRD patients annually. So 2.5 lakh new transplants are required every year, but what we have been doing is around say 8 to 9,000, and that has taken a major setback because of the COVID pandemic. So that means and that mandates that we need to be looking for kidneys at places we have not been looking very keenly. And that brings us to the possibility of using more and more extended criteria donors. Now, it is a very common scenario to have an elderly patient in the ICU with a creatinine a little higher than normal that we would like for our donors. And this is where the concept of ECD kidneys have come. Now, these terms have been used very loosely since the 70s, but it is in 2001 that the definition was codified. And now it includes donors with age more than 60 or donors between 50 and 59 with at least 2 of creatinine more than 1.5, hypertension, or a death due to CVA. Now, where did they come up with these numbers and definitions? How did they reach there? So this by definition, there is a 70% increase in the risk of graft failure compared to a standard criteria donor. So these are not good kidneys. There are 70% more chances of graft failure. So the first question that comes is there a benefit of doing such transplants with grafts we know are not going to do well? So useful statistic for patients is a standard kidney would last an average of 10 years, while a ECD kidney would just last for 5 years. So is there a point in doing that? So that's it? Definitely no. The answer is no, because the comparison is not with SCD kidneys, but it is rather with staying on dialysis. So what has the data to show that the average increase after a marginal kidney recipient gets an ECD kidney is that the life expectancy increases by at least 5 years, the range being around 3 to 10 years. So further evaluation of this data has shown that there is an early increase in mortality. This is true also for ECD kidneys, for SCD kidneys. So the mortality benefit may not be apparent up to 3.5 years because of the death because of transplantation or the recipient factors. But if we adjust the mortality for all these factors, so there is at least a 17% drop in the mortality after a person gets an ECD kidney. And in regions where the waiting time is very high, say 3.7 years, so there is a 27% decrease in mortality. So it does give mortality benefit. Now, the Medline and Embase database has been reviewed, and ECD kidneys do not perform as good as SCD kidneys. That is obvious. So these should not be offered to young patients like 40 years or younger, or those with those expecting a retransplantation. But those above 40 years of age with diabetic nephropathy and expected long waiting times can actually offer these kidneys and derive some benefit out of that. So a decision tree was published by Marion et al. That if the person has ESRD, is aged more than 40, has diabetes, estimated waiting time is more than 3.7 years, and belongs to non-Hispanic race, and not expecting a retransplant and is less sensitized, they can actually derive some benefit. Now, in 2013, this term was a little bit changed from ECD to the definition of KDPI, the Kidney Donor Profile Index, so which consists of 10 donor factors. Just keep this in mind, donor factors, which allow us to qualify the donor, kidneys that are available. This was derived from a 14-point KDRI, and this was supposed to rank order the quality of kidneys. And it was expected to decrease the discards and increase patient or graft survival and increase utilization of such organs. So along with this came the concept of longevity matching, wherein a metric called EPTS, that is estimated post-transplant survival, will mark you a patient who is supposed to survive long, and these patients should receive a standard criteria kidney. And those, suppose the elderlies who have a limited life expectancy, they get these ECD kidneys, so that there is a longevity matching. We give good kidneys to young patients and ECD kidneys to older patients, so that the young patients don't turn up for retransplants again and again. So is KDPI a better indicator than ECD? So mind you, KDPI was not supposed to answer this dichotomous question whether to use or discard a kidney. It is rather a continuous metric. So there is this significant discordance between SCD, ECD versus KDPI. And it does not decrease discard rates according to observations, because once the discussion starts that this is a high KDPI kidney, this might be SCD, standard criteria donor, but the KDPI is high because of some other factors. Once the discussion starts, there is a risk of this kidney getting rejected by the patients and the transplant hospital. So this is called the labeling effect. And what has been seen that even if kidneys with very high KDPIs are used, suppose KDPI from even 91 to 100, they actually provide survival benefit to the recipients. And this does not take too long, but around say 1.5 years, there is apparent increase in survival. So what to do? So that brings us to the possibility of using a pre-implantation biopsy. The typical has been to use the Ramosy score for allocating single, dual, and discards. So if it is more than 6, the kidneys are discarded. And it has been shown that for ECD kidneys, if we use a biopsy, it is possible to get identify those organs which will actually provide some benefit. Now, several other indices are also available, like the Maryland aggregate pathology, but by and large, they are the same. They score glomerulosclerosis, the vascular lesions, and the IFTA, and they have shown that they can predict survival. But what is important is significant experience is needed for pathologists to provide good insight. what has been seen is if transplant pathologists they evaluate the kidneys, they will give you a good information, and that will be predictable of survival. But if usual pathologists or just on-call pathologists rate these kidneys, they don't do much well, and so it is very difficult for biopsies to be used for discarding kidneys. So several reports have been published. They're very heterogeneous, some are of low quality, and it is not always possible to use biopsy for routine because experience must be built. And the wedge biopsies that are typically used, they overestimate glomerulosclerosis, and there is a high chances of discard. So can we use both biopsy and kdpi in a complementary role? To understand, kdpi is a donor-specific metric, and the use of pre-transplantation biopsy with kdpi can limit the number of discards without compromising the overall graft survivals. Now, what are the other methods of decreasing organ discard? So machine perfusion is one option, and dual transplants. So we have heard a beautiful talk by Dr. Stephen Turias yesterday about kidney perfusion. Just to reiterate. So machine perfusion, this is hypothermic perfusion. So they will support the metabolic requirements of the kidney, and there will be elimination of metabolites and free radicals, and they tend to preserve the endothelial cell function. So this has been proven in several studies that hypothermic machine perfusion, when used for ECD kidneys, can reduce the risk of DGF compared to cold storage. And there is the incidence of primary non-function is at least 4 times lesser when using a hypothermic perfusion. Also, the 1 and 3 year graft survival is definitely lower when cold storage is being used compared to machine perfusion. So meta-analysis of all the published reports, they have shown that the incidence and even the duration of the DGF can be reduced, and 1 and 3 year graft survival has definite improvement. Also, using machine perfusion, we can mark some physiological factors, and we can identify the kidneys which will typically not do well and they need to be discarded. Now, coming to dual transplants. Now, dual transplant increases the nephron dosing in cases of marginal organs. They can be used for marginal organs that are otherwise going to be discarded. It's very high kdpi numbers, or suppose a high creatinine or something like that. So lesser discard rates with dual kidney transplantation is very lucrative, but we need to balance very liberal use of DKDs against single organ usage, so that it will not lead to a suboptimal organ use. Every kidney that is ECD and has a high creatinine or something like that, so that they should not be allocated for dual kidney transplant all the time. So several plans have been made as to how to classify these organs for dual and single transplantation. They include criteria like donor age, histopathology, a combination of age and histopathology, GFR, creatinine, donor comorbidities, and several reports have been published. Now, do dual kidney transplants help? Yes, they do. Compared to a standard criteria donor, dual kidney transplant do at least as well as at least an ECD donor. So dual does not offer excessive benefit over ECD transplant done in a single kidney fashion. But what is to be kept in mind is those organs that are being taken for dual transplant are typically worse than the organs that are being taken for single kidney transplant in ECD. So these are bad quality organs which are doing at least as good as ECD organs. So this must be kept in mind, and technical expertise must be built in the centers. And in organs which have a kdpi of more than 90, these are extremely bad organs, and even then dual kidney transplant gives good survival compared to a single kidney transplant. Also, an important thing is that these recipients are essentially different from the standard recipients. So ECD kidney recipients need tailored immunosuppression. Why is that? Because ECD kidneys are known to be more immunogenic. The Eurotransplant Senior Program will not go into the details of that program because of the lack of time, but they have reported at least 30% increased risk of acute rejections. Mind you, these are transplants that are being done with minimal immunological workup. So that is a very important point. So they just take patients who have a low PRA and without much cross-match, with a cross-match, without doing HLA typing, they're allocating to recipients. So ECD kidneys, once these immunological risk have been adjusted, ECD kidneys have shown similar rejection rates. So the immunogenicity may not be that high, but what has been shown is intense inflammatory response and increased T-cell immunoreactivity is the truth. So what are the various trials? So various policies have been used for managing the immunosuppression in ECD kidney recipients. So trials with induction, where RATG has been compared with basiliximab and Campath. Steroid withdrawal protocols have been used along with ATG induction. The belatacept trials have been published. Delayed CNI protocols have been published. And there are some trials with the use of mTOR inhibitors. So CNI avoidance with sirolimus, CNI minimization with everolimus. So overall data is favorable for mTOR inhibitors, but overwhelming benefit is lacking. So worth a mention is this benefit extension trial published in 2016. This is the largest international multi-center randomized trial for ECD kidneys and DCD kidneys. And the numbers was around 500 patients were included. And the outcomes were evaluated at around 7 years. So this is long-term outcome. So belatacept was used in 2 different doses, low and high, and they were compared to cyclosporin. And what was found is that relative to cyclosporin, belatacept was associated with similar death and graft loss and improved renal function at 7 years and had a good safety outcome. So there is a possibility of using belatacept. So overall, what should be the immunosuppression strategy in ECD kidneys? So induction should typically be with ATG, so that later on we can have a lower overall immunosuppression burden, especially in the elderly patients. Reduce CNI exposure. So from the onset, around 25 to 50% lower doses can be used in selected patients. Some centers have used delayed CNI introduction regimen to counteract the effect of DGF. Now, CNI-free regimen have been used with MMF and steroid. So dual immunosuppression with ATG induction. CNI-free belatacept regimens have been used, and delayed CNI exposure and CNI-free mTOR inhibitors have been used. So there are several papers regarding the use of ECD kidneys, most of them from IKDRC somehow. So deceased donor organ transplantation with expanded criteria donors even for younger recipients, because typically India is a country where most of the CKD patients would be typically younger, and the use of dual kidney transplantation from expanded criteria donors. So all of these have given favorable results with good graft and patient survival. Now, deceased donor renal replacement in a single center experience, again from our center. This is Indian Journal of Nephrology publication in 2017 from Parthasathy and group and George Abram sir. And the outcomes of dual kidney transplantation from marginal disease kidney donors. This is a small abstract which I could lay my hands on. So they have all shown good results with ECD kidneys, but the numbers are extremely small. So there is a long way for the Indian transplant societies to go. So to conclude, the ECD kidneys typically represent a missed opportunity for most disease donor transplant programs. They can improve survival in well-selected patients. So we need to handpick these recipients. Maneuvers like pre-implantation biopsy, machine perfusion when available, dual kidney transplantation when feasible, they can help in decreasing discard rates and improve patient and graft survival. And post-transplant management needs to be tailored in these ECD recipients so that overall patient survival can be improved. So my sincere thanks to the midterm ISOT committee and the ISOT. Thank you.
Thank you, Dr. Shubha Banerjee, for your excellent talk on the ECD in transplantation and whether we can expand it more or not. So I thanks the ISOT office bearer for giving us this opportunity to share this session. So definitely it would be considered a novel approach to expand our donor pool to minimize the gap between the supply and demand. And then again, and this is high time, I should say it is a high time to renew our this expanded criteria so that we can increase our donor pool more in ECD. And then there's, so now the topic is open for discussion, so we can invite a few comments or questions from the audience.
A very nice pathology team also. Are you doing a pre-implantation biopsy? Because machine perfusion is difficult, but pre-implantation biopsy and getting a fast report before you go for surgery sometimes is becoming important.
Yeah, so ma'am, the major indication for doing a wedge frozen section biopsy in our center is typically for patients who are anuric. That is where there are sometimes that the donors are not well managed, and by the time we receive the kidneys, patient is anuric. So the number one concern we are having is there a cortical necrosis? For ECD kidneys, we have used pre-implantation biopsy, and it is more or less very difficult because the requirements are very high. It needs around 25 glomeruli to be screened. So the criteria is very high. So typical report would be that the biopsy is inadequate, but we have transplanted kidneys from donors who are around 80 years of age with relatively good outcomes. The overall outcomes, unfortunately, probably because of the immunosuppression and the kind of recipients we have. So it is my hunch, we don't have the exact data, but it is probably because of the allocation strategies that we have. And these kidneys typically go to the elderly patients. It is not a policy, but typically it goes. And because of that, we don't have very good survival. But we have implantation biopsy, and we have had cases where anuric patients' kidneys have been taken. We have done a biopsy, and we have found they're good, transplanted, and patients are doing fine.
May I have a question? Question is
graft survival.
Yes. It should be placed en bloc or separately. Dr. KL Gupta here.
Shubho, congratulations for excellent talk. Just I would like to what will be your suggestion?
Just a minute, please. I think Dr. KL Gupta asked a question first. First answer that question.
My question is, do we place a dual kidney en bloc or do we place it separately, left and right?
Typically, sir, our center has been using en bloc with a Carroll's patch, aortic patch, and inferior vena cava.
But it all depends on the person, whether we can space and all that, we can accommodate. Because I was talking to Dr. Shiv Sharma from our PJ, our institute. They have done 6 dual transplant. He was telling that we did 4 en bloc and 2 separately. So any idea from you?
So also in our center, both are being done. For pediatric kidneys, dual transplant, typically they are taking en bloc. So there is no debate about that.
No, my question was for adult kidneys, not pediatric. That of course no doubt on the we can raise. Adult kidneys.
So for adults, they typically harvesting, sir, is done as a single. So the decision to transplant en bloc become difficult after the harvesting. So after that, I guess it's a mix up. There is a mixed numbers where some patients have been given single kidneys, two separate kidneys. I know of at least 4 or 5 patients who have received two separate kidneys, and I know of at least one patient who has received an en bloc kidney.
Technically, which is more easy?
So I don't think I can comment upon the technicalities of a dual transplant en bloc and something. So I guess we need to have a word with the surgeons.
Okay.
Subha, just I have just one question in my mind. Just you said that the transplant ECD kidneys are more immunogenic, and then there is a 70% increased risk of graft failure in compared to the SCD donors. But traditionally, the immunosuppressive medications in the SCD are done, which is in ECD is a less in compared to the SCD. So how can you expect a more graft survival if you use a less immunosuppressive medication in a highly immunogenic kidney transplantations?
So the what the data has shown that if we take the immunological risks of the recipient, we adjust for that. So there is some evidence to say that the immunogenicity may or may not be high. There are very discordant reports. The initial experience was that these kidneys are more immunogenic because of an intense inflammatory response. But after the recent data that has been published, that shows that once the immunological risk of the recipient is adjusted for, so they don't do too bad. And most of our grafts, patient survival is dependent not on graft failure, but because of intense immunosuppression in the elderly, we lose the patients rather than the graft. So patient loss with a surviving graft is far more common in our experience compared to graft loss per se.
Any comments? Bomik sir, any comments from your end? And no, Anupama call is here?
Yes, Anupama is there.
I'm there, sir.
Yeah, ma'am, please.
So actually, I just had one comment. So we're talking about extension of the donors. So I was just wondering, what is your take on patients who are donors who actually are hepatitis C or B positive, and they're in a naive hepatitis or C or B negative for an extended donor pool?
Yes. Thank you. So if there's no question or no comments, then we can close this session. Once again, I thanks Dr. Shubha Banerjee for your excellent presentation. Thank you.
Thank you, sir. It has been a pleasure.
So we move on to the next session. To chair this session, I would like to invite Professor J.P. Tiwari, who is the head Department of Nephrology at Goa Medical College, Goa. I would also like to invite Dr. Shobhik Shural. He is a senior consultant nephrologist from Kolkata, presently attached with PLS Hospital. And I would also like to invite Dr. Abhilash Chandra. He is additional professor and head Department of Nephrology at Ram Manohar Lohia Institute of Medical Sciences, Lucknow.
Good morning. First of all, I like to thank the organizer, Dr. Om Kumar and his team, and Secretary ISOT, Dr. Vivek Pote, for providing this opportunity to chair this session. This topic is marginal donor renal transplant. Is the outcome marginally different? As you know, use of the marginal donor are important to increase the pool of organ for both live and deceased donor transplant program. And it has been shown that good allograft outcome is obtained with proper optimized preservation, procurement, and allocation of organ, and associated with significant survival benefit in these patients as compared to the patient on dialysis. We have with us an eminent speaker, Dr. A.K. Bhalla, who is chairman and head of nephrology at Sir Gangaram Hospital, New Delhi. He is the president-elect of Indian Society of Nephrology, executive member of Delhi Medical Council, president of Society of Renal Nutrition and Metabolism, executive member of Indian Society of Hemodialysis. His main interest is peritoneal dialysis, vascular access, ABO incompatible kidney transplant, renal nutrition. And he is the recipient of prestigious award like V.C. Rai Award and Padam Shri Award. I like to invite our eminent speaker, Dr. Bhalla. Dr. Bhalla, sir.
Thank you, Dr. Tiwari, for your kind introduction. At the outset, I would like to thank Dr. Harshvardhan, organizing secretary, and other members of organizing committee for inviting me to deliver this talk. And I am thankful to scientific committee for giving me this opportunity. And I congratulate you for arranging this hybrid conference after a gap of 2 years. My slides are actually not moving. Yes. So already we had very illustrious talks by two very experienced speakers on ABO incompatible transplantation and expanded criteria donors. Now this is a marginal donor actually is the real practical topic which is relevant to us in our country. Now that as we all know that the waiting list is increasing and there is a huge gap between the demand and supply of organs. in our country. The reason being that the cadaver donation is hardly less than 5%. And there are various reasons for that. So why we require expanded donor pool? Already statistics have been given by the previous speaker. Now, we don't, although it is legalized, but yet it is not popular as far as cadaver renal transplant in India is concerned because of various social reasons, ethical taboos, poor infrastructure, and financial constraints. And dialysis again is a costly affair, and it is not available in every place in our country, except for metro tier 2 and tier 1 and tier 2 cities. And then question of unrelated donors when we don't have the good cadaver donor supply in our country. Now, why we are talking about marginal donors? Actually, it is a real practical problem. Hardly we find a exactly ideal kidney donor when we do workup of our living-related donors. So all in, as far as I am concerned, my experience of 35 years shows that there is some compromise in every donor. Actually, to be frank and to be realistic, there is some compromise in every donor. So ideal criteria are not being met by when we are accepting live related donors. So there is a compulsion to accept these marginal donors to partially meet the need for renal replacement therapy. So, but we have to be very, very careful that we should not jeopardize the transplant outcomes as well as health of the donor. This marginal donor, actually, not only is it the results are going to be different. That is the topic of my talk, that we have to look for the recipient's results as well as the donor's results. We should not jeopardize the quality of life of donor. That is, I think, very important. And how can we expand this donor pool? That is the important, that live related as well as cadaver. These are the two most important and practical points. And then donor swapping, that is paired donation, and then that is going to be in nest top. And non-heart beating donors, again, that is not something which is not becoming popular in our country. And again, what I think is, again, it is the IKDC Ahmedabad which should take the lead, because they are doing a lot of cadaver transplant. And the emotional donor, which is allowed by our Human Organ Transplant Act, where the authorization committee gives the permission, whether it is due to friendship or neighborhood or knowing for long duration. And then, or ABO incompatible transplant, which is already a reality since last about more than 10 years in our country, and it is going to stay. Almost 1/3 of patients which were rejected initially because of ABO incompatibility now are being accepted routinely. You have heard the talk today. And unrelated donor, definitely we should discourage as much as possible. Now, when we talk of expanded criteria for a live donor, the commonest in our country is actually elderly donor. Then other is donor with underlying medical conditions, when we have almost 1/3 of population in metro cities having diabetes as well as hypertension. And these two being the almost common causes of CKD. So that is a real concern, that how to accept the patients with these comorbidities. And other thing is, when a patient has CKD, then you have the familial and genetic diseases where you, like FSGS and other polycystic kidney diseases, other diseases. So you have the genetic diseases. So then again, there is a dilemma whether to accept a donor from that family. And then donors come with structural abnormalities in the donor kidney. So marginal donors can be complex living donor, which is most practical point for us, and non-heart beating donors, which I am not going to talk today. And disease or cadaver donor already has been discussed in detail in the previous talk. So what are the risk factors actually which we see in a complex living donor? One is a patient can have microscopic hematuria donor, proteinuria in a donor, and donor with nephrolithiasis. Then direct risk of CKD, where a donor is having hypertension, and an elderly donor, reduced nephron mass, especially when age is more than 65 years, genetic risk factors like history of ESRD in first relative. I think this is very important. In every patient, we must ask in detail about the history of ESRD in the family. And cardiovascular risk factors like smoking, hypertension, and hyperlipidemias. Then risk factors for CKD like diabetes in the first degree relative, impaired fasting glucose tolerance test, and others high risk race like rat race and sickle cell trait. Now, when we have a patient who is having microscopic hematuria or proteinuria, that is a problem we often see in our donor workup. And donors with benign orthostatic proteinuria can be potential donors, but only after ruling out any intrinsic kidney disease or as a cause of proteinuria. And if need be, you have to do the biopsy. Then transplant centers can accept a donor with hematuria if the urological evaluation like urine culture, cystoscopy, and imaging studies and kidney biopsy, they are all negative. It has been seen in the studies that isolated microscopic hematuria or isolated proteinuria less than 300 milligram have been accepted in the as donor. And if we have only isolated abnormalities, then usually the prognosis is not different, is same. However, if we have a combination of these two medical abnormalities, this leads to 6 times more chances of reaching ESRD. So that is very important. If you have 2 isolated abnormalities, then you should not accept this donor. Now, elderly donor in an older kidney will have impaired compensatory hypertrophy. It will be more immune-related damage, decreased renal blood flow, and intrinsic less GFR, and more susceptible to nephrotoxicity, like CNI immunosuppression, and you can have age-related histological changes. So these are the various factors which lead to more susceptibility of elderly kidney to graft failure. So elderly kidney, the normal GFR changes with age and decreases over time. We all know that almost a 10 ml per decade fall occurs usually after the age of 40. And most of the centers actually recommendation by broad guideline is GFR of more than 80 ml is the accepted value. Although KDIGO gives it 90 ml per minute. But definitely we have to have a age and a race matched GFR, which is more important, because when we do workup of our patients, we hardly find the GFR of more than 90 ml. Very few, less than 10% of patients actually have GFR of more than 90 ml per minute. So GFR corrected to age rather than age itself. That should be the acceptability for donation. There is one series from Johns Hopkins by Matas et al. They showed that it was the 55 years, which is a relatively younger age, to be a significant factor for late graft loss in a study of 2,540 kidney donors. So less than 55 years, there was no much risk, but more than 55 years, definitely the prognosis was affected by age. And inferior outcomes of an older kidney might be a function of anatomical as well as physiological changes that occur during aging. And the short-term morbidity and mortality actually doesn't seem to be different in elderly donors, but it is beyond 5 years where you have the effect of age of the donor. But there are no clear-cut data on the long-term outcomes for this specific group in the literature. Now coming to hypertensive donors, again, almost 20%, 20 to 25% of population is hypertensive. And similarly, we find that now that we are getting more and more donors who are hypertensive. So if we accept a hypertensive donor, it should be more than 50 years age, easily controllable hypertension with maximum of 2 drugs. Ideally 1 drug, but never beyond 2 drugs. If patient is requiring more than 2 drugs, then you should not accept that donor. And rule out any proteinuria, microalbuminuria, or any other end organ damage. Proper informed consent has to be taken. You have to tell about the future prognosis of this donor, and donor has to be on regular follow-up at least once in a year for renal functions, blood pressure, cardiovascular events, and survival. So that is very important. The follow-up of the donor has to be there. And there was one study where they found that proteinuria and blood pressure in hypertensive donors on follow-up was more statistically significant as compared to non-hypertensive donors. This visual abstract shows that donor with hypertension had slightly higher 15 years risk of ESRD as compared to donor without hypertension. And this visual abstract shows that kidney donors with hypertension defined by fresh criteria of 130/80, there was more chances of development of cardiovascular disease, a hazard ratio of 1.36, and diabetes 1.41 when they adapted the new definition of hypertension. Now coming to very, very important topic, that is how to accept diabetic donors. By and large, diabetic donors should be discouraged because there is definite risk of these donors developing diabetic nephropathy and renal failure in future. However, and diabetes, we all know that it is runs in families. It is a hereditary disease, so there is more susceptibility of donors. But British Transplant Society has recommended that donors with impaired GTT can be accepted with proper counseling and especially more than age beyond 50 years. But otherwise, if you have GTT more than 200, fasting blood sugar more than 126, at least 2 occasions, definitely we should not accept these donors. Now, this study shows that the donors having with the family history, BMI of more than 30, women with gestational diabetes and excessive alcohol use, relatives of patients with diabetic nephropathy type 1, there is definitely increased risk of developing diabetic nephropathy in future. So these donors should not be accepted. And there are more chances of developing proteinuria as well as diabetic CKD in donors who are having diabetes. So next is, as far as other societies are concerned, recommendations, they do not accept diabetes as a donor, except British Transplant Society. Now coming to nephrolithiasis, again, this is a very common problem, especially in North India. So we should do complete workup of the patient at the time of transplant. Usually the donor should be stone-free, and a 24-hour urine collection of report of calcium, urate, and oxalate should be normal. And all these donors should be inherited disorders like inflammatory bowel disease, systemic disease. They are at high risk of recurrence and should not be considered for donation. Whereas a patient who is, if any metabolic abnormality is there or urine infection is there, nephrocalcinosis is there, should not be accepted. A stone size up to 1.5 centimeter isolated single stone can be accepted as kidney donor. That is American Society of Transplantation guidelines, that these can be accepted if the stone has only one stone is there and there is no more formation of stones in the last 10 years and metabolic is negative.
Sir, please summarize.
Yes. The flexible ureteroscopy can be done at the time of transplant, and a stent can be placed, and this lithotripsy can be done after 6 weeks after transplant. Now, BMI, obese donor beyond 35 actually should be discouraged, but less than 35 with weight control exercise can be accepted as donor. Now, transmissible infections, hepatitis C and B now are no contraindication and can be accepted. The treatment can be given even after transplantation for HCV positive. HIV patient positive can give to a positive donor. So that type transplants have been done in literature now. We know that there are various ethical problems with this, and marginal donors can themselves actually develop ESRD. So that is the problem. Now, coming to various familial diseases like polycystic kidney disease, Alport kidney disease, the donors have been accepted, but we should do proper workup and counseling, and then at least in polycystic kidney disease, accept donors who are beyond 40 years, not before that. Alport donors, again, the family donors can be accepted if they don't have hematuria, proteinuria, and hearing loss. And structural abnormalities, multiple arteries are routinely being accepted now as donor. This is the surgical expertise. In fact, I've shared some of the slides with from Dr. Anil Kumar. So to conclude, our all efforts should be do no harm to the donor. That is, I think, very important, more than the recipient. And all efforts should be done to safeguard the donor's health. Then once the marginal donors may face some risk after donor like proteinuria, hypertension, diabetes, cardiovascular disease, and progression to ESRD. So as already highlighted, the CNI, the tailored immunosuppression should be done in these marginal kidney donors. Thank you.
Thanks for the wonderful presentation. Before handing the mic to my fellow chairpersons, I just have one question. I mean, how do you think is this immunogenic profile or immunogenicity of this marginal donor kidneys is different from the normal kidneys we transplant?
As far as live donor is concerned, as you heard in the previous talk, we can do all immunological workup like single antigen bead, then PRA, and good proper matching. So there we can actually do all the workup. But otherwise, if you have although the literature shows, our experience, our impression was that the elderly donors will have less immunosuppression, will require less immunosuppression. But once I went through the literature, I found that in fact these elderly donors, when they are used as cadaver donors, then they are having more immunogenicity. So maybe that there the workup is not there, immunological workup is not there, but when we accept them as live-related donors, then definitely we have a HLA advantage. So there the immunogenicity is less. So in a cadaver donor where we have accept elderly donors, they are more immunogenic and there are chances of they will require proper immunosuppression. But in living-related donors, definitely that is our experience that we require less immunosuppression.
Thank you, Doctor. Hello. Hello. Thank you, Dr. Bhalla, for a nice presentation. Just, I want to tell one thing regarding the age. About is there any criteria to accept somebody minor, like somebody with an age less than 18 years? There is some thought in certain centers, like 17 years or 17 and a half years. Would you accept him as a marginal donor?
No, sir. That is a contraindication. A live donor less than 18 years who cannot give consent legally cannot be accepted as donor. And upper age, good part is that all the societies say recommendation, the upper age is, there is no limit. If you do workup and you find the GFR is good, you can accept even up to 80 years also, beyond that also. We have done so far 85 year also donor, live-related donor, mother of a patient. And the treatment remained for 0.9 milligram only on follow-up more than 10 years.
You are doing PRA regularly in these cases?
We do single antigen bead in every patient now.
Yeah.
Dr. Bhalla, can I ask you a question?
Yes, sir.
How often would you absolutely deny a type 2 diabetic donor who's otherwise had no end organ damage? Would you accept him ever?
That is actually real dilemma which we face every day. Now the question is that as you see our Indian families, we have nuclear families. There is a husband, wife, and maybe 1 or 2 children. And in a diabetic patient where whether mother or father is diabetic, the first question is that the children will be out. We don't want to accept the children. That is a general our unwritten rule that we do not accept the children of diabetic patients as donor. Now the wife is a donor, so she is not going to bother about that whether something will happen to me after 10 years or so. So she says, come what may, you do my workup, do my testing, and I want to donate. So this is a real dilemma, but I think we should be firm, and we have cut our fingers many times. We have really faced this situation, although we accepted with the pressure of the family, but we have really got sorry figured that we should not accept a full-blown, clear, undiagnosed diabetic as kidney donor. The British Transplant Society also has recommended only that impaired GTT only, not a full-blown diabetic. And I personally, if you ask my opinion, I will not accept a fully proper diagnosed diabetic as donor.
If there is no question, thank you, Dr. Bhalla, for excellent presentation.
I have one comment.
Yes, Dr. Bhomik, please.
Yeah, no, just I think excellent talk, Dr. Bhalla. We enjoyed it. I just have one comment regarding the nomenclature. I'm a little particular about it. Rather than using the term marginal donors, I find that a little down. you use the term, I think that's much better, complex living donor. These are complex living donors or expanded criteria living donors. So you use the marginal donors, push them a little down. They are not marginal in any sense. They are donors who have some complex problems or they expanded criteria. So I think that is a better term, and you use the term complex, and I think.
Yes, thank you.
Thank you, sir.
Thanks. We need to close this session. We are running short of time. Okay. Thank you all.
Dr. Valla.
Thank you, speaker. Thank you, chairpersons, for an excellent session. Now we move on to the next session. And to chair this session, I would like to invite Dr. Anil Kumar, who is the Additional Deputy Director General, Government of India, Ministry of Health and Family Welfare, Directorate General of Health Services. I would also like to invite Dr. Anurag Gupta, who is a Senior Consultant Nephrologist at Sir Gangaram Hospital, New Delhi. And I would also like to invite Dr. Ratan Jha, Senior Consultant Nephrologist from Hyderabad.
Good morning. I'm Dr. Ratan Jha from Hyderabad. I'm going to introduce Professor Vivek Kute, who is a very senior consultant nephrologist and a legend figure in the field of nephrology and transplant, who is Professor of Nephrology and Transplantation at the Institute of Kidney Disease and Research Center, Ahmedabad. He is also currently the Secretary of ISOT, and he's going to talk about a very common topic of kidney paired donation in India, how to overcome obstacles. Welcome Dr. Vivek Kute to deliver his talk on this interesting topic. Dr. Kute, please.
Dr. Jha, Dr. Anil Kumar, and chairpersons for the kind introduction. I will be talking on kidney pair donation in India, how to overcome obstacles. I am working in Kidney Institute, Ahmedabad, the largest public sector transplant hospital in India. We have 400 beds for taking care of patients with kidney disease, and all patients get free or subsidized treatment with the help of government schemes. This is our new premise of Kidney Institute, which was started during the COVID second wave. Still now we are using this for the COVID-19 patients. So total we have 1,000 beds for organ transplant, mainly kidney and liver transplant. What are the hurdles in kidney donation? The donor should be healthy, ABO blood group should be compatible, and cross-match should be negative. 1/3 of the living donors are rejected, although they are willing due to ABO and HLA incompatibility. This is the editorial published in AJT, which shows that ABO incompatible transplant is twice as expensive and half as good. Mainly in the Indian scenario, we have more infections, tropical infections like tuberculosis, even for ABO compatible transplant. So definitely in our experience, the infection complications are more in ABO incompatible transplant as compared to the swab transplant. Why we need swab transplant over ABO incompatible transplant? Financial incompatibility is much more common cause to prevent access to organ transplant rather than ABO incompatibility and positive cross match. So we must provide an affordable solution for a common man. So that is the reason why swap should be preferred over ABO incompatible transplant. When we compare different options, we should also check availability, cost, complication, logistic issue, and long-term outcome. Swap can be performed in any center which is doing kidney transplant. So it doesn't require any extra infrastructure for desensitization protocol. And of course, the long-term outcome are definitely better for ABO compatible swap transplant as compared to the ABO incompatible transplant. Swap transplant is bureaucratically complex, but medically simple. Desensitization protocol is medically complex, but bureaucratically simple. This is the year-wise number of total living and deceased donor kidney transplant at our single institute. So far, we have done more than 7,000 kidney transplant. So every year we perform around 400 kidney transplant, 300 living donation, and 100 deceased donation. So out of these 300 living donation, 1/3 of the donors are rejected because they are either ABO and HLA incompatible. So they can be maintained in our single center KPD registry, and kidney transplant program is one of the key component of success in our single center registry. This is the year-wise growth of deceased donor kidney transplant at Kidney Institute, Ahmedabad over the last 20 years. So KPD is useful in scenario where deceased donor transplant is yet not initiated and not expanded. To expand deceased donation, we need a lot of teamwork, administrative effort, government priority. But swap can be performed in any center which is doing a living donor kidney transplant. As on today, 85% transplant in India are living donation and 15% are deceased donation. Deceased donation is active in west and south part of India. So in other parts, still the deceased donation is not very active modality. In this scenario, the living donor swap transplant is much better option. This is the upper panel is showing year-wise number of KPD transplant at our single institute, and lower panel shows percentage of living donor kidney transplant due to swap transplant. From 2000 to 2011, we have performed only 56 swap transplant. Because there is no organized registry for the swap, there was no active team to expand this modality. In 2011, we started dedicated team along with the registry. So thereafter, there is a substantial growth in number of swap transplant at our single institute. In 13, 14, and 15, we have performed 56, 56, and 75 swap transplant. So in 2015, living donor kidney transplant, 25%, that is 1/4 of our living donor transplant, they are from paired kidney donation. So even in a single center program with dedicated teamwork, with registry, we can expand living donation by 25%. This is a learning point from our experience. In 20 and 21, due to COVID-19 pandemic and due to fear of unequal outcome in two pairs because of COVID, our number dropped down by 50%. We should have a software allocation rather than doing manual allocation. This is especially useful for hard to match patients and patients who are highly sensitized. So we are using this software provided by Alliance for Paired Donation, and this software is made by Dr. Michael Rees and Professor Alvin Roth, who is a Nobel Prize winner in economics for his concept and theory of kidney exchange in US in 2012. What are the key features of success? How we able to succeed? Each patient is given awareness and counseling about the available renal replacement solution, about the swap, about the ABO and desensitization protocol, including cadaver. So patient can get take appropriate decision as per its waiting time and other parameters. We started dedicated KPD registry. So any patient who is incompatible is registered in our software. Then dedicated team. This team also help to take the legal permission from other states. Then uniform evaluation and care. Prevent chain collapse. So we allow a meeting of the donor and recipient pair only after medical fitness is completed. Then robust immunological evaluation with the help of lymphocyte cross-match, flow cross-match, and donor-specific antibody prevent unequal outcome because of immune injury in early post-transplant period. Then early registration. Due to early registration, patient get adequate time to arrange their documents required for legal permission for the swab transplant from appropriate authority. Then non-anonymous allocation. Only in India, the patient and donor pairs in our center, we allow them to meet each other. We allow them to share medical reports with each other, and they can ask any query. So transparent allocation process, they have trust in our allocation system. Then exchange kidney of similar quality. When patient and patient meet first time to us, the first question is that what is a donor age? So we try to match the donor age. So if donor age is matched, by and large, they patient have more satisfaction in allocation rather than matching too many minute parameters. Then by and large, we do a simultaneous surgery to avoid any donor renage. So in the initial learning curve, we must do a simultaneous surgery to avoid donor renage. This is our allocation rules. ABO compatibility, use short chain, minimize age difference between the two donor, and bonus point for difficult to match patients. And now we have started APD software allocations. So we need all parameters of patient and donor after medical fitness is completed, and software provide us the available option. We provide these options to the patient and donor, and they can get to some final decision. As per Transplant Human Organ Act, only near relatives can donate in swab transplant. Hospital, district, and state authorization committee can give permission for swab transplant when two pairs are from different states. So there is no need to take permission from other states when patient come to our center for the swab transplant. So this make the waiting time for taking legal permission less. This is the reason for joining swab transplant. In 2000, from 2000 to 2011, we did swab only for ABO incompatible reason, shown in the blue color. Then we started management for sensitized patient with the help of swab, shown in red column. And in 2018 onwards, we increased participation of compatible pair. So what benefit we can give to compatible pair? Better donor age or better HLA matching, especially in case of spousal donor. So this is a learning curve. We started first for AB incompatible transplant, and now we are doing swab for the compatible pair as well. 71% of our pair join for ABO incompatibility, 20% for sensitized reason, and 10% of the patient join our registry for compatible pair. So this is the learning curve for the swab transplant. We did first two-way swab in year 2000. Then we slowly increased the chain length. From two-way to three-way, we require almost 13 years. I take in charge of this program in 2011, and we increased the chain length to 4-way, 5-way, 6-way, and 10-way over the last 10 years. So slowly increase the chain length rather than directly jumping to the long chain in the initial learning period. We also use a compatible pair to increase transplant for difficult to match patient despite a single center program. And we use a compatible pair again in slowly increasing chain length. In 2012, we use a two-way compatible pair, and in 2018, we perform 5-way compatible pair. So slowly increase the chain length so that we can manage the learning curve, mainly for taking the legal permission. To increase transplant for difficult to match patients like highly sensitized patient, we use a combination of desensitization protocol with KPD. And again, in this also, we increased the chain length slowly from 2-way in 2012 to 4-way in 2016. From 2018 onwards, we didn't take permission for swab from other states, because in 2014 amendment, it is clearly written that hospital, district and state authorization committee can give permission for swab transplant when two pairs are from two different states. So there is no need to send patients to different states for taking permission. This is as per Transplant Human Organ Act 2014 amendment, page number 42. So 50% of the patients at our institute, out of total around 500 swab transplant, they are from other states. Before 2018, we used to send permission to other states for the swab, but this increases the waiting time too much by 2 to 3 months. But now our state level authorization committee is giving permission for all the pairs, even though they are from different states. This is showing the domicile status of the pairs in our program. Then this shows how we increase chain length slowly from 2000 to 2020. So 75% of our swab transplant, they are two-way even today. So we perform a longer chain only if it increased transplant for difficult to match patients like O patient and non-O donor or highly sensitized patient. Ideally, a three-way swab is a better solution. If we increase the chain length beyond three-way, we need a more surgical team to carry out simultaneous transplant surgery. This is the example of classic two-way exchange. 95% of swab transplant in India are two-way exchange, and logistics are very simple to carry out simultaneous surgery of two patient and two donor. Then combining KPD with desensitization protocol is a John Hopkins way to increase the donor pool, and we are using this modality for management of highly sensitized patient. Then three-way chain should be the optimum chain length in swab transplant. If we increase the chain length, we will face more logistic issue. Then successful three-way transplant with compatible pair. This is our first report, and this modality is more commonly used in San Antonio's USA single center program. So with the help of compatible pair, we can increase the transplant rate even in a single center program. So compatible pair is game changer to increase transplant for O patient with non-O donor despite a single center program. To increase awareness about KPD, we have performed 10 KPD transplant in single day on occasion of World Kidney Day. Thereafter, these 10 patients become education ambassador, and they given knowledge to the other patients on dialysis in their geographical area. We have also performed international swab transplant after permission from state level authorization committee. In single center, there is a limitation to perform simultaneous surgery. So in carefully selected patient and donor, we have used a non-simultaneous surgery. This is our report of 6-way non-simultaneous surgery. We perform non-simultaneous surgery on consecutive day to avoid any donor renage. In 2015, we have reported that living donor kidney transplant rate increased by 25% using a single center KPD program. These are our 4-way KPD with desensitization, 4-way non-simultaneous KPD to increase transplant for difficult to match patient. In our single center, we have performed 67 swab transplant on non-simultaneous way using 17 bridge donor with 0% donor renage between 2015 to 2020. And this is the largest report of cohort in the world literature. Our outcome of KPD is similar to any living donor kidney transplant program. Does donor recipient age difference matter in KPD? Our data shows that when donor recipient age difference between 18 to 65 has no impact on long-term outcome in living donor kidney transplant. Our data also shows that outcome of living related donation is similar to KPD program with the help of thymoglobulin induction, tacro MMF and steroid based triple immunosuppressive regimen. We can also use a transport of kidney, and cold ischemia time up to 16 hours is feasible. So if the centers are okay with transport of kidney, we can do transport, especially in the multi-center program. ISOT has published this guideline on KPD. So this addresses the common issue of selection of pair for KPD versus ABO incompatible transplant. So to increase transplant for difficult to match patients, we can use a multi-center KPD, liver versus kidney exchange, and list exchange. We can use a combination of KPD with ABO incompatible transplant if the baseline ABO titer is high with the original donor, and if baseline ABO titer is low with the swap donor, we can increase the transplant for O group patient, and this modality is used in Australian KPD program and leading to 35% increase in their living donor kidney transplant rate. We can use a combination of living and deceased donor chain, and Gujarat is the first state to approve the list exchange of living and deceased donor chain. To conclude, we can increase the chain length from single center program, city-based program, state program, national program to international program, and our study provide evidence for expansion of single center KPD program when national program do not exist. Hopefully, in the coming year, we'll start the multi-center program to increase transplant for difficult to match patient. Thank you.
Thank you, Dr. Kuti. This is Dr. Anil Kumar from Ministry of Health, Government of India. And I'm happy to see that your center, at your center, you have been able to successfully run this KPD program despite as a single center. And definitely this KPD program has a very highly important to identify the matches for incompatible donor recipients and donor recipient pairs, and also to improve the immunological matching for the compatible pairs. So, and we should look forward to increasing this to become it as a multi-center program as well as a national program. And for this, awareness is very important. Awareness not only for the patients, but to the transplant units, like through this kind of a conference, this kind of a meetings where we can, like other transplant units can take such programs forward. Also positive stories in media about this. And I agree to a great extent that we are as at your center, as you have been doing non-anonymous type of a KPD, running a non-anonymous program, while in other parts of the world it is an anonymous KPD program. And but in India, I think it has to be a non-anonymous type of a which will succeed. And so we should take it forward and make a good learning out of your experience and expand this program to involve more centers and to become it as a national program. So that is very much required. I have seen the guidelines which were released in 2017 by ISOT, and definitely those guidelines are to be further, they can be discussed at NOTO level and further refined to implement at country level, and more centers can get involved. So this increase of 25% which you have shown in your study in the living donation, in the living transplants, and particularly for difficult to match donors, is really encouraging, and everyone should take it forward, other centers also. So so these are my comments on your this thing, and hope everyone, it will be a good learning for everyone to take it forward at the country level.
Dr. Kuti, can I ask you a question, please?
Yes.
You have mentioned multiple times that we should expand this program to across hospitals in a city. I work in New Delhi, and on the 2 or 3 occasions when we had an opportunity to try and do a pair transplant across the hospitals, one hospital here and the other part of the city, we had actually a big problem in getting this cleared by the ethical committee of the respective hospitals. The recipients should be done in the same hospital was the overwhelming argument. We looked at the OTA rules and there is no clarity on this. Now that Dr. Anil also is here, would you like to comment on this, Dr. Kute, Dr. Anil?
Sir, in our state, we take permission from state level authorization committee. So if we want to start a multi-center program in the New Delhi, all payers can take permission from the state level authorization committee. That is very simple. But most importantly, we do not send patient to other state if they are from other states, because as per 2014 amendment, hospital, district or state in which transplantation is proposed to be done, they should give permission. If we send payers to other state for permission, this will take a huge time and patient will end up in more complications on long-term dialysis.
I agree with you entirely, Dr. Kute. The argument is from the hospital authorization committee. Their argument is that both the recipient operations should be done in a single place, not in two places differently.
India multi-center swap is already done. I think at least in Mumbai, in Aurangabad, in Solapur, and in Karnataka. So multi-center swap is already done in India. It is not the first time. It is even published literature. There is a multi-center swap. More important is required harmony between the transplant team of the different hospitals and authorization committee. We can do some discussion so that patient will get benefit. This will decrease the waiting time. They can formulate some common SOP, common query can be addressed in proper way to follow the Organ Act. But it is quite doable.
Right. Okay.
Yeah,
Hi,
actually, actually,
Sorry.
at the permission for transplant has to be given by the authorization committee of the hospital where the transplant is taking place, of the hospital or of the district or of the state where the transplant is taking place. So if it is a multi-center transplant involving different states, and then suppose a transplant is taking place at Gangaram in Delhi, so authorization committee of Gangaram has to approve that transplant. So if the donor is coming, say, from IKDRC, Gujarat, and then still the authorization committee of Gangaram has to approve it. So that is required. So wherever the transplant is going to take place, the authorization committee of that place has to approve it. So though definitely, as I said earlier, that we need guidelines, national guidelines to be issued so as to even facilitate this. The current position in the law is that authorization committee of the place where the transplant is going to take place, that has to approve the transplant. So, if it is happening in Gujarat, so that Gujarat has to, the transplant committee has to approve it, and then it can, it should be planned simultaneously, at least on a single day, so as to avoid any kind of donor refusal later on. So it definitely, I think that planning on a single day is definitely important, even if it is happening at two places in different states. So that is required. Yeah.
Sir, I'm Dr. Anurag Gupta from Gangaram Hospital. We have started this program from 2010. Then suddenly there is a dip in this program because of more of ABO incompatible patients we have started doing. But definitely we need a collaborative work in the state at the level of various hospitals, and the problem will be like that. Suppose the Gangaram is doing the have one patient and the other patient is from another hospital, then there should be some system that both the transplants should be done at one hospital, whether it's the swap is from the patient is from some government hospital or from the private hospitals. So all of us has to sit together and make some system to improve this program.
If we can take comments.
Yeah, definitely.
If we can take comments from Dr.
Dr. Ratan Jha, you want to make comment?
No, it was a very nice kind of presentation of a topic complex. I was not very familiar how the things are done, but I have understood the things. But after matching also, is there any time you have faced in a real world that if the outcomes are not equivalent, the attendants have resented that why did they opt for this? This is for Kute. Because
Sir, we explain the patient that try our best possible for equal outcome, but unequal outcome can happen because of patient-related factor. For example, one patient is diabetic, other is not diabetic. The diabetic patient gets some infection, but we always explain before allocation that complication can happen because of your comorbid condition. They are not related to swab transplant. So proper counseling can in such a blame.
No,
no. जा रहे हैं
घुमा के लाएगा अभी लेने आए डॉक्टर आना को खाली
I think there are no other questions from the audience. Time is over. If there are any, we can close our session after Dr. Anil Kumar's final comment on this.
Yeah, thank you so much, and thanks for giving us the opportunity to chair this important session. And this KPD program definitely has a potential to expand and increase the number of transplants in our country. And we will definitely try at national level to issue comprehensive guidelines on this, so that it becomes a routine affair in most of the transplant centers, and so that we are able to do the best matched transplants for our patients. So thank you, Professor Kute, for this very comprehensive talk on the KPD program in your center. Thank you all. Thank you.
Thank you.
Thank you.
So I would also like to invite Dr. Nitin Agarwal, Senior Consultant Nephrologist from Varanasi, and Dr. Darshan Rangaswamy, Additional Professor, Department of Nephrology at Manipal Hospital, Bangalore.
Hola.
Good morning, everybody. In the next session, we have the infections associated with the transplantation. And our next speaker is Professor Shivohan Raju, who is the professor in the Department of Nephrology, Nizam Institute, Hyderabad, Telangana. He is a very well-known and a reputed speaker, and he is famous for his unconventional way of describing things in a very interesting way. He's a good friend of ours.
Thank you.
So Professor Raju, please.
Yeah, thank you very much for the kind introduction, and good morning to all of you. And it's my great pleasure to be with you all today morning and giving a talk on very interesting topic called post-transplant infection calendar, and do we need to rethink the timeline? And I feel the answer is yes. It's a high time for us to rethink about the timetable which is given for the post-transplant infections. And you know that the major complication, the risk of after kidney transplantation is the rejection, and also most important is the infection also simultaneously. And unfortunately, many a times it is very predictable to know which infection and what infection and when it is going to happen, and how the manifestations and how to treat and how to give a prophylaxis in most of the infections. But many a times we tend to miss an opportunity to treat the patient, and as we miss an opportunity to diagnose early also. But however, having a timetable after kidney transplantation for the infections is very important. It will help us in establishing the differential diagnosis, and also it will be able to, we'll be able to identify the environmental hazards of our excess immunosuppression being given to the patient, and also to design the preventive strategies. And the concept of a timetable was first given by Rubin et al. In 1980. And the first time they detected, and in their experience in the Boston University, they made important observations about the timetable given to post-transplant infections. And this is the timetable. They categorize them into 3. The first initial 1 month, the followed by 1 to 3 months. Opportunistic infection, which is seen in this particular period. And the late post-transplant period, that is 6 months after the transplantation, we have a chronic infections like recrudescence of hepatitis B and hepatitis C, as well as opportunistic infections with the fungal, bacterial, and other rare infections, along with the tuberculosis and other conditions in our country, and which are predominantly seen in the general population, and also some of the environmental exposures to the patients with the infections. Yes. Yes. Then later, after nearly 18 years, in 1998, the similar authors, the Rubin and Fishman, have reviewed the post-transplant infections in the regional transplant recipients, and they found important observations were made, and they made a similar kind of a timetable again, with the addition of newer infections, especially the parasitic infections with the Strongyloides, Toxoplasma, Leishmania, and Trypanosoma. I heard that this part of the country, the Leishmania is very, very common, but they also added more and more infections to this particular table, and some of the complications like late CMV infections with retinitis and colitis have been added, and another important infection-related malignancy called PTLC has been noted by them. And another important review by Fishman et al. In 2007 also noted that the newer infections, especially the BK virus and the nephropathy, and some of the rare opportunistic infections secondary to the excess bacterial antibiotic therapy with the Clostridium difficile. And that time previously it was noted as non-A, non-B, now hepatitis C virus. And some of the viral infections like adenovirus and influenza virus also have been added between 1 to 6 months. And donor-derived infection the first 1 month after transplantation have been noted. See, these are the new observations which were made during this particular 20 years of period. And more and more infections and modalities of detection of these particular infections have been added over a period of time. And newer immunosuppressive therapies with the mTOR inhibitors and other drugs have made some impact on the infections, especially the sirolimus-based therapies have been found to be having more associated with infections, especially the idiosyncratic non-infectious pneumonitis, which almost looks like any other pneumonia of our viral pneumonias. And especially the new T cell depleting agents like and ATG and other drugs also made an impact on the reactivation of several infections like cytomegalovirus, EBV, and other infections. So this particular article, which is a Recitra network from a Spanish group of people, which they compiled their incidents, the clinical characteristic features, and the risk factors of late onset solid organ infections in the solid organ transplants. That made very important observations, saying that the global incidence of late infections after transplantation is almost 0.4 episodes per 1,000 transplantation dates. And it is basically the heart, kidney, and liver transplantation recipients will get less chances of infections. That is the lowest risk compared to the pancreatic and lung transplantation, which showed the highest risk of transplantation infections after transplantation. And if you really segregate them into only kidney and pancreas transplantation, the cytomegalovirus mismatch, the use of sirolimus drug, and at least 2 episodes of bacterial infections in the early post-transplant period, and the renal failure within the early post-transplant period, and the chronic allograft nephropathy are the major risk factors that are found to be associated with the late onset of infections. However, the severity, as far as the severity of the early versus the late is concerned, almost they are similar. And this late is also as simple as early, and it can be as severe as early infections. And this particular study and article noted the important observation that those patients with high risk, they deserve a benefit from a more prolonged and directed prophylactic measures similar to those performed in the early period. So that's why when we given a co-triamcinolone prophylaxis or the cytomegalovirus prophylaxis, they can be prolonged duration that can be given to those patients who are at risk, especially which is given by this the Resitra network. The similar article given by them again in 2006 also showed that opportunistic infections occur in the first 6 months after solid organ transplantation are seen in most of the patients who are at high risk otherwise. And some of the previously well-known infections like cytomegalo and PCP pneumonia the prophylaxis should be extended to till the 12 months after the transplantation. And this is very wonderful, and I advocate everyone to read this particular infections in organ transplantation, which is a comprehensive review in 2017 that shows that there are several important modalities that have come to us to detect an early and make an impact in the management of patients with the infections after transplant. And application of quantitative molecular microbial assays and advanced antimicrobial therapies have advanced our care. The pathogen-specific immunity, the genetic polymorphism in immune response, and the dynamic interactions between the microbiome and the risk of infections are beginning to be explored. These are the things which have been advocated very well in this particular article. And this is the timeline which is given by this particular article about the post-transplant infections. If you have a closer look into this, this is a viral infections like cytomegalovirus, which is seen after 1 month to almost 1 year and beyond. And hepatitis B recrudescence has come, and hepatitis C also has made an impact afterwards, probably with a very wonderfully available antiviral drug therapies. Probably hepatitis C might probably come down in the future, whereas other infections are making their impact. And some of the donor-derived infections are making their impact into this particular calendar. And Aspergillus has got 2 ways, and early post-operative and afterwards beyond the second half of the first year. And the fungal infections, Candida predominates in the first, and afterwards Aspergillus and other infections, they take over. And the bacterial infections are very, very common throughout the period, and especially the surgical related in the immediate post-operative, followed by several bacterial infections, including the Mycobacterium tuberculosis, especially to be noted in our country, is seen in the second half of the first 1 year. And the parasitic infections like strongyloides and the toxoplasma also are very important to be noted. This is a simple thing called the concept of microbiome. Microbiome, which is naturally that exists in our human body, but it can be changed secondary to excessive immunosuppression, the surgical and ischemia and repeated episodes of infections and several antibiotic prophylaxis therapy makes the normal microbiome into abnormal, and that's called microbial dysbiosis. And if it can probably alter the immune system, systemic immune response to the body, and with which there can be chances of graft rejection, inflammation, and infection, and including ischemia, reperfusion injury. But if it is restored and the resilience or repopulation of this particular infection, if treated early and efficiently, probably it can restore the similar microbiome, and the graft probably can get a graft tolerance as well as improved graft function. And it is basically the fine balance between the epidemiological exposure of the patient to various microbes as well as the net state of immunosuppression, which is very, very important. It is basically tightrope work for the nephrologist to balance between the risk of rejection versus the risk of infections. And this is another article showing the timeline of post-transplant infections in the Swiss group. This made the timeline of infection is organ specific. Every organ has got their own timeline of post-transplant infections. And most of the infections are predominantly seen in the first 6 months after transplant. And the traditional opportunistic pathogens were rare, but occurred throughout the first 12 months after the transplantation. And the bacteria, it is a bacteria that predominated the more than 60% of these post-transplant infections category. And this highest throughout the period, and especially some of the new bacteria, Pseudomonas, Enterobacteria, Enterococcus, are actually making their inroads into the post-transplant infections. And antimicrobial resistance is another important aspect that should be looked into, and it is very, very troublesome and worrisome to the nephrologist who is treating the post-transplant infections, because every infection is putting the graft into the risk of rejection also simultaneously. And we just small experience of our own in 2010 to 2019, around 305 patients of our own. And we found bacterial infections are very, very common in our group of people. And almost 38% of the bacterial infections are basically from the urinary tract infections. And this is the timetable, the table for us. It is cytomegalovirus is seen predominantly in most of the patients. And almost nearly 1/3 of the patients had cytomegalovirus infections. Of the viral infections etiology, we have seen varied group of hepatitis B, hepatitis C, dengue, herpes simplex, adenovirus, parvovirus, EP, and BKV virus infections. And among the spectrum, the cytomegalo predominated in the first 6 months after the transplantation. And more than 90 days, 50% of the patients were seen after 90 days. But we give prophylaxis for a very short period, and probably that could be the reason for that. The fungal infections are also equally common among our patients. The 50% of them are the cutaneous infections. Yes, at the end of my talk, do we need a new timetable for post-transplant infections? I feel it is yes, and very, very important. We have several newer standard quantitative assays for the detection, early detection and efficient management of these patients with viral infections. There is a link, linking the risk of infection with the genetic polymorphism in immune response is also noted. So we need to segregate the patients who are at highest risk based on the genetic polymorphism. And we have so many newer anti-immunosuppressive therapies are available. Not just the triple immunosuppression, but several induction agents are going to come up. This is the reason why we need to have a different timetable for our post-transplant patients. And the prophylaxis change patterns are also changing, and sometimes we give 6 months and sometimes we give 1 year post-transplant cotrimoxazole to prevent the infection. Despite being on such prophylaxis, patients are getting infections again and again. Especially we have seen nocardia and recurrent urinary tract infections in those patients of cotrimoxazole. We're not seeing a lot of PCP nowadays. PCP has come down and other infections have taken a slot. And the newer antimicrobials are also available. We need to probably check with other drugs other than the cotrimoxazole and other drugs. And of course, at the same time, resistance of the particular drugs is very important to be noted. We are doing multi-organ transplantations. Just now we heard Dr. Kute talking about the swab transplant within the institute and within the city and between the states also. And during this particular, they can be multi-organs also can be harvested and transplanted. And probably the infection risk probably might change after that. The drug resistant patterns to be noted, and the screening paradigm also can be changed over a period of time. And we need to know that there's a shift in the global pattern of infections, and especially the COVID infection, we have seen that how it changed. And a lot of literature is being produced in the post-transplant COVID infections, or before or after even to the vaccination. There are several things have been happening. It's a time for us to know the timetable to put in the patients in the right track after the transplantation so that we can avoid infection as well as the risk of rejection simultaneously. Thank you very much for the kind attention and the patient hearing. Thank you.
Thank you, sir, for the nice presentation. To start with, yes, the COVID has itself made loud clear that we need a new timeline for the infections. Regarding the vaccination, pre-transplant vaccination, how much are you emphasizing at your center before taking that it's mandatory before you go for, because some 10% had 10% had pneumonia post-transplant. And second thing is, why are we not going for a 6 months prophylaxis at your center for CMV and just doing a 90-day prophylaxis? What are,
so we are into the 200 days of prophylaxis for the cytomegalovirus, and we are doing that. Despite that, the second half of the first 1 year, or even later also, we are able to see a lot of cytomegalovirus infections. And it's a viremia. So that also should be treated. Otherwise, the patients will get into other complications, especially the GI tract involvement is common in our group. And as far as the vaccination is concerned, we give hepatitis B, but a good number of the patients had a recrudescence of hepatitis B infection later after transplantation. And the pneumococcal vaccination, we're not actively and aggressively treating everyone. But unfortunately, the particular vaccine which is available probably doesn't cover most of the serovars which are available in our country and which are seen in our country. And herpes zoster we don't give, but we have seen good number of patients with herpes zoster infection later. But the impact of this particular infection on graft outcome is very, very minuscule. So we don't have to probably give it, but if at all it is given, it is well and good. But we need to give it again and again. The immunomodulatory effect of these particular people, especially the immunosuppressive therapies, is changing the antibody response. So we have seen that normal people also, when they received COVID vaccine, they did not get adequate amount of titers of antibodies after vaccination. So similarly, our patients who are immune suppressed, the adequate response may not be seen in them despite taking a vaccine.
Sorry, thank you for a nice description. So I have one or two questions. Basically, I want to know your experience regarding these donor-derived infections. What is the timeline for these infections? Do they develop very early or slightly late?
It is basically, we have very few cases, especially live-related also we happen to hit. Yes, urinary tract infections are the predominant. Otherwise, we did not see any major infection that is donor-derived. And we had few patients who had a tuberculosis of the donor, but it is just coincidental because they belong to the same family. The exposure of tuberculosis is there. Even to the recipient, they develop tuberculosis when the donor had a past history of tuberculosis. But it's not through the graft totally. But urinary tract infections, we have seen the donors giving it to the recipient. But it is seen predominantly in the first 1 month after the transplantation. We have not seen any major viruses getting into that. We have transplanted hepatitis B donor to a recipient after taking the consent and after treating adequately, but that still the recipient got hepatitis B infection later. So unfortunately, but it's a very small experience. But the donor-derived infections are very, very common in cadaver transplantation, and we have seen in live-related also.
So another we have seen there's those patients who are getting this plasma or the blood products very early to plasmapheresis on. These patients are getting CMV infections very early and with a very high viral count. So do you have experience with such kinds?
Yes, actually, that is one of the reasons which we think probably cytomegalovirus infection is more common in our group of people. And the literature also says that even if you give an irradiated blood, the risk of infection transmitted through this particular blood products is very, very common. And that's better to be avoided. And morning I was reading a literature, and post-transplant blood transfusions are equally bad, and they can really pose a threat to the graft in the form of infections. But we cannot really avoid. In fact, I thought of seeing this particular entity in our group of people because frequently we give blood transfusion after transplant. And that probably we need to see whether the risk of rejection as well as the other infections, especially the cytomegalovirus infection, which you quoted, is high in them or not. We need to see that.
This last small one is basically all of us have seen this now increased number of mucor cases in the post-transplant in the recent times. So in your experience, which part of the timeline post-transplant you get most of the mucor cases?
So mucor, I had a graft within 3 months after cadaver transplantation, and especially the sinus, the rhinocerebral mucor, we have seen 1 year after transplantation in our. But COVID-related post-transplant mucor, we have not seen actually, luckily. And during the particular time, we had a pneumonia with the manifestation of mucor we have seen, who never had infection and never vaccinated also. So it is the thing. So probably our experience of post-transplant mucor is unrelated to the COVID infection.
Is, any comment from Dr. Srijit?
Just two things. Yeah, like sir mentioned, I think the screening part makes a great difference with regard to the timeline of infections. What we have found is initially to start with, we are not proactively screening people for BK virus. So we started screening in I think 2017, and we found that the incidence of the number of patients where we actually make a diagnosis of viruria as well as viremia in the absence of graft dysfunction was many-fold. So I think it makes sense to screen, and availability of these screening tests are impact timeline of infections, and this should probably impact the outcomes as well. The other doubt I had, the question I had was about tuberculosis. We practically don't give prophylaxis to any of our patients unless they had treated TB and tuberculosis in our transplant recipients as well. I'm keen to know timeline of tuberculosis infection you are seeing in your.
Second part of the question I didn't hear. First one is related to.
The second part was on the timeline of tuberculosis you are seeing at your center without using
So for the past 1.5 years, we started collecting our tuberculosis, and we found that the tuberculosis doesn't go with the timeline at all, and it doesn't spare anyone, and it doesn't really go with the time, and it's beyond the time limit. So we have seen post-transplant tuberculosis in every phase, and it's very, very common. In fact, there's a resurgence of tuberculosis in our part of the country very frequently now. This first one related to BK virus, though it is advocated that 1, 3, 6, 9, 12 months after transplant, we're supposed to screen regularly for BK virus, but the cost effectiveness also we should see. But the 3% of our viral infections is secondary to the BK virus, and we see frequently the BK virus infections. So, but how we can really prevent or avoid infection is very difficult to understand. We can screen, but it's not an issue that we can really prevent or avoid.
Last comment from Dr. Nitin Agarwal. Any questions or comments? We have one question.
What is the prevalence of tuberculosis in transplant population at your center? Because we have one study at IGAMS. The prevalence was to the tune of 10 to 12%.
Yes, similarly, around 10% is our post-transplant infections. But I feel that in the next few years, it is going to really escalate to almost 15 to 20%. Because the tuberculosis in general, in the general population is also increasing and escalating. And there is a lot more and more cases have been reported from the general population, risk of tuberculosis. So our post-transplant setup also probably it might increase over a period of next 5 to 7 years. Yeah, thank you. Thank you very much.
Thank you, sir, for an informative session. Now, for the next session, I request Dr. Shashi Kumar, sir, Senior Consultant Nephrologist, Paras HMRI Hospital, Patna. Dr. Rishi Kishore, sir, Assistant Professor, Nephrology, NMCH, Senior Consultant Nephrologist, and Dr. Nitin Bajpai, sir, Associate Professor, Nephrology, AIMS, Jodhpur, to chair the session. Sir, request you to take the seat on the dais. May I request the chair to conduct the session? Thank you.
Good morning. Good morning to all. Good morning to all. On behalf of organizing committee and my co-chair, Dr. V.M. Dayal, Dr. Nitin Bajpai, and Dr. Rishi, I welcome you all for this important session. And the speaker is none other than Dr. D.S. Bhadoria, who is additional professor at Department of Nephrology, SGPGI, Lucknow. And it's my proud privilege to introduce him because I was working with under him. So I know him very well and is a very good nephrologist. So without wasting any time, I invite Dr. D.S. Bhadoria to start his talk.
Thank you, Dr. Shashi, for humble introduction. Good morning to all of you. First of all, I want to thankful of organizing committee and scientific committee for inviting me to talk upon one of my favorite.
A very important issue that if you diagnose one etiology and treating that person with that infection for that infection, and if the patient doesn't show response adequately, then you must look for the another etiology, because in 1/3 patient you will find another etiology. And in this study, out of 57 organisms, 45% were bacterial, 36% tubercular and fungal, and out of these 44 patients, 22% was mortality. Now again, in this study, two messages are very clear that number one, 34% are mixed infection, and number two, bowel and the lung biopsy gives maximum yield of the specific etiology of the infective microorganism. Now, in this same paper, we compared the Western study and Indian study. Out of these 10 studies, I'm not going into detail, but what I am saying that the bacterial, nocardia, tuberculosis, PCP, fungal, and CMV, these actually constitute 90 to 95% of pulmonary infection. So if you try to go aggressively to find out of these, we will be able to isolate microorganisms in majority of patients. The only point of difference is a incidence of tuberculosis, which is far more in Indian study as compared to Western study, which is not surprising. Now, this is the second study which was published again in 2019. Here we were trying to find out the infection as a mortality and affecting death-censored graft survival after renal transplant. So this was the study done in first-year transplant between 2012 and 15. 387 patients, pulmonary infection were 11%. So it is those infections which require hospitalization, out of which pulmonary was 11%, viral was 33% as the etiology, bacterial at 23%, and 3 to 5% were fungal, tuberculosis, and parasitic, and 86% patient death was due to infection. And in this study, what we found that no death and acute rejection were the important independent risk factor for pulmonary infection. Now, in this slide, just I want to highlight that in terms of the timing, when we were talking of the timeline, now this is comparing various infection, including pulmonary infection in first month, 2 to 3 months, 4 to 6, 7 to 12. And if you see, there is no specific timeline of particular etiology which can fit once we are following these patients currently. So what Dr. Raju was trying to say that the timeline really does give idea, but it doesn't help significantly. This is again showing timeline and the etiology. And you see, I just want to state that the CMV is interpreted as 90% CMV are seen before 6 months. But in this study, majority of CMV we saw after 6 months. And again, pulmonary infection out of all infection-related death was the commonest. Now, this is the third study which we published, and this is published in Transplant International last year. A prospective study of patients who were admitted with pulmonary infection. So these were 88 patients with 102 pulmonary infection, and you see these were divided first year post-transplant, 1 to 5 years and more than 5 years, and it is 1/3, 1/3, 1/3. Which means that the pulmonary infection, there is no timeline. You can see anywhere from first year to more than 5-year time period. We could have a microbiological diagnosis in 70% cases. In spite of being howsoever aggressive you are, you will still find a sizable number of pulmonary infection where you could not pinpoint the diagnosis. And PCP, CMV, nocardia were more commonly seen in more than 12% patients. Another important thing which message out of this study is that 17% patient plain X-ray chest was normal. So in a pulmonary infection, if you only depend on plain X-ray chest, we will be probably missing. So if the symptoms are there, chest is now X-ray chest is normal, go for the CT. And this slide again show in a same study that missed infection is quite common. Now coming to every chest lesion with a acute chest symptom is not infective. So we should also keep in mind that the acute respiratory symptom with chest lesion can be non-infective also, and the common causes are volume overload, alveolar hemorrhage, malignancy, post-transplant lymphoproliferation disorder, and the drug-induced lesion. For shortage of time, I will not go into detail. Pulmonary edema, very similar to chest infection, alveolar hemorrhage, Tuberculosis with malignancy, a patient with the initial diagnosis of tuberculosis is not responding with ATT. When the biopsy of the lung nodule was done, bronchogenic adenocarcinoma was found, and patient was treated with additional surgery. Another patient, Kaposi sarcoma of the lung, again, initially bacterial infection was being treated, didn't respond, biopsy was done, and the Kaposi sarcoma was detected. Pulmonary post-transplant lymphoproliferatory disorder, we have seen a sizable number of such patients of chest PTLD in our own hospital. This is the last non-infective cause, drug-related pulmonary lesion, and there are two drugs, mycophenolate and mTOR inhibitor. These are known to produce interstitial pattern. And this is a study which compared CT finding in patients who were on mycophenolate or mTOR versus who were not on MMF and mTOR and were on CNI and azathioprine. And interstitial chest lesion were seen in 12% of patients who were on mTOR and MMF as compared to who were not on this. So we must keep mTOR and MMF as a cause for interstitial pattern on the chest lesion, and these continue to persist if you do repeat CT without any clinical deterioration. Now, this is what we do in AIMS. Our approach is that clinical suspicion of pulmonary infection, chest X-ray and CT, in most of the time we do simultaneously, and we start empirical antimicrobial. If there is no response or deterioration in 24 to 48 hours, we go for see what is the type of the lesion, whether focal, central lesion or peripheral. If it is central lesion, we go for a ball and esophageal biopsy of the central lesion. If it is peripheral lesion, we go CT guided lung biopsy percutaneously from the chest. Along with this, we go for the CMV PCR, galactomannan, and if there is a pleural effusion, then the pleural fluid analysis. And with this approach, we are able to succeed making microbiological diagnosis in approximately 80 to 90%, but still we are not able to make in 10 to 15%, and we could save large many number of patients by making a specific diagnosis. So in the last slide, my take-home message is that pulmonary infection is common infection. It is the commonest cause of mortality in renal transplant patients. Timeline is changing and not a strong indicator to suggest the start of a specific empirical therapy. 30 to 40% infection are mixed infections. So if your patient doesn't respond to one therapy in a short period of time, you must look for another microbe. Isolation of the organism is key to success. And it really required teamwork of pulmonology, microbiological, nephrology, and surgeon if required. So it is a teamwork. Together we will be able to manage the most common cause of mortality in renal transplant setting. Thank you very much for your kind attention.
Thank you, sir, for the wonderful talk. I now request my co-chairpersons, Dr. Vinay, Dr. Rai, and Dr. Banka to intervene and ask some questions and clarifications.
Great presentation as usual by Dr. Agarwal. And I think he has rightly emphasized we should look for the mixed infection. Most of the time the infections are mixed. Sir, I would like to have your comments on this post-transplant COVID infection, sir, your experience with the COVID.
You see, one of the very peculiarity in All India Institute happened that every patient of COVID was shifted to trauma center. So somehow we were not the very close group which was following the patient, but we have seen COVID infection in transplant setting. And I remember two things especially. That COVID infection, pulmonary infection was important cause of mortality in transplant patient having COVID. And the second was that in few patients, COVID infection did induce acute rejection, which was mostly non-responsive. and we lost graft following acute rejection in a patient with COVID infection.
Any questions from the audience? Dr. Rai, would you like to ask something? I think
He
there
has
are
to
some
unmute.
audio issues. Dr. Rai, unmute कीजिए अपने आप को. जय प्रकाश सर.
Dr. Agarwal has given the
to approach this pulmonary infection post-transplant, the timeline, the approach right from the basic X-ray to the advanced study, to the serology, role of HRCT, the role of BAL, the role of lung biopsy, and then the line of treatment. I think the message is clear to the audience. Thank you, Dr. Agarwal, for the great presentation.
Thank you very much.
Thank you all. Thank you.
So, any comment from any of the chairpersons? Thank you, sir. Thank you, sir.
Thank you very much.
Thank you, sir, for an informative session. And for the next session, I would request Dr. Jayaprakash sir, former head of the nephrology, IMS BHU, Dr. Ghanshyam Singh sir, senior consultant nephrologist, Ranchi, Dr. Vijay Shankar sir, consultant nephrologist, Ruban Patna, and assistant professor nephrology, NMCH Patna, Dr. Anil Jaiswal sir, senior consultant nephrologist, Asian Hospital, Patna, to chair the session. Sir, request you to take the seat on the dais, and may I request the chair to conduct the session. Thank you, sir.
Can you hear me?
Yes, sir.
Okay.
You are audible, sir.
Okay, this is the very important, another important infection in a transplant recipient next to pulmonary infection. And timing of infection between the date of transplant and the onset of infection will become very important. Early UTI, late UTI. Moreover, UTI is the one of the commonest bacterial infection in renal transplant recipients. Dr. Girish will cover all these topics. Most importantly, when to treat, most important is when to treat empirically and when to go for investigation. Secondly, asymptomatic bacterial transplant recipient, whether treat, not to treat, these all aspects will be covered by Dr. Girish. So I invite Dr. Girish to go ahead with his talk. Over to Dr. Girish, please.
A very good morning to you all. Thank you, sir, for the kind introduction of the topic and also of mine. At the outset, I would like to thank the organizers of ISOT for having given me this opportunity. So, and as Professor Jayaprakash sir told, so one of the most important things that we have to deal with in the transplant setting is that of urinary tract infection. So in this session where we have been talking of infections, it's already been clearly emphasized. What is the importance of infections in the post-transplant patient? So, and how it contributes to mortality. So starting from yesterday, like it was Dr. Narayan Prasad who told that patients are dying of infections more than graft failure. And from today morning, Dr. Raju and now Dr. Sanjay Agarwal sir also projected very clearly the statistics that it is the infection which is the most contributory cause for the patient's death and also to the morbidity. And among infections, the most important thing what we see, especially in a renal transplant patient, is that of urinary tract infections. And this is what I'm going to deal with now. So among the common things that we have to deal with in a post-transplant patient, two most important things, which we start from the counseling time itself of the recipient, is that of rejection and then of infections. And in the infections, as I already told, UTI is commonest, especially in a renal transplant recipient. And two things we have to keep here in mind. It is that the susceptibility for any of the infections, especially a urinary tract infection, is very high in a renal transplant recipient. And apart from that, the signs and symptoms might not be very classical. The presentation might be very subtle and signs and symptoms might be very subdued. This is what we need to keep in mind when we are dealing a better outcome for the patients. So otherwise, it will be more of a revision rather than anything new. These urinary tract infections can cause bacteremia. It can lead to acute T-cell mediated rejection, and it can also lead on to graft dysfunction. But I will be coming to this point later on. And of course, all these things put together will lead to increased hospitalization and death. So this is what is important here. So, and then, so what is a talk without any of the numbers? So especially some numbers has to be put in any of the talks to show you all that I'm talking of something very important. I have put these numbers. So incidence of bacterial UTI, this is one of the Spanish study which was projected earlier. It is in the 100 post-transplantation days was 4.5 for kidney, 2.2 for kidney pancreas, 0.6 for liver, 0.7 for heart, and 0.2 for lung transplant recipients. So this clearly shows that the incidence is very high among patients with kidney transplant. But again, I am unable to explain why it was less for kidney pancreas patients. So in fact, we would expect more because there are two organs that are being transplanted. So yes, numbers are numbers, but we all know that it is one of the common problems we deal with day in and day out. And prevalence varies widely from 7 to 80%. So why this wide variation? It is because of the various definitions that are used to define the urinary tract infection. And that is why this wide variation is there. But if at all I have to quote one of the Indian studies that was done from the Army Hospital, Delhi, the incidence was around 32%. So maybe like 1/3 of the transplant patients in the first 6 months can experience a urinary tract infection. So, and the highest incidence is within the first 3 to 6 months, but it can even be up to first year. But this is the 6 months. Within this first 6 months is what matters most as far as the graft function is concerned. And more so, 30% of all hospitalizations for sepsis. So we have already seen like diarrhea, we already dealt with pulmonary infections. But one thing I want to specify here is that almost 1/3 of the admissions for sepsis is because of the urinary infections. And this is what is very important. So coming to definition, we have to define what is the urinary tract infection. And that is the reason because of this definition is lacking, that we have wide variation in the incidence or the prevalence of the urinary tract infections. So this is from one of the review article that I have taken. So here it has been defined as asymptomatic bacteria more than 10 to the power 5 colony forming units. Yes, of course, without any symptoms, the explanation is there itself. And when you come to uncomplicated UTI, or it can be even be called as cystitis. So again, it is 10 to the power 5 colony forming units per ml, but with local symptoms like dysuria, frequency or urgency, and no systemic symptoms. Then complicated UTI or pyelonephritis, again, the bacterial count is the same, more than 10 to the power 5 colony forming units, but it might be associated with allograft pain, fever, chills, or a biopsic finding which is consistent with pyelonephritis. Here, one point, a practical point I would like to pass on over here is this allograft pain. We all know that the transplanted kidney is denervated. So where is this pain coming from? So this pain is usually because of the spillover infection that happens in the perinephric region. So it can be subtle also. So we should not be too much emphasizing on the allograft pain, but yes, it can be there because of the spillover infection affecting the inflammation rather than the infection, the inflammation affecting the perinephric region. And recurrent UTI is defined as that. So when there are more than 3 episodes of UTI within 12 months, and some places it is given as more than or equal to 2 within a 6 months period. So this was one set of definition, but to confuse you more, I have put one more slide here. So here the difference is like asymptomatic bacteria, it's the same. So when it comes to the acute simple cystitis, so it has been defined as there should be more than 10 WBCs per milliliter. So we all take it as like more than 4 to 5, but even up to 10 is acceptable in a renal transplant recipient. So the number of WBCs should be more than 10. If it is less than 10, maybe we'll have to take the diagnosis with a pinch of salt. That is what is being emphasized. And here, if at all the symptoms are there, a colony count of more than 10 to the power 3 also might be significant. This is what I would like to emphasize. So need not wait for the colony count to be more than 10 to the power 5. Symptoms plus a lower count, we might consider it as UTI. And when it comes to pyelonephritis, here again the same thing. So all the symptoms are there, but apart from that, the colony count might be 10 to the power 4. But many of the labs might not report a colony count of less than 10 to the power of 4. So we will have to be careful in diagnosing whether urinary tract infection is there or not. So then to confuse further, there are still more criteria. So this is from the European Association of Urology. So almost same thing, but apart from that severe pyelonephritis, next it goes to the SIRS, that is the systemic inflammatory response syndrome. So everyone knows what are the criteria. When there is a sepsis, that is an organ dysfunction, it is sepsis. Along with shock, it is a shock. So these are the severity degrees, what it can progress to in a patient with UTI. So once urinary tract infection is there, so we need to analyze who are susceptible. Once we know that these patients are more susceptible, then maybe we can pick up the infection at an earlier point of time, and maybe we can institute treatment earlier. So to know these risk factors is very important. And these risk factors can be differentiated into either recipient related, donor related, or the transplant related itself. Coming to the recipient related, yes, female gender is important even in a transplant setting. So advanced age and recurrent UTI in the pre-transplant period. So pre-transplant abnormalities of the urinary tract. So that is especially a vesico-ureteric reflux or a ADPKD with recurrent cyst infections. So these are very predisposing. Then diabetes mellitus, either a whatever was there before, even before the transplant, or even a new onset diabetes after transplantation, polycystic kidney disease, previous pregnancies. These all are the recipient factors which predispose to infection. Coming to donors, it can be a cadaveric donor or so the kidneys from the expanded criteria donors. So this might be because of the more intense immunosuppression, but whatever it is, these kind of scenarios from the donor are associated with an increased incidence of UTI. Then transplant related, these are like with common sense, we can definitely know all these things. So whether there is over immunosuppression, when the intense immunosuppression is there, or a prolonged bladder catheterization, placement of a ureteral stent for a long time. So ureteral anastomosis, if there is a problem, there is reanastomosis, it's not clean. So, and contamination of the graft perfusion solution, cytomegalovirus infections, so episodes of delayed graft function, episodes of acute rejection, reduced graft function. So these are all the transplant related factors which can predispose to the urinary tract infections. So just to emphasize again, the most important are the sex, prolonged bladder catheterization, intense immunosuppression, diseased donor graft, and a vesico-ureteral reflux. Then there are some criteria for candiduria, that is prior antibiotic usage, neurogenic bladder, indwelling urethral catheters, and prolonged stay in the intensive care unit. These can predispose to candiduria, but whether it is important or not, that's a separate question altogether. Pathophysiology, again, everyone knows that the commonest cause is an ascending infection. So even in the transplant, it is the same. But here, one thing I would like to emphasize is the absence of a sphincter between the transplanted ureter and the native bladder. this predisposes to the infection. So along with that, almost everyone uses a stent. So double J stent is being used, so which again predisposes to the infection, and longer it is in place, more is the chance of infection. And native kidneys, which can act as reservoirs. That is why in our practice, it is usually common that whether there is a stone or whether there is recurrent urinary infection in ADPKD with recurrent infections, usually we go for native kidney nephrectomy. But in cases where it is not done, it is again the native kidneys which we might have to look at as a reservoir of infection. And occasionally it can be from the surgical site, which can be transmitted to the urinary tract through blood or directly. So these are some peculiar points in the pathophysiology. But apart from that, the organism factors, fimbriae, these are all common in the general population or even in the transplant population. Microbiology, thankfully, so the organisms are usually the same as in the community acquired urinary tract infections in the general population. That is, mostly it is the gram-negative organisms, and again in that, again E. coli. But the others are Pseudomonas, Enterobacter, Klebsiella, and rarely other things may be there. I will have one more slide next. One of the things I would like to emphasize here is all the patients post-transplant are already on prophylactic medicines. So whenever there is an infection, so we will have to suspect a high degree of resistance to the commonly used drugs, that is a trimethoprim sulfamethoxazole or the ciprofloxacin. So we might now have to choose some other drug for the treatment rather than these two drugs. This is what I would like to emphasize. So apart from these are in the decreasing order of frequency, these are the organisms that can be plausible. So, and here I see the fungi is again one more thing we might have to consider. And Staphylococcus epidermidis, Lactobacillus, Gardnerella, even if they are isolated, they are unlikely to be the pathogens. So we might have to confirm whether it is a causative or not. Then there are other atypical like Mycobacterium tuberculosis, Salmonella, cytomegalovirus, adenovirus, Mycoplasma, Ureaplasma urealyticum. These are very uncommon, but which we might have to consider. BK virus itself is a big topic, but and again, it doesn't come under the common urinary tract infection. But yes, when we are talking here, we have to think it is mainly the bacterial infections what we are trying to talk over here today. Screening, this is not commonly accepted, so whether it is required, but if at all it is required, it might pick up a urinary tract infection earlier, but if at all it is picked up, it is picking up more of asymptomatic bacteria, which might be or might not be important. So diagnosis, again, the same things as in the general population, that is the leukocyte esterates, nitrates, blood and protein in urine microscopy that shows pyuria. As I emphasized, 10 WBCs, and it has to be established by a positive urine culture. We might have to consider blood culture along with that, and because the resistance pattern is common, initially itself we should ask for a extended sensitivity testing and a negative culture test. So we might have to consider for atypical organisms. So on biopsy, this is one more practical point I would like to emphasize here. Pyelonephritis and acute rejection may be a little difficult to differentiate. So some neutrophils and tubular luminal neutrophils, it can be more of rejection, but if there are abundant neutrophilic infiltrates with tubular microabscesses, it goes more in favor of a infection. And if there are unusual pathologic findings like granuloma or interstitial nephritis, we might have to consider atypical infections. So specimen collection is the same like midstream urine or catheterization. But one thing is, if the patient is already on a catheter for more than 2 weeks, it is preferable to remove the catheter and then collect the sample, or put a new catheter and then collect the sample. There is very doubtful evidence for the use of suprapubic aspiration of urine for the culture. So whenever there is a recurrent urinary tract infection, we might have to evaluate the urinary tract. So, and if at all there are any abnormalities found, that might have to be corrected. So evaluation includes from ultrasound to the CT scan to cystourethography to urodynamic studies and flexible cystoscopy. Treatment. So this is something which I won't dwell into much because of the lack of time here. So, but whenever we are encountering asymptomatic bacteria, we have to confirm the same by 2 cultures. So just one culture, we shouldn't jump to treatment. So we have to confirm it by 2 cultures. And treatment should be given only within the immediate post-transplant period, that is within the first 3 months. And again here, a single shot of antibiotic is not good enough. We should have at least a 5 days course. There is no role of empiric treatment, and we should not be treating, if it is asymptomatic, a multi-drug resistant bacteria. So treatment of simple cystitis, again, whatever drugs we are using, that is same. But if at all there is a catheter that has to be replaced or removed. And one thing I would like to emphasize here is there is no role for short course of therapy, minimum 7 days, and clinical response has to be documented. Pyelonephritis, the same drugs we are using, but here the duration has to be 14 to 21 days. And in a very severe infection like sepsis or septic shock, we might have to consider discontinuation of immunosuppression also. So there are few challenges. There is a methicillin-resistant Staphylococcus aureus, vancomycin-resistant Enterococcus, and extended spectrum beta-lactamase organisms. So these are the challenges which have to dealt with very specifically. And non-antimicrobial measures, we have to be not miss these things like hydration, frequent or timed voiding, so local hygiene, glycemic control. So limited evidence for the other things like lactobacillus, methanamine, L-methionine, and cranberry, but nevertheless, no harm in using it unless it is a nephrotoxic thing. So prevention is prevent infection in the donors. So antibiotic prophylaxis, I will come to that again, and early removal of urethral stent. And in the antibiotic prophylaxis, I would like to emphasize there is a definite role for antibiotic prophylaxis to prevent the UTI. Commonly used drug is cotrimoxazole, but there is a pattern of increasing resistance for the same, and the duration of prophylaxis is about 6 months to 1 year, depending from center to center. So just to summarize, the approach is we should have a very high index of suspicion because of the subtle manifestations it can have. And the prophylaxis should be universal, and preventive measures to be taken along with the antimicrobial. Early detection by the right test, evaluation in the form of in the place of recurrent UTI, and treatment. It has to be the right drug, right dose with the right duration, and management of complications. With these things, we can do a good justice to the patient and detect the UTI early and prevent much of the problems that can come with it. Thank you all for your patient hearing.
Thank you, Dr. Girish.
Thank you, Dr. Girish, for the excellent talk. Any comments on the fungal UTI in the post-transplant setting?
On the fungal, sir? Fungal infections are not so common. Like Dr. Sanjay Agarwal said that in the pulmonary infections, like fungal infections are very common. But when it comes to urinary tract infections, it is not so common. And Candida, we all know that it can be a commensal, which is present. So we have to actually document. But if at all we have to say that it is pathogenic, if at all it is found out that it is pathogenic, definitely we have to treat that most usually by fluconazole, or we can go for amphotericin also. Another thing I would like to emphasize here is we are all very fond of liposomal amphotericin, but it has been found that the concentration of liposomal amphotericin is very poor in urine. So that is why it might not be a good choice. So, and echinocandins might be used. So this is what I would like to say.
Thank you. Thank you.
Please, Dr. Girish, can you hear me? Can you hear me? Am I audible?
Yes, sir. You are audible, sir.
Okay. I think for a nice presentation, one practical question which everybody faces, even you, about asymptomatic bacteria. Do you treat empirically or you wait for a culture reports to confirm the diagnosis?
Yes, sir. I made that clear during my presentation. There is no role for empiric treatment in asymptomatic bacteriuria. We have to wait for the culture report. And in the culture report, if at all it is a multi-drug resistant bacteria which comes out, again, we are not going to treat because it might not be effective in preventing any of the outcomes. So, and again, we have to confirm the culture by a second culture. And even in the second culture, it has to be the same organism that should be isolated. So 2 cultures, same organism, not multi-drug resistant. Then we go ahead and treat with the susceptible antibiotic, and that too, one with the least margin of error. So that is what we have to select. And again, it has to be at least 5 to 7 days if at all we treat.
One thing I want to emphasize here, if you are doing a transplant in the elderly people, 50 year above, I think this should be properly screened for any risk factor for UTI, like a prostate enlargement. TURP should be done prior to transplantation. They are the risk factors which may cause infection in the transplant recipient. So in the certain age group, you have to be very, very careful. You must try to find the risk factor UTI pre-transplant.
Yes, sir. Yes, sir. Pre-transplant evaluation is very important. So we have to rule out any of these treatable things before transplant itself rather than struggling post-transplant. Yes, sir. Very right point. Thank you.
Not in all, but in a certain group, not in all. So I invite the other chairpersons for any comment, and then finally I wind up this lecture. Any comment from the audience if are there? Other
may I push in one question?
Okay.
So I wanted to ask the speaker, how often have you actually had to, after a transplant, because of persisting UTI, do a donor nephrectomy? Do the native kidney nephrectomy, I mean. You know what I'm trying to say is there's a recipient who has got persistent UTI. How often in your evaluation have you found the native kidneys at fault and then you had to go ahead and do a native kidney nephrectomy?
Sir, like in my experience of like 12 years, so it was only one patient. He had a congenital obstruction at the vesico-uretral junction. So sorry, it was at the kidney level. So, and because of that, initially we neglected it because it was not coming the way of the transplant. But then he had recurrent infections post-transplant, nephrectomy, one patient, but he did not have any relapses after that. That was one good thing. That was only one patient, sir, in 12 years.
That's right. That's what I was trying to emphasize. It's rare. And the second problem is to actually identify which kidney is at fault. So these are the problems when you're trying to sort of decide on a native kidney nephrectomy.
Yes, sir. Absolutely, sir.
Any questions and comment from audience, please? Thank you, Dr. Girish. With this, we conclude this session. Thank you.
Thank you very much, sir.
Thank you, everybody, the speaker and the other chairpersons. A nice topic, a frequent problem seen by all the physicians. Thank you all.
Thank you, sir, for an excellent session. Now, may I request Dr. Cecil Gang, sir, Director, Department of Nephrology, MPUH Nadiad, Dr. A.K. Vaidya, sir, Senior Consultant Nephrologist, Medica Hospital, Ranchi, Dr. Suraj Gupta, sir, Senior Consultant Nephrologist, Medanta, Patna, and Dr. Jamshed Anwar, sir, Consultant Nephrologist, Ruban Hospital, Patna, to chair the session. May I request the chair to conduct the session, sir, please? Yes, sir. Yeah.
Good morning, everybody. Let me introduce the speaker. So next session is on post-transplant malignancies in India. And the speaker is none other than Dr. Umapati Hegde. He is Vice Chairman, Department of Nephrology at Muljibai Patel Urological Hospital, Nadia. And he has fellowship of ISN USA, Chairman of Scientific Committee, ISM West Zone, and he has several publications, national as well as international. So over to Dr. Uma, please.
Thank you very much. Thank you, Dr. Ashok, and thank you. Thanks for Dr. Vivek and the scientific committee for giving this opportunity. I'm audible?
Yeah, go ahead, please.
Thank you. Post-transplant malignancies in India. Again, it's one of the most problematic area, even though we are improving in the rejections in the early transplant. Because of the intensification of immunosuppression, we are landing up with more of infections. Even cardiovascular risk is also, but again, the infections we heard today, it's a most important thing. Next comes to cancer and even a cardiovascular risk. So I'm going to touch on the introduction, etiopathogenesis role, and there are some of the studies which have shown what is the incidence of different malignancies in India and the screening program. I'll not be able to do justice because of the time. So I'm please pardon me for that. So the cardiovascular risk, infection, and cancer are the three major deaths happen, which is after the transplantation, and they lead to death with a functioning graft. So even though the graft outcome initially has improved, we are losing patients because of death with functioning graft. One of the reasons is cardiovascular and the cancer. The risk factor is, again, it's dynamic, it is an altered immunity, and in the host response and the different clinical presentations. So it is very difficult to say which of the patients which may get it. Again, the immunosuppression which is given also matters a lot, and the patients per se. The studies have shown, as compared to the general population, there is 2 to 4-fold increase in the elevated risk of cancer in those who received an organ transplant. And the age is also an important factor. And as the age, solid organ cancers after the transplant, the duration, the number of cancers that goes on increasing. We also had seen those patients who had more than 20 years, they had more cancers as compared to early. After 4 to 5 years, it's only 4 to 5% after 5 years and 10% after 10 years. And if your patient live for 20 years, it's almost more than 25% of the people will have some form of cancer. So if we can classify the malignancies after the transplant, it may be de novo. That's it's originated after the transplant. And most commonly are the non-melanoma skin cancers. Kaposi sarcoma, we don't see much. It's a Western. PTLD and the genital and the urinary tract and the lung carcinoma, what we see. And even it may be donor derived. It again depends on which organ it is. If it is from the kidney, people might have seen a renal cell carcinoma in the graft, and the pancreatic and the malignant melanoma, chorioadenoma. These are all maybe a donor derived. And the recurring, these are all things which we can, if this is a donor derived, they present much earlier as compared to the de novo. The recurrent of the pre-existing, it may be in the liver, it may be hepatocellular, or it may be a melanoma which has not been treated, which may recur after the transplantation, especially myeloma is also one of them. Why this pathogenesis of malignancies after the transplant? It's one is the radiation, tobacco, and pollution, ultra UV light, and the smoking. Everything will damage the DNA. And usually in a normal person, it gets deranged or it is get rearranged. But again, because of the aging and also the calcineurin, azathioprine, the drugs which are there, they damage. Which once it has happened, the repair process is halted or it's altered because of the immunosuppression. And the B cells and T cells and the natural cells, they angle or clear all these mutations or those cancer cells, but the immunosurveillance is damaged because of immunosuppression or the T cell depleting agents. So increase in the T cells, it also leads to EBV and the viruses, oncogenic viruses, which will cause production of the growth factors and the anti-apoptotic proteins. So uncontrolled proliferation of the tumor cells, which will happen, and even the IGF and everything is also suppressed. So it's also tumor also increases the suppression of the immunosurveillance. So this is the reason why once they are more prone to get cancer, and once you have a cancer, then unupdated growth happens, and there is a more and more metastasis can also happen. And the presentation varies from person to person and the origin of the disease. Calcineurins, they basically are inhibit the IL production, but again, they role in the carcinogenesis is because of the TGF beta and the VEGF and the interleukin increase, and they also enhance the apoptosis. The azathioprine, it causes the intercalation of the DNA, inhibits the repair of the splicing. So the damage which has been happened, it reduces the repair. Mycophenolate mofetil is an anti-apoptotic. It is slightly marginally balanced, and the mTOR is only drug which inhibits the mTOR pathway and reduces the angiogenesis, and all the formation of cancers have been reduced. On a nutshell, the patient-related factors like an age, previous cancers, and exposure, and the viral infection, and the duration of dialysis, they are the patient-related factors for a malignancy, and the transplant-related like donor type, rejection, and the transfusion plays an important role. And in the medication-wise, the net immunosuppression, most of the people have received the immunosuppression prior to the transplant because of the glomerular diseases. They may have more and more increase in the immunosuppression, and the induction therapy and the maintenance therapy also plays an important role. So this was the chart which shows that the older the age, 3 to 6 times, and even the male gender has more, and the smoking increases, the time on dialysis more than 4.5 years, it increases by 40%, and the diabetes increases. There's one, the polycystic kidney, it reduces the chance after post-transplant malignancies. PRA high, more mismatch, and it increases, and the expanded criteria donor increases. T cell and B cell and mTOR reduces the malignancy by 30 to 40%. Immunosuppression has changed over the decades, and earlier people used to use less of intensification. Now almost around 30 to 40% of the people are ATG, and another around 20 to 30% of people, they use IL-2 induction. IL-2 won't cause any increase in the harm, but more and more MMF, almost 75% of the people are on MMF, and the tacrolimus also increased significantly. So these are the more, but whether it has transplanted into more and more malignancies. This was an US transplant data, which showed 97 to 2006, 46%, and 2007 to 2016, this 37. So it has not increased number of malignancies, whether they wither away before getting a malignancy, we don't know. But again, we had to screen so that we can diagnose it early and treat it early. This was the chart from different countries and different malignancies of all transplants by the registries, which basically shows that there are more and more non-melanoma skin cancers, either in the lip or in the lung or in NHL. PTLD is one of them, and the native kidney is the more common. And the outside, the Kaposi sarcomas, they're more common, around 300 type as compared to general population. Non-melanoma skin cancers are 2 to 40%, lip cancers are high, post-frontal lymphoproliferative disease are also high. This is what we see in India. I thanks Dr. Santosh for giving his data. And Velo seen 2.5% of the population, they had malignancies. Most of them were 38% are PTLDs, and non-melanoma skin cancers were 23%, and head and neck was 13%. The average incidence, average malignancy age was 45 years, and 83% were male, and the time to malignancy was 8 years. What we saw was 2,500 transplant, 53 malignancies in 51 patients, it amounting to 2.04%, and the PTLD incidence was 28, and the RCC native and the graft was 22%. This was high in our series, and head and neck cancer was 16. Average age was around 48 to 49, and time to malignancy was around 8 to 10 years. And in Apollo also 4.2%, and there's from PGI, there's a PTLD experience, which I'll come to that later. And even just like one of the presentation, they presented that PTLD was 27%, and the time to malignancy was 10.7%. And in the USA, it was the incidence of malignancy was high, and Australia, New Zealand, it was around 6.5%, and the genitourinary malignancies was 31, followed by PTLD. What are the risk factors for malignancies post-transplant? And this was one of the analysis done from Velo. They have taken into consideration the age, gender, and the induction agents, lymphoproliferative depleting agents, and the biopsy. And the calcineurins was an important factor for increasing almost to 200 times. And the NODAT and the age more than 40 years was an important risk factor for a malignancy post-transplant. Now come to PTLD, you have the WHO classification as an early lesion, and polymorphic, and the monomorphic, and T-cell, and even the Hodgkin's lymphoma and lymphoma. And the risk factors, you all know that EBO serology negativity is an important factor, especially when you're using belatacept, and then hence the belatacept has not been advised if there is EBV negative. T-cell depletion and the age, CMV infection, second transplant, plier, splenectomy are an important factor. If you see the type of a transplant, the intestine and the lung, they are the very high of PTLD, and the EBV negative state and the immunosuppression state also important. Worldwide incidence of PTLD is around 1.3%, but in the children, it's around 1.2 to 10%. It's very higher. What is in India? What people have shown, CMC Vellore, almost 31 patients had more oftenly from the gut, and also disseminated in 19%. Time to malignancy was in 4 years, and by WHO, it's 90% were monomorphic. And so EBV positivity is one seen in one, and the survival, median survival, 69 years. What we saw is PGI, there was 29 people had malignancies for PTLD, 59% were disseminated, and the monomorphic presentation was 81, NHL 176. So 73% died within 1 year. In SDPGI, 9 patients, gut was origin, and CDC positivity was CD20 positivity in 100%, 33% died within a year. And what we saw is 14 patients had post-transplant malignancy, PTLD, and time to malignancy was 8.9 years. We had more of around 78% were mono, and the gut was one of the origin and even myeloma was also one of the major disease. So this was the publication from Dr. Vinay Sakuja group from PGI earlier. 45 malignancies were diagnosed in 36 patients. Out 29 of 36 had the PTLD, which was contributing 1.45, and the predominantly was a male, and 22 patients had non-Hodgkin and 7 had myeloma. 29 were on the first graft, and the mean age was 41 years, and none of received an ATG, and the presentation was 1 to 5 years and more than 5 years. So how to treat with the PTLD? It's an early lesion. The first is to reduce the immunosuppression. And if it is persistent, then we may have to do surgery. If it is a polymorphic variant, then reduction in the immunosuppression, we need to see whether it is CD20 positive or CD20 negative. CD20 positive, we can go ahead with rituximab, or if it is localized, then you can go ahead with the surgery. Monomorphic variants, then you can have immunosuppression reduction if it is CD20 positive, rituximab. If it is persistent, then you can join CHOP. Or if it is negative, then chemotherapy is the option, CHOP, and otherwise ABVD or HDMB along with that. The lymphoma, immunosuppression reduction, chemotherapy, which are options where, again, it is very, very difficult. Now, which is coming up with a card is an adoptive immunotherapy. If it is an autologous origin, then the recipient-derived PTLD, then it's an autologous. And if it's a donor-derived, it's an allogenic immunotherapy, and tacrolimus, you can use anyone. Then coming to the non-melanoma skin cancers, they are also very common. And it is pooled data which shows that almost 12%. Again, in Australia, it is very, very high, almost around 39%. And the Middle East or in India, it is much less as compared to Australia and New Zealand. And it varies. And the pooled analysis shows that in a prospective study, it's around 21%, and retrospective study, 9%. So possibly, if you do a prospective studies, we may also find a little bit more as compared to what has been published. And basal cell carcinoma, it is more phenotype, it's more higher rate for metastasis. The risk factors being elderly age group and the male sex, fair skin, outdoor occupation, during immunosuppression, and the actinic keratosis, it's also predisposing factor for non-melanoma skin cancer. If you find what blue is the low risk regions, then you can do a cryo or a tropical therapy, or if it's a moderate region, you can do an excision, and if it is a high risk, then the surgery, retinoids, and reduction in the immunosuppression, you need to do it. So in a CMC, there are 13 patients had head and neck and the upper limb perianal regions. The diagnosis was done at the age 51 years. After 10 years, they had a malignancy, and the post survival malignancy after that, the lesion was diagnosed, was 163 months. But we had only 4, and 2 were in the upper limb, 1 in the lower limb and the groin. And time to malignancy was after 10 years, and we did 3 in the excision and 1 change into addition of sirolimus. They had post-transplant, they had around almost 130 months. The head and neck cancer is also important. It may be a lip carcinoma outside, or the tongue, or any other. So you see in a squamous cell carcinoma, your keratin pearls you see. And what are the, in Indian literature, we saw 9 patients of head and neck, 7 were tongue, and the brain was an astrocytoma, and it happened after 10 years, and the excision was done. And those who astrocytoma died early, within 3 to 4 months after diagnosis, and otherwise the tongue had around 38%. CMC Vellore around 11 patients. The tongue was 6, hard palate, sinus, and everything. So they also, sharp tooth was a risk factor, and almost 177 months survival seen. Apollo Hyderabad, they presented 5 patients and 24 months survival, and HPV positivity was one of the significant factor. This is the number of cases of 5 patients which are presented, and so 3 were alive at the time of the writing, and the survival was much poorer those who had cancer. Other than non-melanoma, we had multiple CMC. They had urothelial, RCCs, pancreatic, prostate, and the gut, and also the one leiomyosarcoma. What we had is 12 RCCs, squamous cell carcinoma in the renal pelvis because of the stone disease, and the prostate, gut, we had esophageal and colonic cancers, and leiomyosarcoma. So renal carcinoma majorly can happen in the renal native kidneys or in the graft. Majorly in the native, it constitutes 2% of the malignancies. The history of NSAID in intake, or an acquired cystic disease, long duration of dialysis, and the family history, they are the predisposing factor. screening with an ultrasound, it may pick up, but it may not pick up an early lesion. So screening sometimes miss a small disease. What we saw is 11 patients from the native and 1 from the graft, and the diagnosis and histology were equal, almost 50% were papillary and clear cell. Time to malignancy was 8.6 years, and at the age 49 years, but only one person had received an ATG, IL-2 was in 3, and 8 patients did not receive. And 2 patients, they had dialysis after around 2 years. 1 patient, the graft nephrectomy was done, and he has been transplanted after a year. And so this was the Australasian data, which shows that the RCC, the outcome is better as compared to TCC. So the native kidneys, it may be bad. That once you have a cancer, there is more and more mortality. This was next analysis, which shows that 12,805 patients, the report that 56% of deaths, which are with death with functioning graft. So we are losing patients because of functioning graft, because of the malignancy. And it may be one of the reasons might be increased use of immunosuppressions. Again, it is very difficult to monitor and when to reduce the immunosuppression, how much to reduce. If you reduce too much, then we can have rejections also. The survival patients who have been diagnosed with cancer, the median survival of 2.1 years, which was significantly lower as compared to the control of 8.3, which was matched. So in another study, they see the same thing, that those who have a tumor, they have less survival. Which organ which gets a brunt or the lesion or a malignancy, what is the survival? So if you see the total number of at the time of diagnosis, the age and the time of diagnosis and the incidence wise, one of the more important is an RCC, GI, and then the urological malignancies. In this paper they have shown. And if matching, if it is RCC, the survival is better as compared to GIT, lung. So it is, if it is a renal, it can be taken out and it may be better. Even the survival, if it is a lung, which is very, very poor. And so the renal, if it is very,
We're already running short of time, so we might have to quickly
only 1 second, sir. Screening is basically screening annually, and even we have to colorectal cancer as a general population. And in abdomen, we need to do yearly sonography. When to do after the transplant, if the say a malignancy retransplant, we need to consider organ and the patient factor, cancer factor, and immunosuppression, whether the patient needs, how we can have an organ replacement. So time waiting for a transfer, no waiting time is required. Superficial bladder cancer, prostatic cancer of TA, and the incidental things, and the monoclonal gammopathies. To summarize, cancer is a substantial cause of morbidity and mortality in transplant. Incidence of cancers increases with time and after transplant, and the mortality also increases. Limited evidence about the screening. Again, it's very difficult, but we need to screen with time. So thank you very much. I thank Dr. Santosh and Dr. Anam and the team MQH for helping me. Thank you.
Thank you, sir. We are already running short of time, so we need to conclude the session. Any quick comments from the co-chair? Otherwise, we can conclude the session. Thank you.
Thank you, sir, for an excellent session. Now for the next session, I would request Dr. Saket Kumar, Associate Professor, Department of Surgical Gastroenterology and Liver Transplant, IGMS Patna. Dr. Rakesh Kumar, sir, Associate Professor, Department of Surgical Gastroenterology and Liver Transplant, and Dr. Utpal Anand, sir, Associate Professor, Department of Surgical Gastroenterology, AIIMS Patna, to chair the session. Sir, please take the seat on the dais. Now, may I request the chair to conduct the session?
Good afternoon, everybody. I would like to invite Dr. Rakesh Rai, who is consultant hepatobiliary surgeon and liver transplant surgeon at the King's College Hospital, Dubai. This topic will be challenges in liver transplantation, how to start and expand. And Dr. Rakesh Rai, sir.
Thank you. Can you all hear me, please?
Yes, sir.
Okay, please allow me to share my screen. Can you see my screen? Hello? Can you see my slides?
Yes, sir.
Okay. So thank you for inviting me for this exciting meeting. As we all understand that this topic is not a scientific topic. So what I'm going to speak is from my experience in working in different centers in different countries. But this is a very, very important topic. And as we realize more and more transplant centers are coming up in different places, and now, almost every state either has or is going to have a new transplant center, we have to be very careful as a clinician if we are given a responsibility to start a transplant program. You all know when we are talking about liver transplantation, we are dealing with establishing a department which is going to involve a state-of-the-art infrastructure. We are going to deal with multiple different disciplines in the healthcare system, and we will need a huge financial resource for that. And the hospital which is going to start the program will have definitely a lot of administrative, logistical, educational, and financial issues. All these points needs to be taken into consideration before you jump into starting a liver transplant program. And what I suggest that before starting a transplant program, there has to be a joint consensus between the management, whether it's a private hospital or whether it's a government hospital, and with the clinicians responsible to start the transplant program. Most of the time what happens that somebody with whether it's a hospital owner or hospital management makes already a decision that we want to transplant program, and we as a clinician are handed over the responsibility to start a transplant program. That is not the way to run a successful transplant program. And as a clinician, we have to be very careful when we take the responsibility to start a new liver transplant program. So you need to have certain points on which you need to debate and discuss. Why does a hospital need to start a liver transplant program? Is there a need for the transplantation in that particular geographical area? Will you have a real need, and whether you will have a real demand? Separate these two things together. Need is a different thing and demand is a different thing. You may be establishing a transplant program. There is a huge burden of liver disease requiring liver transplantation. That is the need. But there may not be demand. The patient may not be having those financial support, or the patient may not be in that stage where the transplantation can be done. So both the need and demand for the transplant needs to be defined before you venture into establishing a transplant program. And this discussion has to be taken between the transplant team and the management and all the stakeholders together. Now, what is again a point of discussion is what is going to be the initial investment? What is going to be the cost of running the program? How long the institution can sustain the investment without thinking about a profit, especially in the private setting? Okay. Are we planning to start with DDLT and LDLT? Are we planning to start only with DDLT? Or we are in a geographical area where probably DDLT is not possible, and are we going to start only with LDLT? So these are very important points, and unless we have discussed, debated these points, and we have got a clear plan and answer, we should not be venturing into a transplant program, because what happens then, all the responsibilities lies on the head of the transplant team, and finally, after a few years, the transplant fizzles out. Now, it's my observation that there are actually two different kind of transplant model which runs in the world. One is the transplant model in the developed country, and other in the developing country. In the developed country, what happens if some hospital has to start a transplant program? Basically, these hospitals are very well experienced and very well developed. They have department, they have all kind of multidisciplinary facility and infrastructure already available. And then once they think about starting a transplant program, they will recruit a transplant team. So everything, including the surgeons, the hepatologists, the anesthetists, the OT tech, the intensivists, everybody who have already been experienced in transplant, they are brought in to start the transplant program. Now, definitely this kind of infrastructure and support is not feasible all the time in developing country. So in developing country, we have to modify the model. And that's why we cannot just cut paste the model, how the transplant program runs in a developed world. So the first thing, if you want to start a program in developing country, what you need to realize that lot of in-house training goes in place, lot of equipment rental goes in place. You cannot buy all the equipment in the beginning. You cannot get all the trained human resource from other centers. So you'll have to consider these things, and you have to modify your program according to the center, according to the area where you are planning to start the transplantation. Now, there are certain basics. Wherever you are, there are certain basics which we have to consider for a successful liver transplant program. And the most important thing is the leadership. There has to be a single person leadership to run a successful program. All the programs which I have worked in different countries, they have a very a single and hierarchical leadership program. And most of the time, or almost all the time, I will suggest that the leadership of a liver transplant program has to be run by a transplant surgeon. So why transplant surgeon needs to lead a liver transplantation program? Because the result of liver transplantation has got a huge bearing related to the transplant surgery and what goes on in the operating theater. Now, the person who is going to lead the transplant program, a transplant surgeon, now the person needs to be very experienced, and he needs not only have extensive training in liver transplant surgery, but he needs to be very well versed with pre-transplantation care, transplantation surgery, post-transplantation ICU care, as well as long-term transplant follow-up. So that kind of person can lead a successful liver transplantation program. Now, usually you must start with at least 3 experienced transplant surgeons. If you do not have in a team a 3 experienced transplant surgeon to start the transplant program, then it will be very difficult to run it, because these 3 experienced transplant surgeons should be able to do all the different component of surgery, whether it's a organ retrieval, whether it's a donor surgery, whether it's a recipient surgery, all the components of recipient surgery, all these 3 should be completely trained. Sometimes we are pushed into a situation where you are the only one trained transplant surgeon, and then you are being assisted by a person who are partly trained. Those kind of situations you should always avoid, because that's not the way to lead a successful transplant program. You may have other surgeons who are trained GI surgeons, who are trained general surgeons who may be assisting you, but at least you need 3 people who are trained in transplantation. You definitely need a very well-trained hepatologist who should be a transplant hepatologist. That means you should have experience working in a transplant center, because knowledge of immunosuppression and rejection is very, very important. Now, coming to the intensive care unit, you definitely need a very well-experienced intensivist. He may not be trained in liver transplantation, especially if you have a surgical team who is well versed with post-op care. Then with an experienced intensive, you can run a transplant ICU. Coming to anesthesia, you need anesthetists who are trained in liver transplantation. You may have very well experienced anesthetists, but unless they have a training in liver transplantation, they will not be able to provide you with the best of the anesthesia, because liver transplant anesthesia is completely different from rest of the anesthesia. Now, most of the time you can have experienced cardiac surgery anesthetist who can go to certain center and gain experience in liver transplant anesthesia. Again, you need to have a trained OT nurses. These are experienced OT nurses which can be trained in a short period of time in a busy center in transplantation. And last but the most important is having experienced transplant coordinator. Other than that, so this we were talking about the core team, but there are other support departments, although I'm telling them support, but they are integral part of the transplantation and we cannot run a transplant program without them. First thing is radiology. Now, most of the hospital will have a CT scan and MRI scan or a ultrasound Doppler, but you need to see specifically into that, not only because a hospital has got CT and MRI, that means that will suffice for a liver transplant program. You need to have a CT scan department with a state-of-the-art CT. You need to find out whether they look in the CT volumetry or whether they need to get some software for that. You need to have an MRI which can delineate the intrahepatic biliary radicals were not dilated. So that means the quality of MRI has to be good. And you need to have a ultrasound Doppler facility almost 24 hours because that's what you are going to need them. You also need to have an interventional radiology program. And these are the things, especially the interventional radiology, very difficult to get in all the places of India or in any country actually, because there are very few trained interventional radiologists. So you will have a setup of a cath lab, but you need to have an interventional radiologist. Now, interventional radiologist, although it's a subspecialty in itself, but it has again gone into further subspecialty. So just because I'm a trained interventional radiologist, I may not be suitable for intervention for liver transplantation program. So you need to look into and you need to hire an interventional radiologist who have a very good experience in vascular as well as biliary intervention. And there are certain specific procedures which can only be done by certain kind of interventional radiologists, like TIPS or accessing the portal vein and things like that. So you need a particular kind of interventional radiologist. You need to have nuclear medicine, not necessarily in your hospital, but at least close by, because you will need them for PET CT scan, for high-dye scan and other support system. You should have a very good microbiology department with a rapid bacterial and fungal culture facility available. And and of course, a pathological lab with experienced pathologists to look after the post-transplant biopsy. ID, I have highlighted in red because again, infectious diseases specialists are not many in our country, but I'll tell you, they are the lifeline in especially in the post-transplant sepsis. And the way the sepsis is in India, you need to have a specialized infectious disease specialist for a good liver transplant program. Now, infrastructure and equipment, these things are easy because these are available. Either they can be rented or they can be bought. But again, you have to be sensible that in the beginning, as a department, we do not need to invest too much and buy everything. A lot of things can be rented. But basically, at least you need to have a dedicated 2 OTs, which are clean OTs, like where the joint replacement can take place. You also have to consider different equipment. So you must be, you must have experience of these instruments. Now there are so different variety of electrical energy device available. Choose whatever suits you, but at least 2 Thomson's retractor, CUSA, different kind of other electrical energy device like harmonic scalpel, ligasure, Herbe by clamp. You should consider a rapid infusion device, although you're not going to use it in every transplant, but you should have access to that. You can rent it if required. You should have, again, on rental basis, you can get a TIG and a ROTAM, which is a must. And similarly, you should consider a cell saver. So a lot of these equipments are available on rental, but you should have access to all of these. You may not need it in every transplantation, but when you need it, you should have that. Now, how to start and expand? Again, there are no fixed numbers, but I will suggest that in your first year or first 1.5 years, the aim should be to at least do 10 to 12 transplantation. Now, it does not happen, then that means that the transplant was not started in a setting where it needs to be started. And that's why I discussed in the beginning the demand of the transplantation and incidence of the disease in that particular geographical area. If the transplant is started in a suitable geographical area, then you should be able to do 10 to transplant in the first year. Now, slowly the number should go up, and approximately the aim should be to reach around 40 to 50 transplant in 3 years' time. These numbers are, as I said, they are not definitive numbers, but these numbers are important to maintain the viability of a transplant program for the experience of the ongoing experience of the team as the financial support which you need to run the program. One another important thing which I like to highlight is the protocol. The transplant program has to run on a protocol. The transplant program cannot run just on the basis of everyday discussion and experience and all those kind of things. You have to have a written protocol for even a simplest of procedure like putting a central line. All these procedure has to be written before you start the program, and you should follow that written protocol every day, step by step. And that will really help in minimizing the complications in the transplant. All the cases, whether they are failed or successful cases, needs to be discussed in a meeting, and there has to be a continuous in-house training, especially the paramedical staff. So these things are very important when you start in the beginning and continue that, as you expand as well. Now, the last, but a very important slide, what are the challenges? Now, unless we have debated, as I said in the beginning, on the different important topics before starting, you will face all these challenges. Even in an ideal situation, you will face these challenges, and you should have solution for all of them. First thing is not enough demand. It's very common these days because there are so many transplant programs happening that there is not enough demand to run a successful transplant program. There may be a lot of patients, with the disease, but either they have a financial problem or they are not suitable to be listed, or there are other problems. But finally, demand is not enough, and you're not getting enough patients who can come to a table for a transplantation. So think about that. These are the challenges you are going to face and how you are going to resolve it. The second thing, which is a big problem, is finding a trained staff, whether finding a trained hepatology, trained surgeon, trained interventional radiology. And even if you find them, retaining them is not easy. And that's why you see people leaving one center, going to other centers, and all those, musical chair is happening because it's not easy to retain a trained medical staff for the hospital. So hospitals should have a plan how they are going to acquire and retain the trained staff, even the trained nurses. Most of them will leave India after 1 or 2 years of training. Third challenge is the mortality. Now, especially if the mortality happen in first few transplants, it's not that mortality will not happen, but if because of something consecutive mortality happens in first few program in the beginning, that really lowers the morale of the team, and especially with the hospital management, they may just withdraw the support because they do not understand the complexity of the problem, and they do not understand that these things can happen in liver transplantation. Okay, so you need to try to find out how we are going to handle if you face this issue of consecutive mortality in case of liver transplant, in the beginning. Sepsis is a big challenge for any transplant program in India, especially the liver transplant patients. They are pre-transplant immunosuppressed. They have a very poor nutritional status. They have in and out of the hospital several times before they come for transplantation. So sepsis is a very, very increased risk. So that's why prevention of sepsis, handling of sepsis, and the whole protocol geared towards management of sepsis has to be very strong, especially in developing country for a successful transplantation program. What we are going to do with continuation of training for the different components of the team, that has to be planned, and this is going to be challenged. The transplant, science moves very rapidly, and especially if you're not doing a large number volume, the paramedical staff or the other staff may lose touch. The other problem will be escalating cost. Liver transplantation is a very, very costly business. So how you can control the cost, controlling the cost does not mean cost cutting. You have to learn about the efficiency. So how you can run an efficient transplant program where the cost can be controlled. And that needs to be discussed among the transplant team. You have to discuss with your management staff, and keeping a control on transplant program is very important for a successful transplantation. How you can improve the result of your transplantation? You have always to find ways and always to be on the toes to always keep improving your own result and your center's result as the time goes by. These are the challenges, and one of the most important challenges is keeping the record of short-term and long-term outcome. Especially in India, it's very, very difficult to maintain that kind of data because people move and migrate from one city to another city, one state to another state. People also come from different countries for transplantation. So you have to find out how we are going to keep and tab on your short-term and long-term outcome. These challenges are going to be faced by any transplant program, and there has to be a pathways to manage these challenges before you start the transplant program. So thank you. I think that's all I wanted to discuss about the transplant.
Thank you, sir. Thank you for very nicely outlining the challenges and hurdles in starting and establishing the liver transplant program. We all know that liver transplant program is a Herculean task, and apart from resources, manpower, and training, it needs a very motivated and very dedicated team also. So thank you, sir. Because of lack of time, we won't be taking questions from the audience. Thank you.
Thank you very much.
Thank you, sir, for an informative session. And for the next session, Dr. Kamal Kanodia, sir, PDCC and FIC Path, Professor and Head of the Department of Pathology, IKDRC, ITS, Ahmedabad. His areas of interest is renal and transplant pathology and liver and transplant pathology. Dr. Manoj Jain, sir, Professor and Head, Department of Pathology, SGPGI Lucknow. And Dr. Prabhat Ranjan, sir, Senior Consultant Pathologist and Visiting Faculty at IGMS Patna. He is the only trained renal pathologist at Patna. Sir, I request you to take the chair on the dais. Thank you, sir. May I request the chair to conduct the session?
Yeah. Okay, bye-bye. Thank you very much, all.
Hello, good afternoon. It's my pleasure to introduce Dr. Pallav. He is MD and PDC renal pathologist. He is consultant renal pathologist in histopathologist in Department of Pathology in Sir Gangaram Hospital. Today his topic is basic pathology for renal transplant physician. What we need to know. I invite Dr. Pallav Gupta.
So I thank the organizers and the scientific committee of midterm ISOT for giving me opportunity for this talk. So renal transplant is an important modality of renal replacement therapy. And following renal transplantation, 30 to 60% patients can develop renal dysfunction at any given point after transplantation. It may be immediate, early, or late post-transplant period. And so the different types of biopsies which we receive in patients with the renal allograft recipient include indication of for-cause biopsy, which are the most common biopsies which we receive in our setup. And they are done according to the KDPI guidelines, which you must be well aware of. And the second type of biopsies are the protocol biopsies or the surveillance biopsies, which are less commonly performed in our country. These biopsies are performed at a regular interval following transplantation, And the basic purpose is to look at the subclinical rejections. The third type of biopsies are implantation or zero-hour biopsies performed on table at the type of transplant surgery to assess baseline changes in the donor kidney. So we are mainly concerned with the indication of all-cause biopsy, which are the common biopsies which are done in our country. So when we receive a biopsy in our lab, so it has to be processed for light microscopy and for the C4D investigation. So in the labs who are performing, in the hospital setups, where the lab is performing immunohistochemistry for C4D, one core is sufficient for analysis of a renal allograft biopsy. And in that biopsy, the BAMF criteria for adequacy includes presence of minimum 10 glomeruli and 2 muscular arteries. But if a biopsy has got 7 glomeruli and 1 muscular artery, then that can also be reported. In the labs performing C4D analysis by the immunofluorescence technique, the lab would require 2 cores, one in formalin, another in the normal saline, to perform C4D analysis. Also, in patients who are having proteinuria, transplant patients having proteinuria, or when the nephrologist is suspecting a recurrent or de novo glomerular disease, he should take a second core in the normal saline so that appropriate immunofluorescence analysis for complements in immunoglobulins can be performed. An additional core should be obtained in glutaraldehyde solution for performing the electron microscopic studies, the indication for which I am showing in the subsequent slides. So when you need to take the core for electron microscopy, so in patients who are sensitized, have documented DS at any time post-transplantation, or who have had a prior biopsy showing features of ABMR, in all the biopsies which are more than 6 months post-transplant for chronic antibody-mediated rejection, to look for ultrastructural changes in case of CAMR in the form of peritubular capillary multilayering and early transplant glomerulopathy, which is CG1A lesions, which can only be diagnosed on electron microscopy. And it would also be helpful in cases of recurrent or de novo glomerulonephritis to look for immune deposits. So it is not in all the cases that we will require a sample for electron microscopy, but in these indications, you can perform and take an additional sample for electron microscopy studies. Now, when we receive a biopsy in our lab, so it has to be systematically evaluated, and the biopsies are scored according to the BAMF scoring system. So we give a score for both the acute lesions in the biopsy in all the compartments and the chronic ones. So the renal transplant physician should also be aware of the various scores which we can biopsy, so they can interpret correctly how to treat the patient. So like, for example, in glomeruli, the acute score is for glomerulitis, which is a G score. And then for chronicity, we see the GBM double contours, that is called as transplant glomerulopathy CG score. Also, we look for TMS in the tubules. We look for acute tubulitis and chronic score in the form of tubular atrophy. We must also look for viral cytopathic changes and changes of CNI toxicity. In the interstitium, we have to score for the acute inflammatory score, I score, and also in the form of fibrosis in both the scarred and non-scarred cortex. In the vessels, we have to look for endothelitis, V score, and similarly chronicity in the form of. So all the ones which have got a prefix with C indicate a chronic score. So in the summary of the biopsy, you will find these various acute and chronic renal scores. So the renal transplant physician should be well aware of these scores and how to interpret and further give the treatment to the patient. Apart from this, C4D analysis will be reported in all your biopsies, either by IF or by IHC. And as I told you before, immunofluorescence studies should be performed in all the cases of proteinuria or whenever a recurrent or de novo glomerular disease is suspected. So the biopsies, once they are reported, they are placed into appropriate BAMF categories. So there are 6 BAMF categories as defined by the BAMF working group. So category 1 is when the biopsy is normal or have non-specific changes. Category 2 deals with the ABMR, acute and chronic. Category 3 is suspicious of borderline cellular rejection. Category 4 is T-cell mediated rejection, which can again be acute and chronic. Category 5 was IFTA, and category 6 include all other changes which are considered non-rejection, which include ATN and infections like polyomavirus. But now in the 2019 update, the category 5 has been revised as for polyomavirus nephropathy, and it has been also graded based on the presence of degree of interstitial fibrosis, and the percentage of tubules which are infected by the polyomavirus. So in the last two BAMs, there is a lot of focus on the chronic rejections because they cause a lot of problem for the transplant physicians on whether to treat them or not to treat them. So the chronic antibody-mediated reactions have now been subclassified into chronic active antibody-mediated reactions and chronic ABMRs. The one with chronic active antibody-mediated reactions, in addition to having morphological evidence in the form of transplant glomerulopathy or peritubular hepatitis and DSA, would have evidence of active interaction between the antibody and the endothelium in the form of C4D positivity or microvascular inflammatory score, that is the G plus PTC score. Whereas in patients with just chronic ABMR, the activity and the C4D positivity will not be there. So it is important to differentiate between the two because in cases of chronic active ABMR, the renal transplant physician would like to upgrade the immunosuppression, whereas in cases of just chronic ABMRs, symptomatic treatment would be required. There has also been an update in the 2018 BAM about chronic active T-cell mediated rejection. So previous to that, only arteriopathy changes were included in this category. Now, this is defined as presence of moderate to severe tubulitis accompanied by moderate to severe inflammation in both the scarred and the non-scarred cortex and has been graded into grade 1A and 1B based on these. So again, renal transplant physicians should be aware of this entity. In a survey conducted by TTS, it was found that only 30% of renal transplant physicians are actually treating this entity. Remaining 50% to treat only when the degree of interstitial fibrosis and tubular atrophy was not significant. Now, there's also a role of molecular diagnostics in renal grafts. So long ago in 2009, Bhanu had first described the presence of endothelial associated gene transcript, which in 2013 became a part of the BEM classification and was considered equivalent to the C4D interpretation in the renal graft biopsies. But because of the cost issues and non-availability in large number of centers, this is still in the nascent stage. Of late, there has been a development of molecular microscope diagnostic system, which uses genes transcript for mRNA analysis and comparing them with a reference to clear-cut highlight whether the patient is having ABMR or acute cellular rejection. And this would particularly be helpful in future in differentiating the difficult cases in which a pathologist is able to offer a diagnosis of borderline cellular rejection, or in cases with ABMR without C4D, or in patients who have got combined BK virus nephropathy and with coexistent acute cellular rejection. So with this background, we'll see some basic renal transplant pathology cases and how we'll go about these cases in interpreting the renal biopsy. So the first case is of a 43-year-old male patient, allograft recipient 2021, and basic disease got AD-PKD, and 5 months later presented with nausea and rise in serum creatinine. And on renal biopsy, we can see that predominantly it is a tubulo-interstitial pattern of rejection. So we can see that there is inflammation in the interstitium, moderate inflammation in the interstitium, and we can see presence of tubulitis, moderate tubulitis and many tubules, and presence of C4D. So we should the renal transplant physician should well be aware about these scores. The second case is of a 48-year-old male patient, RAR recipient with immediate graft dysfunction, and the graft Doppler showed increased resistive indices in this patient. So as compared to the previous case, we can see that the glomeruli is quite inflamed. So there is evidence of glomerulitis. Also, we can see the peritubular capillaries are congested and they show neutrophilic margination. And we can also see ATN-like changes present in the tubules. And the C4D is diffusely positive in the peritubular capillaries, thereby indicating that this patient is having a acute antibody-mediated rejection. And this is the score was the same. So the C4D was diffusely positive. There was presence of glomerulitis, presence of peritubular capillaritis. So this is a straightforward case of acute antibody-mediated rejection. So the third case is of a 56-year-old male, renal allograft recipient 2017, basic disease was diabetic kidney disease. And patient presented almost after 4 years with a rise in the serum creatinine and presence of proteinuria 2+ with urine PC ratio of 5.5. So renal biopsy was performed, and in this case, we can see that the glomeruli is enlarged and showing mesangial expansion along with thickening of the glomerular capillary basement membrane. Also, in the adjacent tissue, we can see presence of peritubular capillaritis, mild interstitial inflammation. In the silver stain, we can see widespread duplication or GBM double contours, indicating the this patient is having transplant glomerulopathy. And this is the electron microscopy of the same, highlighting the multi-lamination of the peritubular capillary basement membrane, thereby suggesting a chronic injury to the peritubular capillaries. And the C4D was positive in around 40%. So this is a case of chronic active antibody-mediated rejection, having transplant glomerulopathy and peritubular capillary basement membrane, multilayering along with C4D positivity. So the fourth case is of a 38-year-old male patient who presented outside our hospital with symptoms of reduced appetite, swelling in the limbs, and frothy urine in 2011. Kidney biopsy done outside our hospital was suggestive of MPGN with the IF of IgG1 plus and C3 plus. And this patient later on developed ESRD and was admitted to our hospital in 2017. So in our hospital, analysis showed that creatinine was increasing and the proteinuria was around 4.54, urine PC ratio was 4.54, and the C3 levels were reduced. So the renal biopsy was performed, which showed presence of increase in messenger cellularity, along with markedly thickening glomerular capillary basement membranes. And there were also thickening of the tubular basement membranes. And on the silver stain, we could appreciate the thickened GBMs along with the segmental reduplication of the glomerular capillary basement membrane. And on immunofluorescence, we could find that there was a C3 dominant deposit. C3 was 4 plus, IgM was 1 plus, IgG was absent. And C3 deposits are also present along the tubular basement membrane. So this gave an idea that we are dealing with a C3 glomerulopathy. And we further did electron microscopy analysis of this case, and we could find this beautiful hyperosmophilic ribbon-like intramembranous deposits, thereby confirming a diagnosis of a recurrent dense deposit disease. So the last case is of a 59-year-old female patient, hypertensive, received a live related transplant in 2012. The donor was sister, and the basic disease was chronic glomerulonephritis. And she received induction therapy with 3 doses of thymoglobulin and tacrolimus, and the baseline creatinine was 1.4. So initial 2 years were uneventful, and later she developed a rising trend of serum creatinine. There was slow and progressive rise. And in view of the rising creatinine, renal biopsy was done. Meanwhile, the samples were also sent for the serum BKV virus load and also urine PCR for BK virus, and both were found to be raised. So in this biopsy, we can again see that there is interstitial inflammation and there is mild tubulitis. But in addition to that, we can see that these tubules are showing markedly enlarged nuclei with presence of characteristic ground glass inclusions within the tubular epithelial cell nuclei. And also we can see some amount of tubular atrophy. And when we performed immunohistochemistry for SV40, so this we could see that these cells are positive for SV40, thereby confirming the diagnosis of BK virus nephropathy. So to conclude, renal graft biopsy is a gold standard for diagnosis of renal transplant pathology. It provides valuable information for patient management and prognosis. The biopsy cannot be interpreted in isolation and should be done with respect to appropriate clinical context in correlation with neurological findings and biochemical findings. The biopsy report should specify all the acute and the chronic changes so that renal transplant physician can treat the patient appropriately. A refined and precise diagnosis using various modalities available with the transplant pathologists, light microscopy, immunofluorescence, IHC, electron microscopy, and molecular studies, and a good interaction with the renal transplant physician can have a good impact and have prolonged role in prolonging the graft in the patient life. Thank you very much.
Thank you, Dr. Pallav. It was nice oration. And just I want to add a little bit about ATN, which is a real nightmare of the transplant nephrologist or surgeons. It's actually a 7 to 10 day duration that is the more important.
Yeah.
And what was in our study and different study findings, these ATNs when combined with the C4D staining, many are hidden antibody low grade rejection also. So that's a two pathology mostly associated ATN and antibody mediated rejection in early anuria or rising serum creatinine.
Right.
So that's rest is fine.
Yes, it's a nice presentation, Pallav, and very informative. And you have also done this interesting cases. And one thing I just want to add that many times we see the mixed type of things, like rejection with the drug toxicity, especially CNI toxicity. Right. Sometimes rejection with the infections. So basically, renal biopsy is the gold standard to diagnose. I end the session because we are running this. Dr. Manoj Jain is just left and he is now online. And please, Dr. Manoj Jain, you are not on it audible.
Yeah. Thank you, Dr. Pallav, for nice presentation. So the main important thing for nephrologists is that prompt reporting from pathologist side is required. Close interaction, as mentioned Dr. Pallav also, that is very important. And clinicians should also understand that morphological overlap exists in biopsy. Two lesions can coexist, or they has to be separated, just like CNI toxicity with rejection or BKV nephropathy. So close interaction with nephrologist always helps. And for pathologist, early prompt reporting is very essential. So when someone gets biopsy, rapid processing and reporting and close interaction is very important for patient benefit. Yeah. Any question can be taken up.
Thank you. Thank you. Thank you.
Thank you, sir, for an excellent session. And now moving to the next part of our the day, which is a short session. And for this, I would like to invite Dr. Seal Avnish, sir, additional professor and head of the department, CTVS, IGMS Patna, and Dr. Rohit Upadhyay, sir, additional professor, Department of Urology, to chair the session. Sir, I request you to please come onto the dais and take the seat.
Myself, I am available online.
Good afternoon, respected delegates. I can see few surgeons, and next few sessions are regarding surgery only. This is a very important topic because in centers which are doing only renal transplants or live transplant, this session becomes very important because once in a while you get a call for doing a cadaveric organ retrieval. So, and we'll start with the first session, that is regarding retrieval of thoracic organs, and that will be by Dr. Prem Anand. It will be a video demonstration. He is not available, so we'll be playing the video of his presentation. So start, please.
Good day, everyone. Good day, everyone. And special thanks to Dr. and being part of 207 organs. Organ retrieval, heart of 70 thoracic organ transplantations, and I personally retrieved 90 thoracic organs.
He's in KIMS Hospital and associated with thoracic organ retrieval.
Heart and lung procurements are multi-phase processes, often accompanied by an array of complex logistics. Approaches to donor evaluation and management, organ procurement, and organ preservation vary among individual procurement teams. Because early graft failure remains a major cause of mortality in contemporary thoracic organ transplants, it is better to follow a strongly protocol-based standard procurement process. And between retrievals from brain-dead donors and circulatory arrest donors, BBD remains the mainstay and the main avenue for organ donation in India. And there are multiple combinations for thoracic organ procurement. There are heart retrievals, there are double lung retrievals as an en bloc. There are single lungs, two separate single lungs being harvested, and then there is combined heart lung harvest. So the communication becomes the key during the retrieval process. It is always important to communicate with the liver teams as well as the kidney teams, and get to arrive at the tentative cross-clamp time and discuss the surgical details so that there is no problems in organ sharing. The liver team will insist on a good length of IVC, and the lung team will insist on a good LA curve. So it is always better to open up to the fellow surgeons there, get a game plan, and then move across. So the common surgical steps till cardioplegia is the patient needs to be positioned. The importance of position is very important. The neck has to be extended so that the tracheomobilization becomes easier. The median sternotomy has to be in line with laparotomy so as to avoid any tilt towards one side, and organ retrieval can be easier. Hemostasis is very crucial because you don't want the patient going into hypotension. And sponges are placed on the retractor to avoid migration. And the best way to position it is always an inverted retractor so as to optimize space between two working teams. The pericardium is open, cradled, and heart and lungs are inspected using no-touch technique so as not to cause any hemodynamic embarrassment. There are three components to dissection. The arterial, the aorta is looped around with the umbilical tape. The SVC and venous, SVC and the IVC are taped with the looped around with the silk threads. The airway is like trachea is looped around with the umbilical tape in the neck. Purse strings are taken, patient is heparinized, and cannulation is done. The cross-clamp sequence is 500 micrograms of prostaglandin is injected into the main pulmonary artery. Then inflow occlusion of the venous system is done. This is done by tying the SVC down. IVC hemi-transected so that the right heart is completely vented. Then the cross-clamp is applied. Adenosine is injected and cardioplegia given, making sure the heart is having a smooth arrest. Left heart is vented. There are a lot of methods by which the left heart is vented. Each team follows its own strategy. So either from the right superior pulmonary vein or the LA appendage or the posterior LA can be vented out. And once the heart is arrested smoothly and the heart is vented completely, pulmonoplegia can be started. Heart retrieval. After both custodial as well as pulmonoplegia is over, the SVC and IVC is transected, giving good length to the liver team. Then the aorta is transected along with the main pulmonary artery. And the heart is lifted up, LA is detached, leaving a posterior cuff if organs are shared. Double lungs is almost very similar. Once after the heart is explanted, inferior pulmonary ligament is divided. Posterior pericardium is scooped because there's only loose areolar tissue there. And walking on the esophagus is recommended so as not to injure the pulmonary veins. Descending aorta on the left side is divided. Azygos on the right side is divided. The superior mediastinal tissues are divided. The trachea is stapled, making sure that the lung is adequately ventilated, filling up to 80% of its volume with the FiO2 of 50%. Combined heart lung is also similar way. And once the organs are harvested, they are packed in a triple layer bag method where the first bag, the innermost bag contains only like the preservative solutions like the Perfusion in case of double lungs, custodial in case of heart, and in case of combined heart lung, it's custodial mixed with probably normal saline. And the second layer consists of very cold saline, and third layer consists of ice slush. The important thing is to avoid direct contact with ice so it doesn't cause thaw injuries. This is again a video that shows the sternotomy has to be in the midline so as to avoid tilt towards one side, which will make the organ procurement very difficult. The sternotomy is being shown here. So use sponges to avoid migration of the retractor. The retractor has to be placed inverted so as the working space has to be shared. This is again a video which shows the heart has to be examined first. Try and use a no-touch technique so as to avoid any hemodynamic embarrassment. Vessels look for atherosclerosis, pulmonary vessels. Pleura open, lungs look for palpator for nodules, any adhesions, pleural effusion, signs of early consolidation. The organ deems to be good. Then that's a aorta looped around with the umbilical tape, SVC with a silk thread, and so is the IVC looped with the silk thread. The trachea is looped with an umbilical tape too, but usually it's done at the end, just before the cross-clamp sequence to avoid injury to the airway. This is again the cross-clamp sequence. It shows there are two cannulations, one in the main pulmonary artery and the other one in the aorta, which gets the custodial, and the other cannula delivers the pulmonoplegia. You can actually see the venting process. The right superior pulmonary vein closer to the LA is vented, and then the LA appendage is also vented. This is again a video which shows division of the aorta and the main pulmonary artery, SVC and IVC, for the heart to be explanted, and only after which the lungs will be explanted. This is again a video where the posterior pericardium is lifted up and the loose area tissue between the esophagus and the posterior pericardium is divided and extend up to the trachea, and the whole lung is lifted out. This is another important step after perfusion and after the lung is taken out. Triplicate perfusion of the lung is done. So 250 ml of plastic solution is infused into each of the pulmonary veins, and waiting till the clear returns to be seen from the pulmonary artery. This is again retrieved double lung specimen en bloc after backbench preparation. This is a method to show division of the posterior pericardium and the posterior LA curve, and also the trachea is split into the right and left side. Backbench preparation. This is just another video to show how badly the destroyed lungs look like, and the patient gets a lease of life after a transplantation of good lungs. This is another video just to show that well begun is half done. When retrieval is done neatly, the outcomes definitely match it. And this is one of the happy recipient combined heart lung. And this was on a birthday celebration after the transplant, 3 days after the transplant. And results like this gives us a greater gratification. Thank you.
The next presentation will be by Dr. Ravi Mohanka regarding multiple organ retrieval of the abdomen. He is Director of Liver Transplant and Hepatopancreatic Biliary Surgery at HN Reliance Foundation Hospital, Mumbai. And he is also presently the President of Liver Transplant Society of India and has performed more than 1,500 liver transplants and has trained more than 25 transplant surgeons. So he will present multi-organ retrieval from abdomen. Thank you.
Thank you very much for this opportunity. Give me a second, I'll start the presentation. So I saw that there is a separate presentation for kidney retrieval also. So I'll restrict my presentation to liver retrieval or abdominal organ retrieval. So basically, organ retrieval is done in a standard fashion using the hypothermic method, which is standard cold preservation solution, which is either UW or HTK. So the solution is put through the aorta, and using that technique, we can perfuse not only the liver, but pancreas and small intestine also. This is mostly using the core cooling technique. The goal here is to perfuse only the segment of aorta which is marked in blue. So therefore, while the cannula for perfusion will start at just above the iliac vessels, but we put a cross clamp above the diaphragm or sometimes below the diaphragm to ensure that we don't waste the preservative solution, which is very expensive. So this is a video where we show the same. A skin incision is made, or thoraco-abdominal skin incision, and even a cruciate incision on the abdomen is made. Abdomen is opened all throughout, and using the falciform ligament is divided. The liver is assessed for its quality, and a sternotomy is then made if the liver is good quality. The vessels of the liver are identified. Any abnormal or aberrant anatomy is identified here, especially for the right and the left gastric artery. The aorta is then cannulated by just above the iliac arteries, and using the right angles, we will expose the aorta and go around it. And a very strong umbilical tape or one of the strong suture threads is used. The bile duct has to be irrigated through the gallbladder. This will avoid cholestasis of the transplanted liver after the transplant. And this has to be done at room temperature. The portal vein through the inferior mesenteric vein is also cannulated. This is to ensure that both the arterial and portal venous systems are perfused, and that will give the best outcomes. Here the aorta is being shown, aortic cannulation is being shown, and this has to be a very firm tie, otherwise because this is a lifeline for the perfusion fluid. And once that is done, then the aorta is cross clamped in the thorax. This is to ensure that we don't waste much preservative solution. And once the preservative solution is run through the aorta, the surface cooling is also done with sterile ice. Once that is started, then we start the cold dissection. The cold dissection phase starts with dividing the bile duct, followed by the gastroduodenal artery. Once these two structures are divided, then it's only the portal vein and the hepatic artery which remains. The portal vein is divided with some more length on it. And then the hepatic artery is identified, including its branches such as splenic artery, left gastric artery, and the superior mesenteric artery from the aorta, because sometimes there'll be an aberrant vessel into the right lobe from here. Then the IVC is divided below the liver, and here we have to ensure that the renal veins are not damaged. Once that is done, then the liver is delivered from the cavity, and then it is again perfused on the bench. And that is how standard retrieval is done. Then it is stored or packed in a sterile 3 layers of sterile bag, and then put in a ice box for transportation. If it's within the hospital, then this step may not be required. However, things are now changing. In addition to cold storage, we are also looking at normothermic preservation of the liver. This is something that is going to change liver preservation over the next few years. And in addition to providing a longer preservation time, it also helps us evaluate the quality of the organ. So this is a little more complicated because it requires a machine, because it has to deliver oxygen and it has to deliver nutrients, and there is potential that you can even immunomodulate or cause some, get rid of the fat in the liver with this technology. But currently it's very expensive and not really freely available in most parts of the world. So these are the 3 techniques or machines which can be used for normothermic perfusion of the liver. Now, when we retrieve a liver for one of these, then we have to ensure that it is watertight. It's because these livers can actually bleed on the machine also. And therefore, a lot of techniques have to be, a lot of careful dissection has to be done for these livers. But then the advantages far outweigh the difficulties that we will encounter. So between the 2 techniques of cold storage, which is almost 99% of technique in India right now, but about 95% in the rest of the world. So it's a well-established, cheap technique. It's available freely, and it helps us preserve all organs, not just liver, pancreas, intestine, and everything, and very well known. And there are plenty of surgeons who will be able to do this. However, we are heading towards normothermic perfusion, where new data is emerging. It is currently expensive with limited availability, and it is only available for liver, heart, and lungs right now. There are 2 techniques in this also. One is a normothermic regional perfusion and ex vivo perfusion. The machines that we saw are all for ex vivo perfusion. But in a lot of European countries, now there is normothermic regional perfusion, which is mostly used for DCD or donation after circulatory death. The main advantage of this technique is that this serves as a diagnostic tool. So for marginal organs where we are unsure whether this organ is likely to work in the patient, if you see that this organ is working on the machine, that means the lactates are improving, the SGOT, SGPT are not rising, then this organ is going to work in patients also. The first trial for this has been published about a year ago, where about 20 livers, which were rejected by all centers in the UK, were put on such a machine and were successfully used with no graft dysfunction and no mortality in patients. Thank you very much.
Our next speaker is Dr. Jamal Rizvi, who is a professor at Institute of Kidney Diseases and Research Center, Ahmedabad. He will be speaking on 2 topics, that is how to retrieve kidney when you are retrieving multiple organs, or you are supposed to receive only kidney only. And secondly, about the packing of organs and how to take care of the transfusion issues when you are packing the organs. Thank you. Dr. Umesh Souza is not present. He is not coming.
Okay, good afternoon. Am I audible? Yeah, well, I'd like to thank the ISOT for giving me an opportunity to speak here. And I just mentioned that this presentation I'm going to make is on behalf of Dr. Umesh Souza, who was my teacher during my training and who's unable to make it today because of prior commitments. So you've seen excellent videos regarding retrieval of thoracic and organs and the liver. But there are times when perhaps as a urologist, you'll be called to retrieve kidneys only, perhaps from a donor whose liver is not suitable for a donation. So I think it's important to even for kidney transplant surgeons to know a little bit about retrieval. You've already seen the incision. Even if you're doing kidneys only, I believe firmly that sternotomy should be done as well as cruciating of the abdomen, because this gives excellent exposure, especially to the supraceliac aorta, which is of a deep structure and difficult to reach. So this is the abdominal incision. You see a midline incision, which has been cruciated at the level of the umbilicus and the flaps pinned back using towel clips. So this gives you unparalleled exposure and makes it very easy to do whatever steps you have to do. In addition, a sternotomy, again, eases your approach to the upper abdomen, even though you don't the thoracic organs are not of direct interest to you. So I'm going to play a short 5-minute clip. You've already seen the exposure. Once the exposure is done, you start. This shows us the final steps of cruciation by reflecting the ascending colon, dividing the white line of Tolt, and extending the incision up to the hepatic flexure and completing the cattle brush maneuver by mobilizing the duodenum. Then the cecum is mobilized and the small bowel mesentery is also divided. This brings all the way up to the left renal vein, which we see here. This gives unparalleled exposure to the retroperitoneum and the kidney and the great vessels. After this, the IVC is slinged, taking care not to injure the lumbar vessels, and using an umbilical tape. The dense fibrolymphatic tissue over the aorta is sharply divided. The inferior mesenteric artery is divided to improve the approach to the aorta just above the bifurcation. The aorta is mobilized for at least an inch or so, again, avoiding injury to the lumbar vessels. And it is twice slinged. And as Dr. Ravi Mohanka has already pointed out, a good strong tie should be higher up, because this actually secures your cannula, which if it gets dislodged during after ice placement can be disastrous. Also, a strong silk tie is put lower down, which can be tied even at this point if the donor is having hypotension. After this, I think even kidney transplant surgeon can easily learn to do a sternotomy, which is not technically difficult. And as you'll see, once the chest is open, the two advantages: one, that you can vent the IVC here for perfusion fluid. So once the sternum has been separated, you just divide the pericardium. You can see the whole upper abdomen opens up now. You have to do limited, even if you're not using the liver, you have to do limited mobilization, especially of the left lobe, and opening of the lesser sac of the gastrohepatic omentum. Now you can see this, it's fairly easy to mobilize the supraceliac aorta. An alternative is to mobilize the aorta in the chest, but to keep things in the abdomen just makes it simpler. So the supraceliac aorta is slinged now. After this, the lower tie on the aorta is tied off. Compressing the aorta, because you still have arterial pressure here. 5-millimeter arterotomy is made, and the cannula is inserted. It's very important to pass it not more than 5 centimeters, because if you do it more than that, you may overshoot the ostia of the renal arteries. And this upper tie, as has been stressed, is tied very securely, so that there's no question of it moving out, of the cannula slipping. At this point, the supraceliac aorta is clamped to prevent perfusion fluid from escaping into the chest. The IVC below the right atrium is divided to vent fluid, and HTK solution or any other preservative solution of a choice is started. Cold ice is packed around all the organs, especially the left kidney, which has not yet been mobilized. And perfusion is continued until the clear return from the IVC. At this point, presuming that the liver is not going to be used, the IVC is divided just above the renal veins. And again, I'm thankful to Dr. Ravi Mohanka for taking care of the kidneys, because often this is, the cut extends onto the renal vein ostia. This is just to show the extent to which the cannula is to be inserted up to the 5 centimeter mark, and this is an important step. After this, the great vessels are transected just above the points of tying. The ureter-gonadal complexes are isolated and the ureters are cut low down. Now, steps can be done in different sequences. Either you can separate the kidneys first or mobilize them both in the radical nephrectomy plane. Also lift the great vessels off the tendons of the paraspinous muscles. Often, because these days more and more kidneys are going to be shared, it's advantageous to separate the kidneys in situ. So for this, the superior mesenteric artery is divided. The aorta is slit anteriorly. And this brings the renal ostia into view. So you know if you're dealing with multiple vessels. The posterior slitting is done. The right kidney is mobilized and removed. Similarly, now the left kidney, all the remaining attachments are divided. It's taken out in the radical plane. And the last but very important step is to retrieve grafts of the iliac vessels, both the arteries and the veins. You can see the iliac vessels being retrieved. So that covers it as far as kidney-only retrieval. So should I go on to the next presentation?
Yes, sir.
Right. I'm just sharing my screen. Give me half a minute. Is my presentation visible? Hello?
Yes, sir. You can continue.
Right. So this is a continuation of what we saw before this. Once the organs are all out, there are certain your responsibilities with the donor not over. You should dry the body cavity thoroughly so there's no oozing of fluid which is unsightly later. There should be a cosmetic and watertight closure, and just ensure that there's a presentable final appearance of the body. And often this is going to come to the kidney team because by now your thoracic surgeons have left, your liver surgeon has taken his organs and gone. So this is often the responsibility of the kidney team. Again, packing has already been demonstrated, but just to highlight, we use 3 sterile bags. The inner bag contains only fluid and an organ, in this case, the kidney. This is surrounded by a second bag and then a third bag. And has already been pointed out, but it's worth pointing out again, it's absolutely dangerous to put ice into the bags because you're going to end up with a frozen organ, which you have to end up discarding. And you can use any sort of ice box to pack them, but I think it's important to make sure that the organs are not surrounded by ice on all 6 sides, because this can lead to freezing too. Now, coming to bench surgery of the kidneys, which is, I'm not going to talk about the liver and the other organs. Now, why do we do bench surgery? The aims are to remove excess perinephric fat, to remove fibrolymphatic tissue from the hilum, which there's often a lot of, to control the hyalolymphatics, and this is important. Inspect the vessels in the ureters, look for any retrieval injuries and repair them. Look for any other anomalies or pathologies, such as a small renal mass, renal scars, poorly perfused organs, to do any reconstruction that's needed. And it's important that while all this happens, and it may take as long as half an hour or 45 minutes, the organ should be submerged all the time in cold solution. So this is why we have to do bench surgery. See, this is the kidney, this is the left kidney, this is the renal artery, the renal vein, and the ureter down here. But there's a whole lot of tissue here which you can really classify as junk. It's undesirable, and we have to remove it. I'll skip the part of separating en bloc kidneys because now it's a pretty standard procedure to split them on the table. And I'm just going to show 2 very short clips for a bench surgery of the kidneys. So for the left kidney, we start with defatting the kidney. I mean, there are centers which transplant with fat, but I just think it's unnecessary tissue, and you should only put in that tissue that you want. So circumferentially, this is a nice kidney from a young donor, but sometimes this fat can be very tedious to remove. After this, the vessels are exposed. The lymphatic tissue overlying the renal vein is sharply divided. All the tributaries have been dissected. The adrenal vein, the gonadal vein, and there's a small lumbar vein here. And these are all securely tied and divided. You can also inspect the vein for injuries. And in this case, you can see there's been possibly a traction injury near the lumbar vein, which will need to be repaired. After this, the lymphatic tissue is all divided into columns. And these are all taken down close to the hilum and divided after tying them. So you can see after this, this removes most of the undesirable tissue from the hilum. And if you go further down, where all the lymphatics converge, with relatively few ties, you can control all the lymphatic tissue. Now this rent is being repaired with 7-0 proline. And a final inspection is done just to make sure that all your lymphatics have been taken care of. And finally, a leak test is done where cold perfusion fluid is infused, and you look for any obvious points of leakage from arteries. And this, can prevent you from very tedious blood loss after opening the clamps. Similarly, the vein is clamped, allowed to distend, and you look for any venous leaks. Now, coming to the right kidney, all the initial steps that I described are the same. The step that's usually done is the extension of the right renal vein, because it's a short structure, using flaps of IVC. So this shows the planning of the extension. The IVC is cleared of unwanted tissue. And 2 flaps are created. Again, it's important they should be neither too wide nor too narrow, because if they're too narrow, you risk thrombosis. And they're too wide, then they can cause pooling of venous blood there. The flaps are separated, stay sutures are taken. Again, this is just one technique. Probably every center will have its own technique of doing it. Once you put the stays, they set your edges up for suturing, and then you just run a 7-0 proline along the 2 edges to convert these flaps into a tube. And these should be, uniform, watertight suturing. And it's desirable, although not mandatory, to run the suture line up maybe 2/3 of the vein, tie it off, and then we choose to take interrupted sutures over the last 1/3, because this gives us the option of cutting this vein, this extended vein down if it's too short. And if you have interrupted sutures, you can just cut off the last centimeter or so without having to redo the suture line. And after this, a leak test is done as before. So this is the essence of bench surgery for the kidneys. I'm just going to show a couple of examples of, here's an example of a retrieval injury. So here the posterior segmental artery was completely transected during the retrieval. And because it was identified, it could be repaired and transplanted without any sequelae. This is an example of where for the right kidney, the cut on the renal IVC has extended onto and impinged on the ostium of the right renal vein. And you can see if you extend it here, you're going to end up with an hourglass shaped vein which is prone for thrombosis. So you can use a small patch of IVC, augment this, and you no longer have a narrowing. And this can be used for transplantation. You can see a vein without any narrowing. So there's a lot you can do on the bench, but this is a short summary. Thank you.
Okay, thank you, sir. Dr. Sheel, your closing comment, please. Dr. Sheel and Dr. Devra. As we are running short of time, so we'd like to wrap up quickly.
Hello.
Sheel.
Dr. Rohit.
Yes, you are audible. You can continue.
Yes, it was a wonderful session. I would like to thank the ISOT team for bringing all the great speakers, kidney, liver, heart, lung. If Dr. regarding the heart lung transplantation.
Sheel, somehow think you lost your connection.
Because the video itself was self-explanatory, but still the technical challenges what the surgeon can face during the combined procedure vis-a-vis plain heart transplant and in the immediate post-op. So is Dr. John available for the question session? Because
Take. Dr. Rohit.
Okay, Dr. Sheel, we are sorry. Actually, we lost your connection. So I think.
Yes, I can get.
Thank you.
Thank you all the speakers for an excellent presentation, and thank you, Dr. Rohit, for moderating the session. So now
Thank you.
So now we move on to the next session. That will be on management strategies and outcomes in renal transplant recipients recovering from COVID-19. It's a retrospective multi-center cohort study, and the speaker is none other than Dr. Vivek Kute, who doesn't need any introduction. He is President Secretary of Indian Society of Organ Transplantation and Professor of Nephrology at IKDRC, Ahmedabad. Over to you, Dr. Kute.
Dr. Firoz Aziz and Dr. Suraj Godara are online. Please start the session. Dr. Firoz, sir.
Okay, good afternoon to you all. I think COVID has taught us many things. Questions are unanswered, most of them. And managing these patients for kidney transplantation has not been easy. And with infection at one end and immunological triggers due to COVID at the other end, we had a tough path walking. So with the lead of Dr. Kute, we had been able to publish pan-India data. I think it was a learning experience for all of us. And to speak on that, we have Dr. Vivek Kute, who, as the convener mentioned, who needs no introduction. He's professor in nephrology and transplantation at IKDRC, Dr. HLT Institute of Transplant Sciences. He's the secretary of ISRT, and he's a counselor of TTS and a lot more. So I'm not, taking his space right now. I'm giving the podium to him to take us through the study and his take on the whole concept. Over to you, Vivek.
Thank you, Dr. Firoz, Dr. Suraj, and Dr. Hari for the kind introduction. This is a retrospective multi-center cohort study of kidney transplant in COVID-19 recovered patient. This is largest study in the world literature so far with sample size of 372. As per Global Observatory on Donation and Transplantation, India ranked number 3 in the world for transplant activity after US and China. Annual number of organ transplants increased 2.5-fold from 2013 to 2019, and rate of organ donation increased 2-fold from year 2013 to 2019. Due to COVID-19 pandemic, transplant number in 2019 were 12,000 and 6,600, which dropped down to by 41% in 2020 to 7,442. There is a global impact of COVID-19 pandemic on transplant activity. The percentage decline of 2019 versus 2020 as per GODT data. The disease donation declined 12% at global level and 50% at India level. Kidney transplant declined 21% at global level and 43% at India level. Heart, lung, and liver transplant also declined significantly in India as compared to the global standard. USA is number 1 for the COVID-19 burden, but they were able to manage their transplant activity due to well-established disease donation system. So, to increase transplant in COVID era, patients who recovered from COVID-19, there were concerns like, is there any change in need of induction and maintenance immunosuppressive therapy? And what should be the management strategy for transplant in COVID-19 recovered patient? At the end of first wave of COVID-19, we published this multi-center cohort study of 75 kidney transplant recipients from all over the India. 22 centers participated in this retrospective study. 23% having asymptomatic disease, 48% were having mild COVID, and almost 1/3 were having severe COVID-19 and moderate COVID-19. What were the criteria to proceed for transplant? Normal radiology, 2 RT-PCR should be negative, patient should be asymptomatic for 4 weeks, and he should follow social distancing and COVID appropriate behavior. Outcome was excellent. All donor and recipients were asymptomatic at 81 days of median follow. So follow-up was limited in our first study. So we carry out second study at the end of third wave of the pandemic. This is a multi-center retrospective cohort study. Sample included between June 2020 to December 2021. 372 kidney transplants were performed after recovery from COVID-19. Inclusion criteria: patient should have recovered from COVID, which is confirmed by RT-PCR. If COVID is confirmed by antibody test or clinical criteria, they were excluded from the analysis for the obvious reason. 23 centers from all over the India in public and private sector participated in this multi-center cohort study, which are represented on the India map. Definition of acute COVID-19: time from symptom onset with RT-PCR positive. COVID-19 severity were graded based on WHO 7-point ordinal scale. Primary outcome was acute rejection rate, clinical and biopsy proven, and risk factor for rejection. Secondary outcome were graft loss, patient loss, COVID-19 after transplant, laboratory test, and quality of life in both patient and donor. We followed ISOT consensus statement for kidney transplant recipients and living donor with previous diagnosis of COVID-19. We also adhere to NATO transplant specific guidelines with reference to COVID-19. There was no change in induction and maintenance immunosuppressive regimen. What were the prerequisites to proceed for transplant in COVID recovered patient? 2 RT-PCR should be negative. Patient should be asymptomatic for 4 weeks. Chest imaging should be normal either by X-ray or CT scan. Written informed consent from patient and donor. There should be COVID-free pathway in the hospital, and patient, donor, healthcare worker, caretaker should follow COVID appropriate behavior. This is demographic of the patient. Median age 39. 82% were male recipients, which is common to transplant scenario in India. 19% were having diabetic disease, and there was radiological abnormality in some of the patients, which was statistically significant. Coming to the laboratory parameter, hemoglobin around 9, TLC count around 5,000. The statistically significant difference was noted in neutrophil lymphocyte ratio and C-reactive protein and ferritin value. Most importantly, only around 10% of the recipients has received COVID vaccine before organ transplant in this cohort study. What were the demographic of the donor? Median age 48, 65% were female donor. Pre-donation blood pressure, DTPA, GFR were normal. HLA-DR mismatch was statistically significant. 64 donor, that is 18% of the donors were having past history of COVID-19 recovery along with patient. Primary outcome, incidence of acute rejection, 9%. Biopsy proven rejection, 6.1%. This is the Kaplan-Meier estimate assessing acute rejection association with COVID-19 related factor. Lower risk of acute rejection in patient that never required oxygen during COVID-19 infection compared to patient who require oxygen. Estimated largest mean survival time, rejection. DSA and ABO incompatibility not associated with acute rejection episode. Acute rejection rate were similar to cases in which only recipient had COVID-19 history. There was no proteinuria, hematuria, renal and extrarenal abnormality in living donor, suggesting safety of donation without any postulated sequelae. Other risk factor for acute rejection, Cox proportional hazard model for acute rejection. Degree of HLA mismatch had highest risk of acute rejection and p-value is statistically significant. The quality of life in recipient and donor also significantly improved after transplant. Post-transplant complication, around 5%, urinary tract infection, no complications related to COVID-19 in the recipients and donor, except 2 cases. 1 case each with COVID-19 oxygen scale of 2 and 4 developed second COVID-19 infection by day 3 and 3 months respectively without molecular diagnosis and typing confirmation for reinfection or reactivation due to resource limitations. Discussion, acute rejection episode tend to be more frequent in case with higher severity, rejection episode less in case with induction agent. Patient with severe clinical COVID-19 symptom requiring oxygen or those with less potent induction treatment had more frequent acute rejection. We hypothesize COVID-19 disease severity or recovery time may not serve as a criteria for reducing immunosuppression. Our report suggests no tailoring of induction agent even in case who had history of oxygen requirement. An unmodified maintenance immunosuppression regimen in relation to COVID-19. With only 2 COVID-19 infection as a second episode, our report suggests safety of current immunosuppressive regimen. Report suggests that presence of residual radiological abnormality without active infection before transplant should not be absolute contraindication to transplant, rather than individual case-to-case selection should be made. Few surgical complications in the study, which is encouraging in comparison to previously reported eventful post-operative period in COVID-19 recovered patient. Of additional relevance, study have not detected any thrombosis despite absence of routine antithrombotic prophylaxis, which is seen in other COVID population. In this study, a repeat DSA done after COVID-19 infection was not positive. With retrospective nature of this study during pandemic, it was not possible to recover data from patients who lost follow-up. Observation suggests that sensitization subsequent to COVID-19 infection is a rare event. Transplant have not been denied in any recipient from COVID-19 due to medical unsuitability. This is a comprehensive review of solid organ transplant in COVID recovered patient. More predominant data for kidney transplant. Recovery for more than 1 month seems safe for elective transplant. Continue standard induction and maintenance immunosuppressive regimen. Emergency solid organ transplant can be performed even with active COVID infection in some carefully selected cases. Long follow-up is required. In select cases, solid organ transplant in COVID-19 recovered patient appear successful in short-term follow-up. To conclude, our study suggests that there is no need of any change in induction and maintenance immunosuppression in kidney transplant in COVID-19 recovered patient, and there is no difference in outcome in COVID-19 recovered patient versus those without history of COVID-19. This is visual abstract of this study, 23 centers. Median duration of waiting time from RT-PCR negative to transplant is 88 days. Inclusion period is June 20 to December 21. Median follow-up time is 241. That is longest follow-up available in the largest cohort literature. Acute rejection rate is low and there is outcome is acceptable. We have published around 66 studies on COVID-19 in transplant during the COVID pandemic. I would like to acknowledge contribution of all the authors from India, from out of India, and from our own institute. Thank you for your attention.
Thank you, Vivek. I think it was an excellent overview.
I congratulate you, sir, for this multi-center project. It definitely gives so much highlight to what should be done in COVID record patients. Over to other chairpersons for final comments.
Yes, Vivek, I think it's open for questions. Suraj, my co-chair, please go ahead.
Thank you, Dr. Vivek Bhai. This is the excellent presentation as you are doing in the as usual. I would like to ask, do you have any experience of COVID vaccination in the post-transplant population and rejection? Any association, any case reports you have encountered?
There are only 3 reports in the world literature for COVID vaccination leading to immune injury. But so far, COVID vaccine is safe in transplant recipient. We have also done a systematic analysis which will be published in the upcoming issue of Transplant Infectious Disease. And our systematic analysis shows that vaccine is safe in terms of immune injury in solid organ transplant recipient. Thank you.
Okay, thank you.
One last comment I want to make. Vivek has made sure that India stands very tall in the COVID experience. From India, we have the maximum numbers of papers on COVID in the international literature today. So big congratulations to Vivek for doing so much hard work, making sure all the data goes there, all are published properly. Short period of time, 66 publications. In COVID has not happened too long back. In lifetime, people don't publish so many papers. And Vivek is first author in most papers, right? Yeah, Hari. So great job.
is here. Yeah. He has contributed. Dr. Firoz is
fantastic. So we have dynamics. Yeah. So big round of applause for him.
Thank you, sir.
Nothing extra to add, but here they prepared. Hats off to you and excellent work. Keep doing it. Thank you.
Thank you, sir. Thank you for contribution from all of you. Thank you.
Ashish and Vikas, just 5 more minutes of waiting. We have an audience, and since Vivek has a flight, and we felt that we'll do a very quick 5 minutes validatory function, so that there is an audience also available. So just to thank home, please come, na? Vivek, aajo. कुछ नहीं कर दिए, आप दोनों सेशन में हैं. So please sit up. aajo. There is an audience also available. So we had an excellent 2 days of conferencing in Patna. For me, it was a dream in my tenure to do a meeting in Patna, and that has happened. And I wish to again thank Om and Harsh for doing all the hard work, and many others, of course. I can't take all the names, otherwise our validatory function will go on forever. And then, of course, there are blessings from Ajay ji and Satyajit ji and Indu Bhushan ji. So many people came and gave the blessings. So great job done. Fantastic meeting. Both days, I tell you, the audience which has been there, even in ISOT meeting about 10 years back, we only used to have so much of audience. Now ISOT has become very big. So you guys have done a phenomenal job. So big round of applause for both these boys from us. And big round of applause. I don't think so. They have seen their family for the last couple of months. And so much of tension. The meeting got postponed so many times because of COVID. But we wanted to bring this meeting to Patna because we want Bihar to come up in transplants. And yesterday, obviously, our principal secretary also was so enthusiastic. So I hope that with all your cooperation, something positive will come out. Sir, एक दो comment from the audience. Validatory function is to khatam nahi ho raha.
Yeah. See, I am from East, so we frequently come to Patna for conferences, and the hospitality of Om, Hemant, Harshvardhan, every time. We just come for the hospitality there. So it's, yes, absolutely amazing. And it has been proven again. Thank you.
Since I come from Patna, I will not say about hospitality because I know it's always par excellence. You don't have to, there is no ifs and buts about it. So the hospitality has been really fantastic. And I came yesterday also. These days, usually I don't spend so much time in the conferences. But I was here whole afternoon yesterday and I was in the inaugural function. For me, it was a good learning experience yesterday, and there is experience today also. And I'm so delighted that so many of my friends have come from all over the place, including those sitting on the dais, these two people. And today I was really happy. I never knew that Ajay Oswal will come. I thought he will also be virtual like many others, but he is here. I'm really glad you have come all the way from Aurangabad. And as a matter of why I'm saying all this, because we are only 20% in the whole ISOT, the surgeons. So if I see a surgeon, I'm very glad because one surgeon is surrounded by 4 nephrologists in ISOT. Anyway, it is good, the experience, and I must congratulate these two people. One is Harsh, and other is this gentleman who has been my junior since my school days. मेरा जाने नहीं छोड़ता है, ये सब जगह लगा रहता है, and these two people have done wonderful job together. ये बीच-बीच में बड़ा nervous रहता है, कोई भी काम, anything I used to tell him, जरा हर्ष इसको कर, sir, after that conference, everything after that conference, and Om is like that. Anyway, I had wonderful time, and thank you very much, Sunil, for bringing this conference, midterm meeting to Patna. It's great. Thank you very much.
Thank you, sir. Thank you, sir. Thank you, sir. Thank you, sir. So
So I'm thankful to ISOT, especially the president and the secretary, for giving us opportunity to hold this midterm conference in Patna. I'm thoroughly humbled by all the faculty members who have contributed, who have come in person or they are connected virtually, all the chairpersons and all the committed delegates who are present in this hall. So with the blessing of the office bearers of ISOT and with the support of all the faculty members, delegates, we are able to arrange such type of conference, and we are very much encouraged by the kind words of all these office bearers. So thank you very much. Thank you, sir.
Thank you, IGMS team, Patna team, all ISOT members, and look forward to great Congress in Nagpur in October 22. Thank you.
Thank you, sir, for those encouraging words, but I would just like to mention a few names which have been left out. That is Dr. Amresh Krishna, who has been with me constantly guiding me on this. Dr. Pritpal Singh, who has been with me on every step. Dr. Apur Chaudhary, Dr. Rohit Upadhyay, Dr. Shashi, and many of my nephrologist friends who could make it possible. Thank you very much, sir. Thank you. Sir, sorry for the delay. So we quickly move on to the next session. That is the panel case discussions. So for this, I would like to call Professor Ashish Sharma, who is a transplant surgeon at PGI Chandigarh, and Dr. Vikas Jain, senior consultant urologist. So over to you, sirs.
Am I audible?
Yes, sir.
Very good afternoon to the organizers and to the people sitting in the conference hall. We are now starting a panel discussion on surgical aspects of renal transplantation, and the first topic that we are going to discuss is perigraft fluid. With me is my colleague and senior professor Ashish Sharma will be moderating this session. And in this session, we have got eminent pathologists, eminent transplant surgeons from India, Dr. Ajay Kumar, Dr. Vijay Kumar, Dr. Anish Srivastava, Dr. Ehsan Ahmed, Dr. Aditya Pradhan, and Dr. Priyadarshi Ranjan. And I don't think any one of need any introduction to the present gatherings. They have been stalwarts in their fields. So directly we go to the presentations. We'll be presenting a few cases and case scenarios, and we'll be taking the expert's opinion on the scenario.
1 second. Can we get our panelists on the dais, Dr. Ajay?
Dr. Ajay Kumar and the other panelists.
So I would like to invite the panelist, Dr. Ajay Kumar. He doesn't need any introduction in Patna. He's a senior consultant urologist, director, renal sciences at Paras HMRI Hospital, past president, Indian Medical Association, past president, Urological Society of India. Welcome, sir. The other panelist is Dr. Vijay Kumar, former head Department of Urology at IGMS Patna. Dr. Ehsan Ahmed, additional professor, Department of Urology, IGMS Patna. And Dr. Aditya Pradhan, sir, senior consultant urologist, and he would be joining virtually.
So, are you able to see my screen?
Yes. And Rajesh Agarwal, sir, to kindly come on the stage. Senior consultant urologist from Jalandhar, sir.
So shall we go ahead?
I think yes, please, Vikas, carry on.
One more panelist, Dr. Rajesh Agarwal, is a very senior transplant surgeon from Jalandhar. He is here in Patna, so we are adding him in the panel for both the panels.
Sure, sir. Thank you. Welcome, Dr. Rajesh, sir. So let us take the case discussion forward. Fluid around the graft is most of the time asymptomatic collection, and it can range from this to a catastrophic event requiring immediate surgical intervention. So fluids can be of 4 different types. Grossly, we can divide into either it can be lymph, or it can be urine, it can be blood, or it can be pus. Fortunately enough, most of the collections are clinically insignificant, and they do not need any intervention as such, and they are diagnosed on routine ultrasound graph Doppler. So my question to the panelist, Professor Ajay Kumar, sir, Sir, how frequently you do the routine ultrasound after a kidney transplant? Is it a routine practice or done for a purpose?
Well, we routinely do post-transplant ultrasound.
On day one, or when do you do it, sir?
Sorry?
On what day you do it, sir?
Well, as a matter, if and when required, we can do it immediately also. We do it immediately after the transplant.
So
For
routinely, if the patient is doing well and there is no problem.
For one reason or the other, we do, but for the collection, it is after 24 hours.
Okay.
If we feel that
So that's what
collection which is causing the symptoms, then we do it, after 24 hours and then continue maybe after 2 days, whatever.
okay. So routinely, sir, most of us do a baseline ultrasound on post-op day one just to ensure that everything is fine. There are no collections there and the Graft Doppler and everything is fine in a patient who's doing well. So let us come to the first case. This lady she was a 28-year-old female, and she had an uneventful left iliac fossa renal transplant because she had earlier a CAPD catheter in place. So they're expecting some additions there. We did a left iliac fossa transplant. She had an acute cellular rejection on post-op day 5, which responded to steroids well, and graft function recovered completely. CAPD catheter was removed on post-op day 7. DJ was removed on post-op day 14. 2 days after the DJ removal, there was a 165 cc collection over the superior lateral aspect of the kidney. Patient was asymptomatic. The fluid was aspirated, and which was suggestive of 1.21 of creatinine. So, Dr. Rajesh Agarwal, sir, what is your impression on this? What do you think it is, and how you want to proceed in this patient?
I am not sure whether baseline ultrasound was done in this patient or not.
So, baseline ultrasound was normal on post-op day 1, and after that she was asymptomatic. There's nothing much, so repeat ultrasound was not done. So she was discharged
after
as usual.
After removal, there is a collection at the upper pole. So that means probably there is some obstruction at the anastomotic site, and which has led to more lymphatic ooze from the renal bed, more from the kidney side, and that has caused a lymphocele on the upper pole of the kidney.
So first of all, for the audience, so fluid analysis showing a serum fluid and creatinine of 1.21 indicates a lymphocele. Is it right?
Let me ask you one question.
Sir.
You aspirated the fluid.
Yes, sir.
And it's very nice that you got the fluid. If after 3 weeks or around 3 weeks, and you aspirated the fluid and you got it, usually we don't get it. The failure rate is very high.
So we got the fluid and sent it for analysis.
Did you do it under ultrasound guidance or what?
Ultrasound guidance, sir.
Yeah. Because this is most likely a case of lymphocele.
Small lymphocele which was aspirated. So what is the significance of such a small collection being aspirated, and how frequently you do want to do the ultrasound to monitor whether this is recollected or not, sir? Now that you have aspirated, it has come out to be lymph. Sir, how you want to follow these patients as to see whether this gets recollected or not, sir?
Well, there are two things. If I am suspecting lymphocele, I have to be very, very careful. This is really nagging problem, and the thing keeps on sort of, coming back and back, and especially when creatinine has gone to 1.21 from 1.
So that is fluid creatinine, sir.
Oh, sorry. Oh, I'm sorry. In that case, we will just keep a proper follow-up.
Okay.
We had a lady who was absolutely fine after the transplant, and I think after 4 weeks, she came with increasing swelling in the right iliac fossa, and she was really, her creatinine was also rising. To cut the long story short, it was a case of lymphocele, and this case we managed finally by fenestration.
Sir, Dr. Anish Srivastav is there?
Sorry?
Dr. Anish Srivastav?
Fenestration and marsupialization.
Can't see him in the list
Doctor,
of participants.
On way to Lucknow back. He has a flight.
Okay. Dr. Priyadarshi Ranjan.
Even I can't see him also.
Dr. Ashish Sharma, sir, can you please elaborate and take the discussion forward? How frequently you see lymphocyte in your clinical practice, and how do you manage, and how many of them require intervention, and how many of them?
So I think, clearly the incidence of lymphocyte varies a lot in the literature across different centers. If I talk about my center and I think of laparoscopic marsupialization, I probably wouldn't have done even one in last 4 or 5 years from my own patients. So, but I'm aware that, I've worked overseas, there we used to get a lot of lymphocytes, at least one every 40, 50 patients, which will require intervention.
Okay.
So maybe our technique, like we tie everything on the lymphatic side, either on the recipient or in the donor bench. So maybe that is important. That is why we don't have any lymphocytes. My residents will go after 3 years of training without seeing any lymphocyte.
So that's very important point that you made, sir. It's very important that how you make the fossa and how you do the dissection at the donor side has a important bearing on post-transplant lymphocyte. So most of the residents, it's a clear-cut message that try to tie all the lymphatics, don't leave anything open. That actually reduces this lymphocyte problem post-transplant. So, Dr. Sunil Shroff, sir, is there?
So question here, is because like once you have identified, so that's a 160 ml of collection.
Yes.
So it is not causing any trouble here.
Yes. She had some discomfort, sir, not much of a problem. And ultrasound showed a collection. So we aspirated.
So that is fine. So you've diagnosed it's a lymph now. So do you want to do any other? When do you intervene next, or do you just leave it alone?
That is what this patient we followed up every third day for a recurrence of collection. She had some 1 or 2 more recurrence, but again that was totally asymptomatic. So we did not do much about it. So there was a small correction of 50 ml or 80 ml. And it was not bothersome and not causing any problem to this patient. So we did not do much about it, sir.
Yeah, so the message is very clear that if you have asymptomatic collections, they may be 100 ml, 200 ml. If it's not causing any rise in creatinine, any swelling in the limb, any hydronephrosis, and you do one ultrasound, you can maybe repeat another ultrasound after 2 weeks also, because you always follow your creatinine. If there's no other symptoms, if your creatinine is normal, then probably you just can leave it alone.
So the most of the asymptomatic collections not causing any graft dysfunction should be left behind. That's what the message should be very clear.
Yeah.
Dr. Rajesh Agarwal, sir, do you have any experience of, I have not done it, but during my PG days, that infusion of instillation of some agents to look after the lymphocyte. What is your experience with that, sir? Do you do that, still practice that, or not done at all these days?
And I would just like to add, the available literature about lymphocytes says that the incidence is around 80 to 20%, taking both the donor or the recipient site, lymphocyte. But that's literature when the open surgeries were done for donor. As the electric energy sources are improving, the people are shifting towards lap donor nephrectomy. The incidence is gradually coming down. And we have a very limited experience of transplant at IGIMS, about 80 to 90 cases we have done till now. But fortunately, we didn't have any significant symptomatic lymphocyte till date. The small collections could be found on ultrasound, follow-up ultrasound, but they all resolved. There was no graft. So what the book says about lymphocytes is not that this problem is gradually declining with better magnification in better electric energy sources, so that if you are doing a lap, even the lymphatics are visualized, and that can be either burnt out or ligated.
Good. So, right, sir. So definitely the incidence is decreasing with good energy sources, as you correctly said, and taking preparation of the fossa very well.
So coming back to your question of installation of betadine,
yes,
we've
sir.
had experiences from the nephrology side, so patients who've been operated outside. So that experience has not been great. So I would probably discourage. We've got a very easy solution of marsupialization. So yes. I think installation should be discouraged. Only intervention should be a needling, a diagnostic tab, and followed by, if it is symptomatic, just proceed with the marsupialization.
Right, sir. Thank you so much, sir.
I do agree, because when I was going through the literature, there was a whole list of things, even ethanol being put in,
yes,
being put in, then this doxycycline, bleomycin, you name it, and they were just putting it some fibrinogen and talcum, whatnot. But I feel these cavities, if they are there for say 4 weeks or 6 weeks, how? I mean, they are rigid cavities.
Yes, sir.
You know, if they are that bad, the best thing is to do a marsupialization.
Yes.
Or leave it alone. Don't put things inside from outside. That is what my contention is in these cases.
Correct, sir. The message is very, very clear.
Just one thing more: repeat installation or repeat puncture, and even on ultrasound guided, carries some inherent risk of perineal hematoma. And moreover, in an immunocompromised patient, it can create infection. So either we should, if it is symptomatic, one aspiration done, and if it persists, is the problem, then fenestration, I think, is the better solution.
So I think we all agree with the thing that asymptomatic, leave it alone, single time diagnostic aspiration, and followed by marsupialization. So I think we should move to the next case in interest of time.
Sir. So the next case, she is a 33-year-old female. She had uneventful, non-stunted right fossa renal transplant. She was asymptomatic, and it was in Nadiad that we used to do Doppler, and what we found that she had a small collection. It was asymptomatic. Catheter was removed on post-op day 5. Now she came back to us after discharge with a serum creatinine of 1.3 and mild abdominal pain on post-op day 10. Sir, ultrasound was done that she already had some small collection. So it was a 150 cc perivesical collection with mild dilatation of PCS. So what do you want to do, sir, Dr. Rajesh Agarwal?
I could not get the detail of the patient. She had come with a abdominal pain and
Sir, abdominal pain, creatinine was normal, and ultrasound revealed a 150 cc perivesical collection.
And the
mild dilatation of PCS.
stent has been removed, or it is inside?
So DJ was not there. This was a non-stunted anastomosis.
Naturally, there is a collection. We have to find out what is the nature of the collection, whether it is lymphatic or it is urinary collection.
So you want to aspirate it, sir. You want to put in a needle and aspirate. So we aspirated it, and biochemical analysis revealed that the creatinine was 9.43.
So it goes in favor of urinary collection.
Correct. That is in favor of urinary collection.
And
so
more,
looking at both the cases, it is very clear when the fluid creatinine is close to the serum creatinine, it is lymph, and when it is very high like this, it is a urinary. And what you do next is catheterize the patient, because sometimes the small urinary leaks, they settle with catheterization, sir. So yes.
If the catheterization doesn't treat, I mean, the collection doesn't respond to catheterization.
Yes, that is where I am coming. What do you want to do next, sir? The collection still continues to be there.
Go ahead.
So what do you want to do, sir?
No, if the catheterization doesn't solve the problem,
yes,
you have to look for DJ stenting.
You have to look for DJ stenting.
It's difficult.
So how long do you want to wait for the catheterization to be there before you actually want to put in a DJ stent?
We have to follow the patient every day with hydronephrosis, whether hydronephrosis is coming down, whether the creatinine, what is the trend, whether it is going up, it is stable, or it is coming down. If the creatinine is not coming down, it remains above the baseline, and hydronephrosis is also there, it is not settling, then we should go for DJ stenting, either retrograde or antegrade.
So, and anybody in the panel want to differ, or would want to go with the same approach as Dr. Rajesh Agarwal?
I think retrograde DJ stenting would be maybe technically difficult. It should be tried, but better would have been antegrade retrograde study of doing a PCN and catheterizing from.
So everybody would agree that this patient, because she had mild hydronephrosis and the creatinine is on the higher side with this urinary collection not settling with catheterization, definitely either antegrade or retrograde stenting is a must. So that is what is done here. And under ultrasound guided, antegrade puncture was done.
And then you put.
And you can see that the contrast being instilled. And what you find, a very small leak at the ureteric anastomotic site. So antegrade 6/16 DJ stenting was placed, and there was a still small perivesical collection which was aspirated. So Dr. Ashish sir, you would like to take it forward from here?
Supposing, the collection persists in this situation, so you, and next day you find that the collection has become bigger, so 200 ml. So would your plan change, or would you still keep on waiting with the stent in place?
Sir, if actually in this patient it subsided, it did not reappear after putting in a DJ, and we removed the DJ after 4 weeks. But definitely yes, if the collection persists or it increases in size even with the DJ and catheter in place, she will require open intervention.
So what has been experience, Dr. Rajesh or Dr. Ajay, what has been your experience regarding these collections which are like daily? Maybe if you put a pigtail, you might have to sometimes put a pigtail drainage, and if the pigtail drainage is say 300-400 ml per day, so what has been your experience in these situations?
Well, Rajesh has vast experience. I do not have as much experience of transplants, but let me tell you, if the drainage is so much, you suspect much more than just a small problem which will heal by doing the DJ stenting. That means there is some sort of necrosis at the uretrovesical anastomosis. And in that case, if it has not healed, the thing is increasing, that means you have to do some other bypass. In our unit, we have not done it, but you can take the ureter to the native ureter and do the bypass if there is a, because don't try to fiddle with the anastomosis. It's already there and necrose. It's better to bypass it. Either you do weak anastomosis or you do ureteric anastomosis with the native ureter. What is your experience?
Since it is very early post-operative period, so sometimes mostly they settle with catheterization and stenting combined.
Yes.
You keep it there, the patient will settle down. But in rare case, it may not settle. The collection may continue to be there. And sometimes even if the drain is, you have not removed the drainage will continue. So in that case, you have to explore, because there are chances that maybe the lower ureteric necrosis is there, or there is some big defect in the anastomotic site. I remember one case. So, in fact, 2 cases. One case where there was a necrosis of the ureter, and one case where there was defect at the anastomotic site. There was a gap. I don't know why this gap was there. But in that case, we just put additional sutures over the previous anastomosis, and it settled because the ureter was healthy. But if there is if there is a necrosis of the lower ureter, then I think it is an early case of post-operative period. You should better take a native ureter and do ureterotomy. That will solve the problem, and it will be very uneventful surgery.
Yes, 100% agree with that. That early intervention is always better, because there are no adhesions, and if you want, you have the chance to fix it right away, rather than waiting and having a stent in place and a catheter in place, which with ongoing antibiotics, which predisposes to recurrent UTI. So if you think that the diversion, the drain amount is large, so better to go in early. And of course, your management will depend upon what are the operative findings. If it is only the possibility to we've done a revision of anastomosis in these situations, like putting if the ureteric length is adequate, so you just can put another ureteroneocystostomy just superior to or inferior to the previous, mostly superior because your length is getting short. And if you think there's a lower ureteral necrosis, then there is an option of doing ureterostomy, or better would be a ureteropylostomy, pelvis of the native kidney to the ureter, pelvis of the transplant kidney to the native ureter.
Okay. Right, sir. So we go to the next case in the interest of time. So this is uneventful living donor renal transplant, immediate good urine output on table. Drain and DJ stent were in place. Urine output was hourly around 1 liter per hour. 4 hours after surgery, you receive a call from your resident that there's a decrease in the urine output and the patient has got hypotension. Sir, any panelist, Dr. Vijay Kumar, are you around? What do you want to do? What do you think it is the problem there?
I think it's a serious issue. It must be evaluated whether by the urine output, it should be ultrasound should be, and Doppler studies should be immediately done, and look whether the vascularity and other things are all, is there any perirenal collection? And if there is perirenal collection, the nature of the collection should be determined, whether it's blood or...
So sir, you definitely you want an ultrasound, and actually before you start from your home and reach the hospital, you want the ultrasound to be done. So this is the ultrasound for you. It shows a large hematoma. I don't think there's any doubt on the clinical picture right now, and this patient has a large hematoma, which is almost 480 ml. So what do you want to do next?
As it is just very early after renal transplantation, there is a large hematoma. That means some issue with the your anastomosis. Then so you have to, I think if a patient is going into hypertension, it is better to explore and see any leak and see any anastomotic leak and all that.
Sir, in this particular situation, what is your deciding factor to take the patient to OT immediately? There's so many times that the hematoma which is evaluated in ultrasound is actually misleading so many times. So
if the hematoma is increasing, expanding, and patient is going into hypertension, then it is chance to.
So I'll just give you one scenario, sir. The patient, these are the findings with the patient. You transfuse 1 or 2 bloods. After that, the patient is started on noradrenaline, and after the patient becomes stable and the urine output picks up to around 200 and 300 ml per hour. So you still want to take the patient to OT, or you want to wait?
If the patient stabilizes that, then I don't think there is any reason to take him to the OT. We must observe and be ready.
Okay. So it is important then the size of the hematoma.
Hello. What do you mean by stabilization? Has his urine output increased?
Yes, sir. Urine output becomes stable at around 300 ml per hour. And even after giving 2 blood transfusions, even the NORAD dose had come down. The patient became stable. So there is a possibility that he has bled at some point of time, but now he's stable. So do you still want to take the patient to OT or wait? That is the question to the panelists.
We'll wait. But if any parameter is going to fluctuate, like the blood pressure suddenly starts going down when you are waiting, please don't wait for ultrasound and all that. If blood pressure is going down, urine output is going down, you know what was the pathology, immediately rush the patient to the theater. We have done it once and we have saved the kidney. There was a small leak from the anastomosis and it was taken care of and patient recovered. So if we are waiting, we should be ready, prepared to take the patient to theater
anytime, immediately.
Starts going down.
Raju sir, what is your experience with perinephric post-transplant immediate?
I think nowadays ultrasound is very handy, available everywhere. So there is no harm in doing immediately ultrasound. But one thing what I have seen in my experience, and I have burnt my fingers also by waiting, that if there is a situation where you want to decide whether intervene or not to intervene, you should go and intervene. Because it is very early, within 24, it is going to happen within 24 hours.
Okay.
And is virgin, you just open and see, you remove the hematoma, clear the hematoma, and if there is no bleeding, it's good. If there is somewhere some leak, you just take a revision suture and that will solve the problem. So any hemorrhage which has caused fall in blood pressure and which has caused decrease in urine output, I think we should go in and check if there is a persistent bleeding, and at least you remove the hematoma, which must be there, at least 200, 300 ml hematoma you will find. And you should clean the bed from the hematoma. So
definitely the message is very clear. When the patient has got hypertension, clinically not doing well, output decreases, and you find an ultrasound with such a big hematoma, there is no point waiting, just go and intervene. So in my personal clinical experience, sir, whenever I have intervened, I have not found a anastomotic leak. I have found a diffuse leak. So what has been the experience of the panelist in this case? How many times do they find a leak, anastomotic leak, or how many times they do not find anything and just close and come out and the patient has done well?
I have only one experience where I could not find a bleeder. In two cases, I remember there was a bleeding from the drain site.
Okay.
In one experience, I remember when I explored, there was no bleeder, and we closed, and again there was a bleeding. Again we opened, and we could not find any bleeder, and it was probably some coagulation, because we at that center we had not much of support, so we could not establish the cause of persistent bleeding. But ultimately it settled with plasma transfusion and conservative management. But there was no obvious.
I would like to add
you would like to intervene. You would like to say something, sir?
Yeah, so I mean, it's very clear. Bleeding which has caused hypotension means there's a significant amount of blood, and you should immediately go in or plan to go inside. What happens is when there is a lot of blood inside happening in an extraperitoneal space, is called compartment syndrome. So pressure is raised here, and that pressure is enough to stop your oozing. My experience has been most of the time it is oozing from your hilar vessel. So some hilar vessel has been missed, small capsular branch or something which is arterial spurter which has been spurting out blood, and with the pressure it closes off. So the moment you evacuate the hematoma, make sure that your blood pressure inside the theater is enough so that there is no recurrence of bleed in the post-op period. And a lot of times, as Dr. Agarwal has mentioned, that you may not find anything in there, right? So it probably has closed. But even then, your evacuation of hematoma helps a lot, especially for the wound healing. And if the patient goes into DGF, then you will not have problems with the hyperkalemia, which is more common with the diseased donor situation rather than a living donor transplant.
Thank you, sir. If there's a time available, I can present one more case, or we can close it here only.
We are already running late, so organizers would be happy for us to close rather than wait, but you can ask them.
Sir, just you can make some concluding comments before we close this case.
So I think there's a nice discussion as far as these three cases were concerned. So always remember that there are only 4 things which can happen around the graft. So if it is lymph, you really don't have to worry unless it becomes symptomatic. If it is blood, most of the time you should have to go inside if it is causing symptoms. And for the urine, depends upon the first preferred modality is your conservative management. If it doesn't settle, or if it is large amount of wound, the amount is large, then you probably should go in early. And in the end, I would also like to add the role of resistive indices here on Doppler. So they can tell you about that is becomes more relevant in case of diseased donor kidneys, where you may not have a primary kidney function to assess the urine output. So there, all your monitoring is done by the intra-renal indices. So if you have a collection around the kidney and your intra-renal indices change, so supposing in the immediate post-op period, your RIs were normal range 0.7, but with collection, your RIs have increased. So that again becomes another indication if you have no tool to monitor as in urine output. So I think with that, I would like to thank Vikas and all the panelists who contributed to the discussion. And thank you for the organizers to have us all here in this meeting.
Thank you, sir. Thank you, everyone, for the wonderful discussion. Thanks, organizer, for the opportunity.
Thank you. Thank you, sir, for that excellent panel discussion, sir. Thank you very much. Thank you. So we move on to the next panel discussion. And to moderate this session, I would like to call Professor Sandeep Guleria, who doesn't need any introduction. He's a senior surgeon, transplant surgeon, past president, Indian Society of Organ Transplantation. And I would also like to invite Dr. Ajay Oswal, Senior Consultant Urologist from Aurangabad. Sir, please up. And I would request Dr. Rajesh Agarwal, sir, to be seated there. And I would also like to invite Dr. Anil Kumar, another very senior transplant surgeon, past president of Indian Society of Organ Transplantation. Dr. Harsha Johari, senior consultant urologist from Sir Gangaram Hospital, New Delhi. Dr. Amit Deora, senior consultant urologist from Noida. Dr. Apurv Chaudhary, senior consultant urologist, transplant surgeon from Patna. Dr. Rohit Upadhyay, additional professor, Indira Gandhi Institute of Medical, additional professor urology, Indira Gandhi Institute of Medical Sciences, Patna, and a transplant surgeon. Dr. Baldev Olak, senior transplant surgeon from Ludhiana. And Dr. Prabhat Ranjan, consultant urologist from Medanta. I think he's not here. So over to you, sir.
Respected teachers and dear friends, I know I'm holding all of you away from your flights and the day's rest, but the task given to me is quite serious. That is perfusion issues. By perfusion issues, we mean that kidney is not getting perfused either in the donor or in the ice slush or after the clamp release in the recipient surgery. There are few very disastrous experiences which some of us have seen in our careers in transplant. So let us share our experiences with you. I welcome all the panelists who are all highly experienced in renal transplant and need no individual introduction. So let us proceed straight away with the cases. So when a disastrous complication occurs, sometimes we win the battle but lose the war, and vice versa. In spite of losing the battle, we may win the war. Let us see how. Presentation, presenter view. Vascular clamps. So sometimes battle won, but war is lost. Sometimes battle lost, but war is ultimately won. Let us see how. These are some funny examples of what I have been trying to tell you. Here, in spite of hard work of years together, almost there, but see what has happened.
Not playing, Ajay. The movie is not playing.
So ultimately romping home. So let us straight away proceed to the first case. So kidney was retrieved from an elderly donor, put in the ice slush. But our colleague says, come here, unable to perfuse the kidney in ice slush. It's not. See the video carefully. Red kidney, but see the periarterial tissue getting distended and fluid not going into the branches of the renal artery. This is the most disastrous complications of our career. Kidney not getting perfused fluid, not going in and not coming out of the vein, which we should see classically and give us some comfort.
We are not able to see.
This is living donors.
There is no film.
So, Professor Rajesh Agrawal, you are here. Can you enlighten us? How could this have happened?
See, in this case, I feel there is a dissection with the tip of the cannula, because you see the distal part of the artery is blanching and it is enlarged, white, with apparently some edema also. Probably the tip of the cannula has dissected the intima, and that is the cause. The intima has lifted and it is blocking the.
Yeah, you may be right, but I'll share you one of the details of the operative procedure. During living donor retrieval of that elderly donor, there was some undue traction on the kidney, and the renal artery had gone into spasm. It did not become blue, but with very gentle attempt at pushing the cannula into the artery, it did not go. An attempt at flushing resulted. This is not the injury why occurred during perfusion. The intimal dissection occurred during retrieval, traction. No, sir. Elderly father donating to son, quite bad atherosclerotic vessels. Due to shortage of time, I'm not showing the angiography picture. So, my next question is to Professor Sandeep Guleria. Is he there on the panel?
Yes, I'm there, sir. I'm there.
Pardon?
I'm there, sir. I'm there.
Professor Sandeep Guleria, can you hear me?
I can hear you, sir. I can hear you, sir.
Unmute yourself, Professor Sandeep Guleria.
Yeah, I'm unmuted, sir.
Okay, we'll go to Professor Harsha Johri. Professor Harsha Johri, can you hear us?
Yes, I can.
Sir,
can you hear me?
Johri, there is a dissection of the intimal dissection of the renal artery during retrieval in the video. How do you prevent such accidents? That is the first question to you. And second question goes to Professor Anil Kumar. Now we have landed in deepest of trouble. How do you propose to rescue me out of this shit? So Professor Harsha Johri.
So I will concentrate on the prevention. The prevention is excessive handling, too much of stress, and causes spasm of the artery, and also causes intrarenal spasms. Along with that, what happens is that the intima starts getting stretched. Also, what happens is you start having little platelet aggregations, and inside in the renal artery, you get some debris or clots. When the patient comes to you, when the kidney comes to you for perfusion, the artery already is in spasm, and there's this tendency of putting your cannula straight into the artery without even trying to gently dilate it. Now, the first thing to do is a gentle dilation of that artery, or maybe even a reverse perfusion from the vein at low pressure. It can be done, and it tends to unclog the renal artery. Second is direct the jet of fluid into the artery without putting the cannula in. That tends to flush out some of the debris which is inside the renal artery. And once you have got the right size of cannula in to the renal artery, and then the vein, you have got your perfusion, the kidney may still be soft. And please do not try to force anything. People are there who are trying to force the fluid into the kidney by putting a blood pressure cuff. You know, and the kidney is not, it's a denervated kidney, and we end up doing more damage than good. So the intima starts getting torn.
They let us in. Already they let us in.
So I think the best thing is accept the fact that the kidney has got a damage, or there's a spasm. The kidney, you can feel it and know that it is soft. It is not getting perfused properly, but at least the effluent is clear, and the renal artery and the veins are taking the fluid in and out. Be prepared for that, and then over to Dr. Anil Kumar for how to repair the intima. That's what you asked, I suppose. Yeah.
Hello.
Professor.
Can you hear me?
Hello.
Yeah, can you hear me?
Yes, we can hear you.
Audible, you're audible. Hear you, Professor Anil Kumar. Please go ahead.
Yeah, I was listening to the most probably while cannula is being probed into the artery, there is an intimal dissection. So there is
Can't hear you.
We
can't hear you, Professor Anant Kumar.
You have to fix the intima. So you take a suture, go
Sir,
from inside out.
Anant Kumar, we are unable to hear you. I request you to stop.
Yeah.
Okay. Dr. Rohit, now we have landed with an intimal dissection of the artery. Just to bail me out.
Sir, I think Dr. Johri raised very pertinent question.
Hello.
Prevention
Can
is-
you hear me now?
Yes. Yes, sir, we are able to hear you.
Yeah, I was saying that since you have realized that intima is dissected, it should be fixed. And to fix the intima, you take 60 or 70 proline with both the needle go inside, from inside out you come and then tie it gently so that it should not.
No, Dr. Anil Kumar, I am
Intima will get fixed. And once the intima is
So, Dr. Apurva, how do you identify the true lumen of the arteries? Once there is dissection, the true lumen of the artery is lost to you. Now, how do you get into the proper true lumen of the artery so that you can take repairing or quilting sutures and then rescue yourself? So, how do you identify the true lumen after this disastrous complication has occurred?
One way can be, sir, we can try holding both the sides of the adventitia gently, opposite 6 o'clock and 12 o'clock, and gently separate them. Sometimes you can see the intimal lumen there. Otherwise, as sir said,
Hello, I'm Dr. Baldev Singh on it.
the venous side,
I'm a faculty for this session. My video is off.
irrigation fluid from the lumen will be evident. That can guide us towards the.
So one more point I want to add here is you just go on transecting the renal artery half or 1 millimeter by millimeter till you see the normal lumen, and then you are in safe zone. So I'll stop this case here. And Professor Sandeep Guleria, you are there?
I'm there, sir. Very much there, sir.
So over to you for another case which is similar in nature. Please proceed, sir.
I have the first slide, sir. Yeah, this is the first slide. This is a 60. Am I audible?
Yes, please.
This is a 66-year-old diabetic, borderline diabetic donor who had severe atherosclerosis. His kidney was harvested. It perfused well on the bench. When we came down to doing the anastomosis in a 64-year-old recipient, this was a wife giving to a husband. We reperfused, but there was no flow distally. So my first question is to Dr. Baldev Olak, who has now come on. Baldev, what will you do now?
Sorry, Guleria, my video and the audio started just now. Can you just repeat the question?
So 66-year-old marginal donor came up with severe atherosclerosis as a donor for a husband. We took the kidney out, perfused well on the bench. We anastomosed it. When we anastomosed it, there was absolutely no flow after a small segment, which meant we in all probability were looking at a renal artery dissection.
Probably this dissection has happened and it is the thrombosed artery. It is better to clamp again and take out the kidney, perfuse and see the intimal dissection and go up to till the normal renal artery is found, and then take that cut that wasted artery or dissected artery. Then if you are able to anastomose internal iliac artery with the renal artery, it is good. Otherwise, you will have to take some graft.
So that's exactly what we ended up doing. I think this is what the cut segment. These are not my own slides. These are slides from literature. But as you can notice, the artery was resected out. and the distal artery was then resected. However, sometimes you are unable to find a good distal length, a good length to anastomose. And in that case, it is recommended that you can sometimes use what is called as a Dacron graft. As you can see here, two arteries have been joined end to end to a Dacron graft because the dissection went really very distally. It's also important to remember that dissections may not present immediately, they may present even later. And if they present at a later stage, you could ask your cardiac colleagues to go in and put in a stent. So essentially, can I have the next slide? Next slide, please.
This is your last slide for this case.
Right, sir. So I'll hand the mic back to you, Ajay, for the next case.
Okay. So this is another, please see this picture very carefully. These are the deceased donor kidneys imported from another center. We were very wildly excited that today we have received 2 kidneys in the package, in 2 different packages, because no other hospital had a eligible waiting recipient. We had a lot of them. The kidneys were allotted to 2 of our waiting listed recipients. We were quite excited to do 2 transplants in the same night, but to our horror, this was the picture. So, Dr. Rohit, can you please enlighten me? This is the picture after we have opened the package of each kidney. These are deceased donor kidneys. What abnormality do you find here?
Issue with the vein.
No, sir. There is no issue in the vein. There is no issue in the artery, and there is no issue in the ureter. If you allow me to speak, I'll.
Yes, sir.
No. So I'll tell you what has happened. These are bluish, blackish kidneys. They should look plum white.
Yes, sir.
So some disaster has occurred either during retrieval or perfusion during the retrieval, or the recipient had some pre-retrieval issues. Let us see what were the issues. Probably Professor Sunil Shroff, who is here, we are honored to have him here. Sir, these are deceased donor kidneys which are bluish, blackish. Can you tell us what must have happened here? Actually, this is what has happened, but you may enlighten us more.
Thanks, Ajay. Sometimes, when you are doing donation, sometimes the graft goes into primary dysfunction and never recovers. It's a gone graft. And many times, if the multi-organ retrieval I've seen, if you don't save your kidneys, they're not perfused on the table, inside of perfusion, then it looks like some blood has clotted inside. And that's why nothing is going in, nothing is coming out. These kidneys are gone, to be honest, from my side. When I see these kidneys, there are 2 disasters which I hate in disease donation. One is this color which I see. I've only seen it once in my lifetime. I couldn't use those kidneys. I don't know if you tried to use these kidneys or not, but I didn't use it. The second time I find disaster is when ice is packed around the kidney and the kidney is totally frozen like a hard rock. These 2 disasters in disease donation do happen in a new program. I've seen both the disasters happen. When the kidney is frozen, hard kidney, sometimes it will work. We have used that, but this type of kidney we never used. And when you're doing multi-organ donation, you must be in operation theater. You don't let the liver guys take your kidneys. You must be there in the theater and make sure that the kidney is perfused in situ properly. Kidney is pale when you take it out. If you're going to do an en bloc, sometimes you do en bloc when a disease donor is unstable. That is also the time when this can happen. So both block rapid retrieval can happen. This also can happen in DCD donation sometimes. When you exceed the time of half an hour, 75 minutes to take out the kidney. So there are multiple situations in which you can encounter this kidney. In a new program, if you start, You must get trained on how to retrieve kidneys before you start your cadaver program. This is my message.
Okay. So the most important thing here is the history in the recipient. He had CV, persistent hypotension, large doses of multiple pressure supports, recent cardiac arrest and resuscitation. His terminal creatinine was 2, and liver and heart team had refused retrieval. So probably either pre-retrieval graft primary dysfunction, or during cannulation, some disasters with a novice surgeon can occur. So my message here is, we cannot control the pre-retrieval conditions, but we can control the intra-retrieval proper cannulation of the aorta. Exact technique should be known to each one of us.
If the patient has had multiple cardiac arrests, then again, of course, it can happen. But normally, if the patient is in hypertension also, if he not had cardiac arrest, even in cardiac arrest, if he revived, it will only look like this if cannulation has not happened.
Yes.
Kidney clotting happens beforehand.
Or
before you retrieve, you should get 20,000 units of heparin.
Exactly.
So if you're not given that, then again it can happen.
Yes. So exact technique of cannulation and pre-cannulation heparinization. These two are surgically most important things in disease donor retrieval. Professor Anil Kumar, are you there? Dr. Anil Kumar.
Yeah, I'm there. I'm listening.
Sir, how should a cadaveric kidney look and feel?
Yeah, that kidney should look pale, nicely perfused. There should not be any blue patches, and it should be looking like a pale kidney. And when you try to flush it, you again the clear. If you start to flush it, again that colored fluid is coming out. It means kidney was not perfused, or there was something wrong.
Yes, sir.
This kidney might have had some problem.
Stop in the interest of.
And that's why it couldn't be perfused.
Yes, sir. Thank you. So, Dr. Apurva, will you take both these kidneys, one kidney or none? What would you do with these kidneys?
Not done transplantation in such cases, but definitely this kind of a kidney, if it's not going to work, then there is no benefit in using this.
So one of the recipient took that risk. One of the kidney was sent to histopathology, which reported as severe cortical necrosis, and similarly the another recipient and family and his nephrologist accepted that kidney. It was transplanted and ended up in a disaster. We had to remove it 72 hours later. So we had to remove that kidney since we observed that he was going into DIC. So Professor Sandeep Guleria, over to you for the next case, that is suspected renal artery kinking. Please take over, Professor Guleria.
Thank you, Ajay. So this is a 56-year-old obese deceased donor. The right kidney was harvested, and we put it into a 16-year-old recipient who weighed only 32 kgs. Remember, the deceased donor was more than 100 kilos. Kidney reperfused very well. We had very good urine. But on the first post-operative day, when we got a scan done, it showed diminished flow with some idea of maybe a kink in the artery. So I'm going to ask Dr. Amit, where are you? Are you there, Amit?
Hello.
Dr. Amit is not here.
Yes, sir. Can you hear me?
Yes, I can hear you. Can you come? Have you heard me, or you want me to come again?
Yeah. You have told that there is a possibility of kink. So whenever there is a possibility of kink, we have to immediately go in because this is the time duration. Earliest you will go in, the better there is a chance that we can.
We are unable to hear you, Amit.
So, right, is
always this graph.
Dr. Sandeep, can I request you to direct this?
So there is a need to re-express.
Who do you want to direct
exactly
this
the kink is?
So, hello, Dr. Shroff, if you're there, can you?
Hello,
Dr. Amit, we can't hear you. We're having a problem with audios, and I think which could end up being our last hybrid meeting till we get everybody on stage, because there is a problem hearing people, and I think the signals are clashing. Is Dr. Sunil Shroff or Dr. Johri there who would like to take this on?
Dr. Johri is there.
Yeah, I can. Can you hear me?
Yes, we can hear you, Harsh.
Yeah. See, the question you raised.
Someone is connected to instruments.
Can't hear you, Harsh.
Analyst has to shut off his mobile phone.
Can you hear me?
Yes, Harsh, come on now. We can.
Yeah, whosoever is disturbing, please shut him off.
See, if we are talking about the possibility of kinking of the artery, that usually would take place on the table once you have closed it and suddenly a urine was coming and it has stopped. Large kidney, small fossa, things like that. Once a kidney has started getting a perfusion, 24 hours later, a kink is not very likely.
So
not 24 hours later.
It doesn't usually happen like that. It can have multiple presentations. It could present on the table when you close up with a drop in urine output.
Absolutely, yes.
Both the cases that I'm putting forward into at the moment is one who's 3 days post-transplant. This is a case that we reported in NDT, and I can notice an acute kink in the renal artery. This is a cadaver donor. The renal vein of the right side was very short. The artery is always long. So you've got to be careful how you place your vessels, and you can see the angio showing 2 kinks in the artery. We went further. Can I get the next slide?
That point is well taken.
Yeah, I'll just go on. We got a cardiac guy, and he stented the entire thing, and the patient went home with a normal creatinine. Next, please. This is another one, and you can notice the MRI showing you an acute kink. This was referred to us from outside for a transplant. Next slide. And this, we thought, the cardiac guy said, look, I can't do much about it because it was taking off from the external iliac. So again, we had to re-explore. This is the one we re-explored almost 4 or 5 days after the surgery. Kidney has flow, but it's not sufficient to get the creatinine down. Perfused on the table, swung the internal iliac and joined it.
Another good reason to use the external iliac artery.
Absolutely, absolutely.
Yeah, which is what I've been doing for the past 35 years. So another good reason to do the external rather than internal.
But I was just wondering, I think the take-home message really is that when you do your anastomosis, you must make sure, see the way the kidney is going to lie on the bed. And once you're sure, then plan your anastomosis. Dr. Shroff, you have something to say?
Yeah, I think, this is good experience you shared. I had one experience like this in England. And this was the right kidney. With right kidney, the artery is very long, the vein is short, as you said. And you need to trim the artery, especially if you're either putting an external iliac or internal iliac, and make sure that the match is correct. Otherwise, you need to plan your anastomosis in such a way the kidney is comfortable and the length matches. That's why when you take a right renal, right kidney in a cadaver, if you are able to get the IVC and get your right renal vein long, then the problem is less.
Yeah, so the problem is, Sunil, sorry for interrupting you.
Matches with the internal, with your renal artery kind of length. It absolutely matches, and the right kidney transplant goes easier than the left kidney transplant.
Yes.
Yeah, it's just that you have a Carroll's patch, so you don't want to dissect the artery because it makes it more difficult. That's the reason you end up using the longer artery.
Just to preserve your Carroll's patch, you increase the length of your vein.
Absolutely, absolutely.
Because if kink happens and if it loops after the anastomosis, and the kidney moves a little bit in the post-op period, then the kink can happen quite, it has happened to many of us. So now what I do is I do sacrifice the Carroll's patch if required in a cadaver. If I don't get a long length of the vein, then in that case, I'll, sacrifice the Carroll's patch and then put it on the external iliac. That's what I do. I learned from my lesson in England once when we did exactly the same thing. I kept the Carroll's patch, the vein length was short, I anastomosed it, and it kinked.
So, thank you, Professor Shroff, for those words of wisdom.
And Guleria, may I make one comment?
Guleria, you want to say something more?
Yeah, Dr. Olek wants to make a comment. Yes, Dr. Olek.
Yeah. This is a common problem sometimes when the renal artery length is long, even on the left side. So in my experience, I see if after anastomosis with internal iliac artery and renal artery, if you feel slightly length is longer, then anterior abdominal wall is lifted, peritoneum is mobilized. So you put this peritoneum and cecum enclosed beneath the upper pole of the kidney, and mild kink is gone off, and your results are very good.
Yeah, I think that's a very good idea. Maybe you should report this as the ECI modification for kidney.
Yeah, I have been doing this number of times.
Okay, thank you very much, gentlemen. Can we, if time permits, move on to one more short case? Dr. Harsh, can we move on to one more short case, or should I stop here in the interest of time?
I think we can stop.
Okay.
We can take one more.
Okay.
Sandeep,
sir,
okay.
You are looking quite similar to the photograph of the Don behind you.
Oh, Harsh, it's a Sunday afternoon. It's the gin and tonic.
Okay. So, so the Don has made a proposal which you cannot refuse.
Anytime.
I cannot.
Okay. So, this is a living donor retrieval from an elderly lady. And after flushing the kidney, some of the kidney has become completely white. And there is a definite subcapsular hematoma here. So, we transplanted the kidney. The kidney was perfused very nicely, and there was brisk, abundant diuresis. Now, Dr. Rajesh, will you drain this subcapsular hematoma, or will you leave it alone since everything is perfectly fine?
I like to just make a nick over the capsule of the kidney over the hematoma, so that there is no pressure effect of that hematoma on the pelvic.
See, there is no pressure effect. The blood pressure of the patient is normal. The kidney is perfused so well, and there is brisk diuresis. So there is the hematoma is neither troubling the patient nor the kidney. So why do you want to irritate it unnecessarily?
This hematoma can expand. Thinking that it may expand, already the capsule is lifted from the parenchyma. So if you make a small nick on the capsule, it is not going to make any problem. It is not going to bleed. So to be on safer side,
got your point. So Professor Harsha, do you agree with Dr. Rajesh, or you differ with him? Harsha Johri, sir.
You're asking me? You're asking me?
Yes.
Hello?
Yes, we are asking you.
You see, if there is a hematoma, it is for one of two reasons. Somebody has avulsed a small capsular branch, which has gone subcapsular, or you have a bleed from the kidney surface itself because of whatever reason. So, to sit and hope that this bleeding is just going to disappear, it will not. So, make a small cut, as he has mentioned just now, deflate that hematoma, and if you can pick out which particular spot is bleeding, give a little diathermy, that will stop it. But to leave it as it is, you are risking that the hematoma might increase, and then you will have problems.
Okay, got it.
I would definitely on the table do what I can.
Okay, Dr. Anant Kumar. Dr. Anant Kumar, are you there?
Yeah.
Sir, again, we are unable to hear you. So, Dr. Baldev Singh ji.
Hello, yes.
Would you leave the hematoma alone, or would you drain the hematoma?
It becomes reassuring if you just drain it out and so that everything is okay. I don't think you can find the bleeder, as Dr. Harsh has told, that you cauterize it. It is not. It is very unlikely. So just give a small nick, see whether this hematoma is evacuated, nothing further bleeding is taking place, and then sleep over.
Okay. Our team did not agree with you. So our team decided not to open the capsule and drain the hematoma. The patient was shifted to transplant ICU, and 3 hours later, the patient became anuric, severely hypertensive, and Doppler showed reversal of diastolic flow. All the parameters were in favor of reduced cortical perfusion, and the expanding subcapsular hematoma was there. Dr. Apurva, now what?
So, sir, now, sir, we should definitely take the patient to the operation theater and open the capsule over the hematoma and drain it out.
Okay. So, Dr. Rohit, this is the intraoperative finding. This is the hematoma. We have incised the capsule, drained the hematoma. There was a large hematoma, and this is the denuded, decapsulated kidney. All hemostasis has been excellent now. We just burnt a few bleeders with the help of diathermy, which in this situation is an excellent tool. Now, this bare kidney, what would you do with this bare kidney? Again, leave it alone or do something to it?
No, sir, 2 points I will make. This is a very good thing that you should always make a very large capsulotomy.
Okay. So
And
we had
covered with the
completely
fat.
denuded. The whole capsule has gone and now it cannot be brought back together.
Sir, if it is not oozing, you can leave it or you can just cover it with some surgicel and come out. Or you can take some fat
Or
around.
can you leave it alone or wrap it with something softer like peritoneum? Because
Yes, sir.
surgicel, vagare, they all can tend to cause fibrosis around the kidney, and in many years later can give rise to chronic page kidney.
Yes,
So
sir, that is
would
what I'm
you,
saying.
if there is no bleeding, would you like to leave this?
If there is no easing, I will like to leave, sir.
Okay. So
I would like to.
why, sir?
Kidneys are very soft, very friable, and you can easily use peritoneum. It will only take 10 minutes. Peritoneum is lying there. It's a natural substance. This I have done twice in disease donation when there was no capsule at all. And I find those kidneys, I get a little nervous when I see a kidney which has got no capsule because they're so friable. They can be easily traumatized.
Fractured.
I like to cover it with peritoneum and I find it very easy procedure. And both the times when I did it, I slept very well. I can't tell you why, but I'm a little nervous with these kind of kidneys when they're so soft, they're so friable. In case the third day biopsy happens by a dear colleagues nephrologist, what will happen to this kidney? Again, I'm a little worried. Third days, early biopsies are now happening more and more commonly with the nephrologist with antibody-mediated rejections, third day, fourth day. And actually, I've had 2 times post-biopsies, almost a disaster of losing the graft. Post-biopsy.
Why?
Because there was so much of bleeding after the biopsy. The blood pressure fell down. One happened 5 days after, both for disease donation. One happened 5 days after, and one happened 10 days after transplant. And in both the cases, we had.
That's very rare. It's very, very rare to lose a kidney post biopsy. In fact, I can't remember.
I'm only talking about my experience, Sandeep. I know it's very rare, but those rare experiences teaches you certain.
Absolutely.
And those
Sir,
certain
where
lessons.
do you harvest or retrieve the peritoneal graft
Very
from?
nice question.
And how much? It's a big kidney.
Yeah. It's very simple. Most of the time the peritoneum is bulging towards you.
Okay.
So I just take an ellipse of that area and then put it back. It comes back very, very comfortably.
You are able to close the peritoneum?
Absolutely. Both the instances I was able to close, and there's so much of peritoneum there, to be honest, because most of the times it's bulging into the whole space. So both the times I took the peritoneum like an ellipse and very comfortably put it around the kidney. There is some, capsule available of the kidney itself at the periphery. It's not all lost.
Yes.
So I use those and just do some continuous, sutures or some interrupter sutures. It is all done. It's not a very difficult thing to repair.
Okay. I thanks all the senior teachers and my colleagues and friends for their words of wisdom and enlightening us and taking us through some difficult situations. Professor Ajay Kumar wants to add something.
Well, I don't want to add something. I just want to say hello to my good friends who are on the panel. Harsh.
Yes.
Dr. Ajay Kumar. And saying hello to you. Seeing you after.
Yes, hello to you too.
Where is Sandeep? Oh, yeah.
Yes, sir. Thank you for your blessings.
Photograph. Sometimes you come down, sometimes you go up.
No, sir. I'll come. I thank you for your blessings. What a pleasure to see you, sir.
Lovely. And Baldev.
Sir, yes, sir.
Nice to see you.
My elder brother.
Really nice to see you. Well, thank you very much. We had a very nice time.
Thank you so much.
So I think we must thank all the participants. Thank you for thank you for coming together. Thank you, Sunil. And I'll hand over the mic back to Harsh or to Manish. Thank you.
Thank you, sir. Thank you. That was a wonderful panel discussion. Thank you, the panelists. Thanks. So my apologies for running late. So we move on to the next session. And to moderate this session, I would like to call Dr. Manish Balwani. He is a consultant nephrologist from Nagpur and Joint Secretary of Indian Society of Organ Transplant. And I would also like to call Dr. Divya Vajpayee. She is a faculty at KEM Hospital, Mumbai, a senior consultant nephrologist. So over to you, moderator. And I would also like to call the panelist, Dr. Orge Majumdar. He's a senior consultant nephrologist from Kolkata. Dr. LK Jha. He is a senior consultant nephrologist from New Delhi. Dr. Dharmendra Prasad, nephrologist, senior consultant nephrologist from Muzaffarpur. Dr. Santosh Kumar. He is a consultant nephrologist at Paras HMRI Hospital, Patna. Dr. Prem Shankar Patel, assistant professor nephrology, IGIMS Patna. And Dr. Deepak Kumar, consultant nephrologist at Mediversal Hospital, Patna.
Welcome everyone. We have an august panel to discuss a very, very contemporary and a very, very important topic. I welcome all the delegates to this very special panel discussion on the topic of how to overcome the challenges of COVID-19 as a barrier of transplantation. We all know that COVID-19 is still here, though the waves have flattened a bit. And also in future, we have risks of many such more infective pandemics coming. So let's learn from whatever we have done and try to move ahead. Without much ado, I would like to put my first question to Dr. Arghya Majumdar. In this COVID-19 pandemic era, how do you screen recipients and donor for COVID-19 prior to transplantation? Do you always do HRCT within 24 hours or do you have any other protocols? Please, sir.
Hello.
Yes, sir, you are.
Can you hear me? Yeah.
Yes.
I thank the organizers in Patna for letting me join virtually the ISOT. Now, your first question is very important. So we, both for the donor and recipient, first, we obviously look for symptoms of any fever, cough, anything related to COVID. And also, we take a history, whether in the last 2 to 3 weeks, there have had any symptoms of COVID or have been exposed to any COVID-19 patients. Usually, they are recommended in live-related transplant. They are recommended to quarantine for 14 days before the transplant. So there is no chance of infection in between in the last 2 weeks. After that, they are usually tested by RT-PCR, the CVNAT. Both the donor and recipient are tested. And if it's only in cases of kidney transplant, upper respiratory samples are enough. It's only in cases of lung transplant where we need lower respiratory samples. And this is as far as live-related transplants are concerned. In deceased transplants, within 72 hours of the transplant, they should have upper respiratory samples tested for RT-PCR. And UK, guideline, they suggest taking lower respiratory samples as well by bronchoalveolar lavage. But the American Society of Transplantation and the OPTN, guidelines, they just suggest taking upper respiratory samples. Now, a chest X-ray is mandatory, and that should suffice in both the donor and recipient. Now, unless the patient has any symptom. Now, even if they have the very minutest of respiratory symptoms, then I think we should go ahead and get a HRCT done. But HRCT routinely is not mandatory.
Okay, thank you, sir.
Thank you.
My next question is for Dr. LK Jha. How long one should wait for live organ transplantation if someone has contracted recently COVID-19?
Right. I also first thanks the organizers for inviting me for this panel discussion. My hometown is Patna, but for some other reasons I could not come and physically attend it. That post-transplant in that scenario with the COVID in, the mortality is definitely was high that we have all experienced between, the mortality would have been between 10 and 15% in various studies. And so that is the time period that we want the patient to recover from COVID and then go ahead and do the renal transplant, at least in the live related ones. So there were some guidelines initial phase. It was coming from the American Transplant Association. And that one thing is definitely the patient should be asymptomatic from the type of respiratory illness. That is one. We should have at least 2 negative. This was the initial phase that we were doing during the second phase in the first wave of this phase, the Omicron one. We were not that particular of 2 reports, and we were doing with 1. But then the guidelines came like that. So 2 negative reports within the 2 weeks prior to transplant, and at least one of them very near to the transplant. That was like within 48 to 72 hours of. So that was the second criteria. And 28 days after recovering from the COVID positive. So these 3 were the guidelines. And finally, there was one anesthesia group also, American Association of Anesthesia, which were categorized depending upon the severity of COVID. So they had given like 4 weeks for asymptomatic or very mild non-respiratory, for around 6 weeks for patients who were, they were not hospitalized, but some respiratory symptoms like cough and all. 8 to 10 weeks for a patient who was hospitalized, and around 12 weeks for a patient who went into ICU. So that was the time duration they had given as a guideline. Then our own ISOT consensus guideline was also there with Dr. Kute. He's already there, and other members of the same consensus team is there. So that was and they had given 5-6 guidelines that way. One was that COVID appropriate behavior has to be followed, like hand hygiene and distancing and other things. That was one. Then this patient should be asymptomatic for 28 days. That was second criteria. 2 negative report. That was the third criteria. They should have a normal X-ray, which anyway we get it done in the pre-transplant workup. And if there was some abnormality in the previous CT, then we had to have a repeat CT as well to have a normal CT as well. Then there should be an informed consent from the donor and the recipient both. And that could be a multidisciplinary team effort. That the cardiopulmonary risks are higher. So at least those 2 persons, those 2 teams should be there in the explaining the risk and the benefit. So I believe those are the time duration. If you ask me, minimum is 28 days and maximum it can go up to 3 months, 90 days that is. So this was the time duration, but there should be negative reports, 2 negative. Now we are going with 1 negative report. Also, if it was more than 3 months old. So that's what I want to convey, right? Thank you. Any other queries that we can take up?
Thank you, sir. That was that completely justifies the question. So my next question is to Dr. Dharmendra Prasad. What should be the ideal induction protocol in the recipients who have recently recovered from symptomatic COVID infection? Like Dr. Jha was telling how much we wait, but when we transplant them, then what should be our induction protocol? How do we manage the immunosuppression in these patients?
Good afternoon, everyone. Thank you, organizing team, for incorporating me as a panelist in this wonderful session. As we for the induction protocol in COVID recovered patient, this depends on the 2 factors. First, what is the institutional practice of using induction agent, and immunological risk profile of the patient. So patient who have the high risk immunological risk, in that scenario, again, induction agent should be used. That depend again on the institutional protocol, and in a low risk profile, or sometimes there is a high matched in between the recipient and donor, induction agent cannot be used. As recently is recent published study by Dr. Vivek Kute, they have not used any induction agent in well matched recipient and donor. So it's depend on the institutional practice and immunological risk profile of the patient. Thank you.
Thank you, sir. Our next question is for Dr. Santosh. Sir, as we have recently encountered post-COVID fungal infections in hemodialysis patients also. So if they have the suitable donor, then when can we safely take them for renal transplantation? What should be the waiting time after fungal infection, after COVID infection?
Okay, as we know that COVID infection is an immunosuppressive state, and also we know that the end-stage kidney disease is also an immunosuppressive state. So COVID infection with in patient of hemodialysis, definitely further immunosuppressive state can lead to further fungal infection, as we know. And on top of that, if there is the patient is of diabetes mellitus, then there is high chance of fungal infection. So depending upon the clinical situation, we can divide the patient into three or four categories. The first one is like having mild COVID infection, don't have any prolonged stay or no requirement of oxygen. Then in that case, we can take as that of normal patient, like 28 days of waiting period. After that, definitely after RT-PCR negative, 2 RT-PCR negative, we can take them for transplantation. The second case is like severe COVID, moderate to severe COVID, and with diabetes mellitus, with prolonged hospital stay and on ventilator or requirement of high immunosuppressive steroid. So in that case, the waiting period should be without any evidence of any fungal infection. So in second case, we can wait for at least 3 months, although there is no such guidelines are there. But as Dr. L.K. Jha told, so waiting period should be more, and definitely there should be extensive search for fungal infection. Like as we know that rhinocerebral mucormycosis is more common. So we should definitely go for CT-PNS, and for atypical pneumonia, HRCT of the chest should be done. And depending upon the situation, like galactomannan and that D-glucose test to be done to rule out aspergillosis also. So the third scenario in which COVID patient who have fungal infection, invasive fungal infection like mucormycosis, in that scenario, I don't know what to do, but definitely should not be to do transplant or not to do transplant should be balanced. I think more than 6 months or 1 year, I don't know. Particularly, I would not go for transplant in that patient. Okay.
Thank you, sir. So switching gears, now let's discuss the very important topic of COVID-19 vaccination in kidney transplant recipients. And my question is to Dr. Prem Shankar Patel. So what is the policy of COVID-19 vaccination against SARS-CoV-2 in kidney transplant pre and post-transplant?
Okay, thank you, ma'am. At our center, we are following the guidelines laid down by NOTO and adopted by SOT guideline in 2021, which is published in IJT or IGN. And we try to give the complete 2 dose of vaccination at least minimum 2 weeks beforehand, or if any patient who have not vaccinated and get the transplanted, we waited for the minimum 4 week or 4 to 12 week post-transplant to get the complete 2 dose of vaccination. And nature of vaccine, whatever vaccine is available, we counsel to take whatever vaccine is approved or available in that region. And second one, we counsel to get vaccination to all close contact, and even we maintain the complete vaccination status of our healthcare, particularly depicted in our KTU, which removes close contact in the recipients or in donor. Thank you, ma'am.
Thank you.
The next question is very tricky. It is for Dr. Deepak Kumar. So, Dr. Deepak, if the deceased donor is incidentally detected with the COVID-19, supposedly he has road traffic accident and is declared brain dead, now his RT-PCR is COVID positive, and the relatives are willing for organ donation. So this is a tricky situation. What should we do now? Whether to proceed ahead with organ transplantation and which organs can be transplanted?
Thank you, sir. Actually, I don't know the exact answer of this question, but it has been proven through several randomized control trial, all the case series reports, that donor-derived COVID-19 infection is mostly seen with lung organ transplant, from the lung organ, if the lung is used as a solid organ. But all of the published data and from the case series report, none of the recipient has shown donor-derived COVID-19 infection while using non-lung solid organ. You are talking about a scenario in which incidentally the donor is positive without any known prior history of COVID-19. So in that case, something should be taken into the account if suppose transplantation is planned, like what will happen to the recipient, what will be the risk of mortality if he will not be getting this organ or he stays on the transplant waiting list. Second, doing such kind of very tricky transplantation not only increases the chances of donor-derived COVID-19 infection to the recipient, but also the organ procurement organization, transplant team members, and the close relatives of both recipient and the donor recipient will be under scan for COVID-19 infection. In this kind of tricky situation, an expert opinion from infectious disease expert should be taken into the account. But all the collective data which has shown till now, and it has been also recommended by the CDC, last year from March 2021 to August 2021, total 178 solid organ transplant from COVID positive disease donor was done. Almost all the recipients who got donor-derived COVID-19 infection was seen in those recipients who got the organ from lung. But in special circumstances like a recipient who is not getting a proper donor, who is highly sensitized, or there is access failure, multiple access failure, then in that case, on case-by-case cases, if a strict COVID-19 protocol is being taken, then in that case, kidney transplantation can be done if there is no any alternative options available, sir.
Dr. Deepak, is there any role of organ biopsy, for example, say for kidney? Should we do biopsy in such cases to rule out viral? Yeah.
If the age is circumfund, if suppose age is more than 65 and the terminal creatinine at the time of doing transplantation is more than 5, so by definition wise is called as either marginal donor or expanded criteria donor, then you can go for frozen section biopsy, which we usually do in our center at IKDRC. If glomeruloscopy...
No, Dr. Deepak, it was just to rule out the COVID transmission from cadaver donor. So what is your opinion about that?
Sir, I don't know regarding this, but I don't know, sir, regarding this.
Like if your center has expertise for getting a frozen section and demonstrating viral particles in that require little bit of expertise, then that can be considered as a viable option.
Yes, sir.
So moving ahead, now we have done everything in our hands to prevent and to choose a donor and recipient very carefully. But then the fact of life is that our recipients who are already transplanted are also getting COVID-19. Quite a few of them, as seen by even the data presented by Dr. Kute in a study. So Dr. Arghya Mazumdar, I would like to know from you, what are the outcomes of COVID-19 in kidney transplant recipients? How they are different from other individuals in your experience and in the literature?
Well, initially we were quite apprehensive and we thought that these are very immunosuppressed patients and that, the outcome will be very bad with this sort of immunosuppression they are on. Well, we have, first I'll mention the data we have, the data in the literature. Now we have good Indian data and Western data. So US series, multi-center study shows that usually mild presentation in more than 56%, moderate in about 20-21%, and severe presentation only in 1/4, so 24%. And the series from 13 transplant centers published by Dr. Kute in the transplantation that also shows mild disease in 60%, moderate in 20%, severe in only 14%, and in 6% they were totally asymptomatic. And mortality in this series was about 11%, and the in-hospital mortality was around 47%, and only in, of course, that is expected even in non-immunosuppressed patient in These patients who are on ventilator vasopressor support in ITU, the mortality was up to 97%. Now, I think my experience has been similar because in most cases, the presentation has been mild and maybe the immunosuppression has prevented. I used to watch them very closely and maybe the immunosuppression has prevented the cytokine surge in many of these patients. I have not had to use tocilizumab in these patients, and just by cutting back on immunosuppression, stopping the mycophenolate, and I've not had to modify the calcineurin inhibitors, but just by cutting back on the mycophenolate and maintaining a higher dose of steroid, either dexamethasone or this, we have managed most of the patients. I just lost 2 patients who were very severe and who went on to develop, one developed fungal infection and the other went on to vasopressors and ventilator. But all the other patients we managed to salvage and they were relatively mild to moderate presentation.
Sir, was there any graft loss?
No, there wasn't graft loss. That is another aspect we were quite worried about, that whether it will lead to acute rejection. And that is another thing we were monitoring closely. None of my patients, we didn't have any acute rejection or graft loss.
Well, that is very, very interesting, and it's a happy thing to know. But our data from study of Mumbai is little different. Like we have published a multi-center thing from Mumbai where we had the outcomes were okay, but the graft outcome, particularly the AKI when they developed COVID-19 associated AKI, graft did suffer a big bit of brunt. So that's just a comment. Over to Dr. Balwani.
Dr. Jha, what is your comment about immunogenicity of various vaccines, COVID vaccines available in India in post-renal transplant patients?
So immunogenicity, a general comment is that because the patients are immunosuppressed, so their mounting of that response is poorer than an immunocompetent patient. So that is for sure. Even in immunocompetent, the measurement of that immunogenicity is not that easy. I mean, it's not. Though, I mean, of the first dose, the immunogenicity was roughly around 70%. This is in immunocompetent, 70%. And after the second dose, very close to 90%. That was the figures which were quoted. And there was one meta-analysis just looking by this for the preparation for this panel. So there was one meta-analysis of 82, such series. And out of that 82, because we had around 4 different vaccines, Pfizer, Moderna, and AstraZeneca, and the Covaxin. These are the 4 major groups of vaccinations. And this meta-analysis, almost 77 of them were on messenger RNA vaccines, majority. And then vector was around 16 and 4 is as an inactivated one. So overall, the seroconversion in the immunosuppressed ones is very close to 50% after the first dose and not better than 2/3 of the second dose. That was the reason third dose was one of the healthcare workers and immunocompromised patients were given the third dose as a priority. So, and we had also, asked for all that booster or a precautionary dose, whatever. So, and the measurement per se is also again very difficult because then you have either neutralizing antibody, which has to be, we have to depend on which one, anti-RBD, that is a receptor binding domain antibody, or it says anti-spike protein antibody. So it's not very, very clear, frankly speaking, but it is low, definitely, that is for sure. There was one, in case you allow me to share just one slide or a picture, share my screen if that is possible.
Yes,
so
sir,
that
please,
was just
please do that.
If I could, yeah. Don't know whether I am able to screen broadcast. So that was actually, are you able to see my?
No, sir.
No, sir.
Okay. So basically I can just read it out. It was from the Institute of Health Metrics. So that was a figure, and that they have given all around 10 vaccines. And they have also given this is for immunocompetent though. So, severity of disease, and they have divided into ancestral, the first wave, the alpha, beta, gamma, delta, and omicron. And they have again divided these two into whether they could prevent a severe disease or they could just prevent the infection. So I'll just briefly, So all the vaccines except probably the Sinovac and the CoronaVac was these two, which was around 50-60%. Most of them were very close to 90% in preventing the severe disease, and infection was also between 65 and 90. But down the line, going to the Delta wave, it was around 85 to 95, the severe disease, and the infection was very close to 60 to 80. Again, going to the Omicron, the severe disease was between 50 and 70% prevention, and infection was very close to, the prevention of infection was very close to 30 to 40% only. So basically, effectiveness at prevention is depending upon various things. The type of vaccine was one, the type of wave or the variant of concern, that was another. So these are many factors, even for an immunocompetent patient as well. Even for an immunocompetent patient also, there was so much of variability. So, definitely it was low, and definitely a third dose or a booster or even a fourth dose comes, we have to, advise our patients to get it. So, but very, very specific going is a bit difficult in this aspect, that much I can say. Yes. Thank you.
True. So my next question is to Dr. Dharmendra Prasad. Part of it, Dr. Majumdar has also touched on it. When your kidney transplant recipients gets COVID-19, how do you manage in short term and over long term? What do you do with the immunosuppression and the antiviral treatment?
Thank you, ma'am. As you already told, there is a two issue in management of COVID-19 in recipient, kidney recipient. One is what is the severity of the patient, whether patient is hospitalized or non-hospitalized, and second issue is the change in immunosuppression. So first, we took what is the severity of the patient. If the patient is mildly and not hospitalized, in that scenario, slight change in the immunosuppression, especially we can either reduce the dose of anti-metabolites or hold the metabolites for a few days, and symptomatic treatment is sufficient for the recovery. But whether a patient is hospitalized or whether patient is categorized in moderate to severe category, whether patients require oxygen therapy, and then in that scenario, we have to consider for the antiviral agent or what available agent to treat the COVID-19. So in case of the moderate to severe patient, whether patient is hospitalized and they are stable, only we can use available monoclonal antibody, and we can use molnupiravir, or you can also use remdesivir. But if the patient require oxygen or low flow oxygen, in that scenario, we have option of use dexamethasone with remdesivir, and depending on the what is the GFR level, what is the liver profile of the patient. If the patient require mechanical ventilation, again you have to use dexamethasone with remdesivir. But if the patient require ECMO therapy and patient condition deteriorates, in that scenario, you can use tocilizumab besides all these medication. Besides this, we can also use the prophylaxis for thrombosis, whether patient has a previous history of thrombosis or whether hospitalization getting prolonged. In that scenario, we have to use anticoagulant agent like heparin. So in change in immunosuppression, again, sir has already told that we have to increase slight dose of the steroid, decrease the dose of the anti-metabolite, or we can hold anti-metabolite for a few days. But again, we have to consider for the risk and benefit of holding this important immunosuppressive drug to prevent whether patient is going to have a rejection or not. So we can change the immunosuppressive dose. We can increase the dose of steroid. We can maintain the calcineurin inhibitor, and by this way we can manage the COVID-19 transplant recipient.
Okay. Dr. Prasad, can you share something on use of monoclonal antibodies?
I have not used it, but I think it's not available in my area. I have no personal experience of using monoclonal antibody, but I have seen transplant recipient patients who are mildly symptomatic. They are just improved with just decreasing the dose of anti-metabolite mycophenolate and increasing the dose of steroid. but I have no personal experience of using monoclonal antibody.
So over long term, when do we again get back to the original dose like of antimetabolites? What is your time frame about that?
I think at least we have to wait 4 to 6 weeks after the getting recovery from COVID-19. We can increase it because we have to judge again. We have to judge what is the risk for the rejection in long term. So because antimetabolites are one of the important immunosuppressive agent, so we have to come out the original dose of the antimetabolites after 4 to 6 weeks of the recovery.
So next question is for Dr. Santosh. Continuing about vaccination. So is there any data about booster dose in kidney transplant recipients?
Not yet. I have searched a lot, but there is no data on the booster dose and the antibody response to that. Recently, it has been launched and data are yet to come. But there is one study basically on mRNA vaccines. In 120 patients, they randomized into two groups. Both total patient received 2 doses of the vaccine, and regarding third dose, they randomized and given saline placebo in one group and third dose in another. And they seen that the antibody response in those who received the third vaccine dose is very high. And they are not only very high, they are also neutralizing the wild variant plus alpha, beta, and delta variant. So definitely, if you use the third vaccine, as the solid organ transplant have lower immune response to that COVID vaccine, so definitely booster dose should be used as per the local guideline also. Okay.
Here, actually, we do not have data, and we also know what titer is protective and for which variant. So it will be, I think, clear in near future after further detailed studies.
Yeah, definitely.
Over to you, Jyoti.
Yeah. So my next question is to Dr. Prem Shankar Patel. Whether all human tissues are considered capable of transmitting COVID-19 infections. What are your views about solid organs, kidney and otherwise?
Okay, well, ma'am. As far as evidence is present, it is not associated with transplantation of all organs. Case series and few case reports has demonstrated that risk of transmission is associated with lung transplantation, whereas it has negligible or minimum risk with other solid organ transplantation. But to conclude the definite opinion, we need large evidence with good number of patients. Thank you.
Yeah, I agree with you.
So our last question, I think we are just short of time, to Dr. Deepak. Deepak, as we have seen 3 waves till now, so and we have learned few things about transplantation, doing transplantation during COVID. Say, for example, if there is 4th wave and positivity rate is high and 20%. In such scenario, if there is available infrastructure, should we continue with routine transplantations or should we halt at that moment for a few weeks? What is your opinion about that?
So this is a very tricky question again. But the good thing about kidney transplantation is that we do have an alternative option in the form of hemodialysis. And better understanding of viral genome and the level of infectivity, if suppose 4th wave will come in the future, will guide us to whether we will continue this transplantation or we have to suspend. To minimize the risk of infection, and it is anticipated that the infection dose which is required for post-transplant recipient to have COVID-19 infection is less. So we don't want such kind of transplantation which will increase the risk of both donor and recipient along with organ procurement organization and transplantation team. But during the 3rd wave of COVID pandemic, several centers across India have done a significant number of transplantation. Let's say from our part of this country, RN Tagore has done a significant number of transplantation. So before going or taking any decision, if suppose fourth wave will come, I think better standing of that particular type of COVID-19 should be taken into the account. I think it is visible to suspend all the elective and non-urgent transplantation in the centers, but in selected case-by-case basis. If suppose patient is on long waiting list and he is highly sensitized and he is not getting any suitable donor, and ultimately you have found any suitable donor, then in those hospitals who are having optimal resources and a strict COVID-19 protocol has been taken out, then on case-by-case basis, certain transplantation should continue.
Here, I think we should also look for the effectiveness of vaccination by measuring the antibody titer. That may also guide us. So that's okay, Dr. Deepak. It was good listening to you. In view of limitation of time, I would like to thank all the panelists for wonderful discussion. Myself and Divya would like to thank organizers for inviting us for this panel discussion. Over to you, Dr. Hass.
Thank you, Manish. Thank you, Divya, for the wonderful session which you just moderated. And thank you, Argo sir, Jha sir. Thank you. Thank you very much for participation. Thank you, all of you.
Thank you, sir.
Thank you. So now we move on to the last session. And the session is going to be moderated by Dr. Bharat Shah, who is a senior consultant nephrologist from Global Hospital, Mumbai. And I would also like to call the panelist, Dr. D.S. Ray, a well-known nephrologist and transplant physician from Kolkata. I would also like to call Dr. Vishwanath. He is head of the department and senior consultant nephrologist from Manipal Hospitals, Bangalore. So over to you, sir.
Thank you, Harsh. Good afternoon, everyone. We have been running late. This is the last session, but I think this is the most important session. It is most important because if you look at the entire program, this is one subject which is completely new in the field of transplantation. And I think we should give credit to Dr. Bahadur for bringing this up. And in this session, which is going to be a panel discussion, I would first request Dr. Bahadur to tell us about his experience. And after he has made his presentation, we'll have a panel discussion on this subject. So without wasting much time, because I know we are running quite late, I would now request Dr. Bahadur to make his presentation, and then we'll have our panel discussion. Dr. Bahadur.
Thank you, sir. It's really a pleasure. And I'm very interested to find the top transplanters of India, I should say, Dr. Bharat Shah, Dr. D.S. Ray, Dr. Varghese, Dr. Vishwanath. So I'm honored to be among them. And it is indeed a pleasure to be speaking today. So what I have decided, let me just share my screen. Right. So, right. Since it's the fag end of the day, my first 10 slides would be more theoretical, because we need to understand what's the theory behind the case. And then our next 10 slides is about a case which really got us thinking what's happening. And the last 10 is to know what is the scene around and what is the extent of the problem and why we should be really talking about this NUDT 15. And so first thing is very basic. We know there are two sugars, the ribose and the deoxyribose, so building blocks of DNA. So add up a nitrogenous base, which is either a purine or a pyrimidine, adenine, guanosine, thymine, cytosine, uracil. Okay. So if you add a nitrogenous base to a sugar, we get a nucleoside. And you add a phosphate group, 1, 2, or 3, and you get a nucleotide. So that's a very basic thing, because we would be talking about nucleoside analogs. So that's why we need to know what we are talking about and how does a basic DNA replication happen. Well, it does require us to have a nucleoside triphosphatase. So that's important. So this is one nucleoside, that is a sugar. Add to it the nitrogenous base and the 3 phosphate bonds. And then the complementary purine or pyrimidine. So adenine with thymine. And then there is this extension of the, so that is how DNA gets replicated. And so if we need to target the DNA replication, this is the target, the nucleoside triphosphate. And so what do nucleoside analogs do? Well, these are not actual natural nucleoside. They are a mimic or an analog of the same. So nucleoside analog is an inactive form. It has to be activated to a triphosphate form. And when they get incorporated into the chain, as we said, mimicking the nucleoside triphosphate, the chain of DNA replication gets terminated. This is exactly what is shown here. An analog, it gets a monophosphate, then a diphosphate, and a triple phosphate, and gets incorporated and causes DNA synthesis to be terminated. And so, where is the use of nucleoside analogs for us nephrologists? The commonest use would be in immunosuppression, as in azathioprine, antivirals, and in cancers. So if we inject analog into an antiviral nucleoside, it stops, or a cancer cell, it stops, or a activated T cell, it stops. But all of these have got a narrow therapeutic index. And so it would be helpful, but very dose limiting adverse effects. And so what is this NUDT15 enzyme? Well, it's a nucleoside diphosphate linked moiety X-type motif 15. So that's a long name. What does it do? It's a Nudix hydrolase enzyme, which actually hydrolyzes compounds with a general structure of a nucleoside diphosphate. So now we get it there. This is a very important enzyme, which is a nucleotide pool sanitization enzyme. So if there are oxidatively damaged guanine in the system, possibly, we still don't know what the exact natural use of NUDT15 is, but possibly all the damaged nuclear material of DNA synthesis can be catabolized by the NUDT15 enzyme. So rather than adding into a triphosphate and becoming more toxic, it can be dephosphorylated and to become an inactive form, possibly. And the locus is on 13q14. And so how does it act? So the way we have seen this figure again, an analog gets phosphorylated, 1 phosphate, 2 phosphate, 3 phosphate. And here is where the NUDT adds up. So it actually catabolizes the active nucleoside analog. So it's a counter-regulatory mechanism that we do want the DNA termination of the cancer cell of the viral synthesis, but we do not want it to go on and on, because if it does so, it's going to become toxic to other cells. And so this is a sanitization enzyme coded by NUDT15. And so that is where it is hydrolyzing this. And so there is a wild variant. So this is exon 1, 2, and 3, and we saw 13 on the 13 chromosome, and it has got various. So let's not get into a lot of issues on this, but there are 4 coding variants. This is 1, 2, 3, and 4. So 4 coding variants representing 5 haplotypes. So there is a wild type, and then there are another 4 which are having a different structure genetically and a different structure phenotypically. The basic thing is all of these variants have their activities, that phosphatase activity is low. And in certain NUDT 15 variants, like this one, which is depicted in red, you can see it is very, very low. This is the wild type, and this is the P-arginine 139 cysteine. So it is very, very, very low. And that is going to make a difference when we prescribe certain drugs that we routinely use. Now, junket cells are cancer cells. Whether they have wild type or mutant type, they grow. When we introduce 6-mercaptopurine, that's an azathioprine subsequent substrate, if you have a wild type, which is the normal type of enzyme, then the cell gets lysed to an extent. But if there is a mutant NUDT 15 in your genotype, then the process and the effect is multiplied several times. And so does the apoptosis marker or the toxicity marker with a mutant. So in short, if we have an NUDT variant, it will increase the effect of the particular drug to the extent that it can become very toxic. So now we have this case, and how we stumbled onto this. A 27-year-old man, hypertensive, small contracted kidney last 2 years, on dialysis last 1 year, mother donor across the blood group. Baseline titers were anti-B 118 and 128. So AB incompatible. And what our protocol is, Ritux 200 mg 2 weeks prior. Then typical prednisolone TAC MMF 1 week prior. And he required 3 sessions of plasma exchange with a donor FFP in the last. And so what happened is, in the first 7 days of admission, when we did start his triple immunosuppression, 3 days prior to transplant, he developed severe pain in abdomen. To that extent, we did all the routine things. The stool was normal, amylase lipase normal. We did a CT scan, pelvis, what was, absolutely unremarkable. And then, of course, we blamed it on the MMF and changed it to ASA 3 days earlier to transplant. Abdominal symptoms settled in 24 hours. He could get a titer of 1:2 and nil. And the patient was transplanted on 24th May with an induction of ATG 1 milligram per kg. And of course, now the transplant was uneventful, and the create came down very well, and as expected. On day 6, we introduced the Ceftriaxone Valgan prophylaxis, which is again standard for us. Now the problem started on the day 11. There was severe leukopenia, thrombocytopenia, and severe hair fall. Look at this. Total leukocyte 330, and actually absolute neutrophil count is just 30 points or around 100. Platelet counts down, HB down, and day 11 to day 15. At day 15, we came to this. And of course, at day 11, as a knee-jerk reaction, we did stop Valgan, we did stop azathioprine, and definitely we looked at other reasons of severe leukopenia and pancytopenia. CMV negative, parvovirus negative. There was nothing to suggest sepsis. TMA, no markers, no rejection. Create was normal. No fever, normal bilirubin, LDH, no schistocytes. All these negative, blood culture, urine negative. But once we stopped the azathioprine and the Valgan, the problems resolved. So in our mind, we thought, well, this is definitely due to azathioprine, and we stopped azathioprine. So he was on 2 drugs. And Valgan had been stopped empirically. We kept it off. We did a CMV, and CMV quantitative was negative, so we just didn't start it at that time. And then from 11 to 18 days, the cytopenia became okay. And we thought, well, we cannot start azathioprine because he had somehow, reacted to it. So go back to MMF, and so we did. And day 22, we restarted, and this time there were no symptoms on day 22. And so we thought, okay, this is an ABO incompatible, has received plasmapheresis, Rituximab, ATG, and the sort. So Valgan was restarted on day 36. And when we had got this on day 11, all that severe neutropenia, based on azathioprine prescription recommendation, which we do not do. Any patient who is to be put on Azoran needs to do a TPMT genotyping. It is there on the box, which somehow at least I have not been doing, but now doing it frequently. So it did show 2 normal functional alleles. And so that made us worry. If this was not azathioprine, then the second thing was, could it be NUDT of 15 publications? Now, publications came out in about August and September, I'll talk about, and these were publications in the basic research journals, because we went back and based on that and some findings based coming back to a few more studies in some other fields of literature, we found that we should be doing a NUDT 15 genotyping, which we did. And to our surprise, for the first time, we found 2 non-function alleles, .3/.3. Normal is the *1/*1, even for NUDT. So anyway, so we thought our problem is solved, because we read up and found that if it is not TPMT, then NUDT 15 also, as we know, is enzyme which clears up nucleoside analogs, and so possibly we have caught the problem. But the problem resurfaced again at day 48. Patient had fever, but obviously the patient was discharged. He came indoor once again, and this time again we find a total count of 360, and this time the ANC count was only 50. And obviously everything was done, blood culture, CMV, there's that, CMV PCR, and X-ray chest and a CT scan, left base haziness. So initially we thought this must be sepsis, but he was not septic, except for that fever which he had for the first 2 days, and he was put on meropenem empirically. And definitely we thought, oh, this time what is happening? It must be this anti-metabolite MMF. So we stopped that. And of course, we stopped the Valgan once again. And over the next 5 days, the fever subsided and the TLC improved once again. And then we went back to these basic research journals. And to our surprise, we found 2 articles which were not yet published, which have been published in the November and December now, wherein, and which we'll talk about, which showed certain things that ganciclovir is also metabolized through NUDT 15 to its inactive form, ganciclovir. There was no talk about valganciclovir, but we know that this is a precursor to ganciclovir. And over time, MMF has been reintroduced. Patient has regrown his hairs, pancytopenia reversed, and renal functions continue to be normal. And if you look at this chart, actually it tells us how it all went. We started ASA here, we had a transplant happening here. This is the TLC count. Valgan was started here, and we did stop both of this, but zoop, it came down here almost to 150. Both had been stopped. It went back again. And then when day 48, we started valganciclovir again. Now we know because of this, not because of azathioprine, it went down to again 50 and sepsis. And when we stopped it, it came back. And we could easily restart MMF at 2 grams. So this was not an anti-metabolite effect. Patient is doing well. So even now, after about 9 months. So this was the article which came in the Cell Chem Bio in 2021. November actually, which told us that ganciclovir behaves like a nucleotide triphosphate. It is phosphorylated like this, one monophosphate and triphosphate, and then NUDT actually puts it back. So how did they find? They had a blocker for NUDT 15, TH8321. So they were actually looking to treat resistant cytomegalovirus infection. And so when they introduce a blocker to NUDT 15, what they could show is all these red dots that we see, and along with a blocker of NUDT, the effectivity is huge. So there's hardly a few dots that remain, and that is shown in this particular thing. So if you block NUDT 15, you increase the effectivity of ganciclovir, but you also increase its toxicity. So that was the paper. And the other paper that we were very interested to see, almost in the next month, it was NUDT 15. It came up again in one of the basic journals, Natural Communication 2021, and in which they tested 12 nucleotide analogs with NUDT 15. And they found that pyrimidine analogs, actually, it doesn't matter. But purine analogs, such as acyclovir, ganciclovir, and now we know that its variant, ribavirin, clofavirin, all of these catabolism is affected by NUDT 15. So either you have a blocker which is in the lab, or if you have a variant in which the NUDT 15 does not work as much as it could, two things happen. One thing, its effect becomes the effect of the triphosphatase, whether it is anti-cancer, whether it is antiviral or anti-CD4, increases exponentially. So it helps and it damages. And so another good thing that if this is a thing, if we just 1 minute, if you can go, then we can go on something else, is NUDT 15 acts at both the sites. We are interested, azathioprine and Valgan, because the TPMT actually diverts azar to inactive metabolites. So it is a diversionary thing. It is not hydrolysis. So it can only divert here, or xanthine oxidase, the xyloric, actually diverts the 6-mercaptopurine to inactive forms, while Valgan actually inactivates the active form, whether it is of a thioguanosine, or whether it's a ganciclovir, or it is valganciclovir. And in fact, I will be talking about maybe in the discussion, even though they have mentioned that zidovudin did not matter, the next patient that we had who was on azoran, developed HIV, was put on a regimen, and to our horror came again with accounts of less than 300, turned out to be an NUDT 15 variant. So even though as per basic science journal, the pyrimidine thing did not affect, but in practice, we have proof that it does. And when we stopped that and changed the regimen of the anti-HIV, then the counts went up and we went home. So before we go to NUDT 15, we just look at TPMT variants and azathioprine. The reason is I want to show that the problem is not small. That is the important thing, which the elephant in the room somehow has been missed by us. So even TPMT, induced leukopenia, is a well-established phenomena. We should be doing TPMT testing, has been recommended. And TPMT, but this, since all the literature has been generated from the West, this TPMT mutations, which are much commoner there and much lower in Asians, that is why we have been able to get away with it. But even though TPMT mutations in Asians are lower, thioprine-induced leukopenia is much higher. So what causes it? And that is NUDT 15, which we have been missing. So to that extent, if you look at Koreans who with Crohn's disease, something like 31 to 39% actually developed azathioprine associated leukopenia, which is huge. And now you look at azo and NUDT 15 variants and azathioprine. There are enough studies on inflammatory bowel disease, hematological malignancies, and autoimmune disorders using ASA, who have described NUDT 15 variants, wherein the required dose of ASA was significantly low. But it is very surprising that there is only one case report in 2018 which talks about azathioprine-induced leukopenia in a kidney transplant patient. So our awareness is much less, and the ASA dose reduction is recommended by, in this clinical this particular paper has been there. And so now we look at the distribution of this variant. So if we look at the distribution of variant in Koreans, so Asians, there's hardly any TPMT variant homozygous variant, 0. While if we look at Koreans with NUTT variants, there is very significant number of homozygous and heterozygous genetic variation in this particular NUDT 15. So out of 1,000 patients, that is type of frequency we are talking about, which is huge in Koreans. And now we look at the biogeographical grouping and look at this. Normal function, that 1/1. 99% of Europeans and the West have normal wild types, while East Asians have almost 14% will have a variant. Now 14% in a normal population is not a small amount. So in Asians, Southeast Asians, the frequency of allelic distribution of NUDT 15 variant is to the extent of 15 to 17%. Let us look at, this is based on the alleles. Let us look at the functions. So all these functions, depending on what alleles we get, it may be a normal metabolizer or poor metabolizer. Now look at my patient. He was 3:3 here, 3/3, poor metabolizer. That is why we went into trouble within 11 days of doing this transplant, because we had 2 nucleoside analogs, azathioprine and valganciclovir, acting on this. So we look at biofrequency as metabolism. The same story. Europeans, they metabolize normally, while East Asians and Southeast Asians, something like 15 to 20%. Indian experience. Look at the Indian experience coming from Hinduja. It said there are 17% NUDT 15 variants in Indians. So of the patients on azathioprine who received for ulcerative colitis, Crohn's or autoimmune hepatitis, this is the level of Indian NUDT variant. And accordingly, it has been shown that the dose at which azathioprine has to be reduced. So a person gets grade 3 or grade 4 leukopenia, that is less than 3,000 or less than 2,000 of TLC, is only 0.86 milligrams. While a normal carrier, if he gets leukopenia, it is 1.5 milligram per kg. So even at much lower doses, a more serious type of leukopenia is seen. So that is something which is very important. We are using these drugs every day. And so where do we use Valgan? We already know about azathioprine. We use it for prevention and for possibly treatment of mild to moderate CMV disease. And you will be surprised that actually some degree of leukopenia has been seen based on these AGT publications, anywhere from 25 to 60. And definitely the blame has to be shared with the induction agents, whether it is ATG or is Graflon or it is rituximab, and the antiproliferative, whether it is MMF or azathioprine. So somehow, because there are so many things happening in our transplant, most of the time we have been blaming this leukopenia mostly to MMF, mostly to ATG, mostly to our other induction agents, and we have somehow missed this NUDT 15. So, suppose we have a transplant patient with the NUDT 15 variant. So what would we, how will we treat him? for prophylaxis. If he's a heterozygous carrier, we may have a reduced dose, or we may not start it at all. We may just look at frequent CMV PCRs and then take a call when to use it, the Valgan. And suppose he does get CMV, then we have a choice to use this in a reduced dose, ganciclovir or valganciclovir, or use the alternative doses of cidofovir, foscarnet, CMV, IVG. IVIG is generally not available, and these are very toxic. So this remains our choice. But then there is another possibility. We may decide to use a protocol which is non-inferior for biopsy-proved acute rejection, non-inferior from primary endpoint of eGFR, large transform trial showing everolimus and reduced dose CNI in the present dose scenario using same immunosuppression induction in the form of ATG or basiliximab, whichever the people would have chosen, no change in the primary endpoints of their efficacy. But viral infections, specifically CMV, very low on. So in the Indian subset, there is a point to think, if 15% to 18% of our patients are having some degree of NUDT variant, which is a big deal, do we think about this? But the question is, one may question whether transform is also includes European patients. So then this was the Asian subgroup. And in the Asian subgroup also, what was seen was that BKV CMV, whether we look at the risk reduction ratio, wonderful, 0.33 for CMV, or we look in the absolute or P values, 4.4% versus 13.4%. When we use the low dose plus everolimus. So food for thought, whether that is something which should also be kept in mind. And of course, this case we presented in the transplant infectious disease. Just to say, it was received on 9 January and accepted in 15 January because they felt this was something which has never been reported worldwide. So let's discuss the way forward, and it would be really a pleasure having so many big transplant nephrologists doing a lot of transplants and hearing from them what their experience with post-transplant leukocyte would be. Over to you, Dr. Baracha.
Well, thank you, Dr. Bahadur. That was an excellent presentation. And as I said in the beginning, this is one thing which is completely new in this ISOT program, and therefore it is very interesting. Maybe the organizers purposely kept this new thing as the last part of the program to keep everyone's interest going on. So Bahadur, very nice presentation. My first question to you, I have my colleagues Dr. Ray and Dr. Vishwanath with me, but I'll take the liberty of putting the first question to you. MMF is also an inhibitor of furin synthesis. Does NUDT15 variation affect metabolism of MMF, and does it increase the risk of bone marrow toxicity when MMF is used?
Yeah, so that is why actually I went through the basics of our NUDT15, nudose hydroxylase. The substrate that is required is a nucleoside. It has to have a nitrogenous nucleoside base in a phosphate form. MMF doesn't fit in there, while valganciclovir actually has a nucleoside base and gets phosphorylated. But I am very sure, and I'm looking at, actually I looked at other drugs also, and in one of the patient who was having this heterozygous variant, and we were using a tetracycline variant for nitrogenous antibiotic, we were using minocycline, and she was getting a pigmentation of the skin. I somehow suspect that this particular enzyme, which is deficient or variant in a significant number of our population, we'll find that this will also affect, because all the effects are not known in certain more drugs. I am sure of this. But as far as MMF, sir, is concerned, we have been safely been able to, reintroduce MMF to the dose of 2 grams, and these patients are doing well. So obviously, it is not a substrate for NUDT15.
Now, the standard triple immunosuppression is TAC, MMF, and prednisolone.
Right.
So when someone is introduced on CMV prophylaxis with valganciclovir, and then if leukopenia develops, what would be your first approach? To look for NUDT15 variant, or to reduce the dose, or stop mycophenolate mofetil?
Actually, I would see, because the turnaround time of NUDT15 today is still about 10 to 15 days. Actually, we get the report. So the first thing they see, actually, if on another, possibly on another forum and on a more nephrology forum, I would be presenting that. We have subsequently looked at about 53 patients who, from my database, who actually developed leukopenia post-transplant. And I can tell you offhand that it's 11 patients turned out to be NUDT variants. It's a huge, it's almost coming to 22%. So yes, going forward from that day, ordering for an NUDT15 has become more or less routine if the patient is developing leukopenia. Yes, sir.
Dr. Ray, I have a question for you. Do you find the problem as common as has been shown with use of azathioprine and valganciclovir? Do you find this a widely seen problem in clinical transplantation?
Thank you, Dr. Shah. I must appreciate my friend Dr. Bahadur. Every time he comes with a new theory and so interesting. So actually, I appreciate this. See, leukopenia is a common problem, especially people like us who use induction therapy of thymoglobulin. It's common, at times it's very difficult problem. But majority of time we have been able to handle this by modifying the drugs which causes bone marrow suppression. This is something new unless we actually have a study of our transplant patients, how much of them or how many of them have NUDT15 variant. It's very difficult to comment at present. We nephrologists try to, modify. See, if somebody has a kidney failure, a drug is not excreted, we reduce the drug and reduce the cost of medicine. So maybe valganciclovir we can use in a lower dose, and that's rather helpful for the patient than harmful. So maybe in future we'll study this, but for the time being, we have been able to do it in most of the situations by modifying our drugs. Thank you.
The next question is for Dr. Vishwanath. Do you routinely use valganciclovir for CMV prophylaxis in transplant patients? If you do so, in what percentage of cases do you see leukopenia? And if you see leukopenia, in what percentage of these cases have you had to withdraw valganciclovir? We cannot hear you. You may have to unmute yourself. Dr. Vishwanath?
Can you hear me, sir, now?
We can hear you now, yeah.
I think my mic was a problem. We do use valganciclovir prophylaxis. As Ray sir mentioned, we also use extensively induction program. So any of the induction patients, we definitely use valganciclovir. And we do commonly come across this leukopenia. Once you give induction, they're on good dose MMF, valganciclovir, then we'll be wondering what caused leukopenia. And if you ask me the percentage, at least about 1/3 of the patients, we do have leukopenia significant, needing reduction of these medication. And then comes what to reduce first. So we are all worried to reduce MMF because we don't want to have a rejection there. And first thing we lay our hand is on valganciclovir because that we can do away without for some time. And we don't want to reduce MMF and get into trouble. So if you ask me the percentage, almost 1/3 of patients have leukopenia And among them, maybe 50% we reduce valganciclovir, and it is very common practice for us to go to valganciclovir alternate day and then later. And as Ray sir mentioned, it helps our patients. Our patients are happy when we reduce valganciclovir because of cost. But it may not be right thing to do. And Bahadur sir has done a wonderful study. I think it has thrown light on new things which we never thought of. I think hats off to his work, especially in the basic research. And maybe we should do a trial of all the centers and see on all the patients what is this variant, and then decide our decisions based on that. Yes, sir.
Let me see, Vishwanath, if I got you right. Our approach for someone who develops leukopenia would be to first reduce or withdraw mycophenolate mofetil. On the other hand, you said that your approach would be first to stop valganciclovir. Let me ask Bahadur, what has been your approach, and Dr. Ray also? Do you first reduce mycophenolate or you first withdraw valganciclovir?
See, as you saw in this case, sir, we first stopped Valgan actually, and because we were worried about rejection, and we reduced the MMF. In any case, we have not been using 2 grams to start with. It is 1.5 grams that we use. So to start with, and definitely it was reduced to 1 BD twice a day. But then because obviously this was a homozygous variant, so and the leukopenia was very severe, ANC as low as 50 or 100, we did stop MMF completely. That is sure. But if you ask me what would be my practice, yes, from a TDS, I will make it BD, and Valgan we will hold for a few days. I'll send for a CMV. If CMV is negative, I'll be on safe wicket for a period of time. And
yeah, Dr. Ray.
Since we use thymoglobulin, normally we'll reduce or stop antiproliferative fast, and then later on, if required, valganciclovir.
Yeah, because when you are leukopenic, actually your risk of rejection would be less because you are leukopenic. Secondly, when you are leukopenic, you are also worried whether you are seeing CMV infection coming up. With those two things in mind, we normally reduce or stop MMF, and only if they don't respond to reduction in MMF, that we start thinking of withdrawing the valganciclovir.
Okay.
Let me ask the next question. You brought out this point about the Transform study, Bahadur, that you would consider using everolimus with low dose of CNI and avoid using MMF to reduce the risk of MMF, risk of leukopenia. This being the case, and having heard that valganciclovir can contribute to leukopenia, do you feel it would be a good idea for all people to be on everolimus and low dose CNI?
Yeah, so the problem is I would really wish to do that, looking at the efficacy that has been shown in the Transform, reduced biopsy proven rates and better GFR, if not the equal one. The problem remains the cost. So my take on this would be, it would be easier to do an UDT 15 to start with, and in those 15% of patients who may actually be having a variant, then these people would be the right patients to start with, if cost is not the consideration, to on a reduced dose CNI and everolimus, and the rest can actually go on the routine type of thing. Because for everolimus, the whole story is when we use cyclosporin, the everolimus dose was very low. Now everolimus is costly, and with TAC, with its it doesn't boost it. So the cost of therapy becomes pretty stiff, and that practically stops me from using it on every patient. So, but I could use it on those 15 or 18% of patients who have this variant. So yes, this is a possibility. Now, definitely for every patient who is on Azoran, definitely I am doing an NUTT 15. That's for sure.
Dr. Bahadur, I have not looked at the cost, but what would be more expensive, TAC plus everolimus or TAC plus valganciclovir?
Dr. Bharat, can I intervene for a second?
Yeah, sure, Dr. Ray.
I'm in ground zero actually. I'm in the hall.
Okay.
And people, it has been a tiring and long day. So we'll limit little bit, one or two more questions. If you agree, you are the moderator.
Yes, sure. Yeah, Dr. Ray, you may ask a question. I would like to hear from you.
About the cost.
My question was about the costing when you use MMF, TAC, and valganciclovir prophylaxis versus using everolimus, TAC, and no valganciclovir prophylaxis.
Say the valganciclovir we use in a reduced dose. Considering the GFR will be around 50, we use on 450 milligram a day. In that way, the cost of these three drugs will be lesser than the TAC, everolimus, and maybe mycophenolate. And the protection, I don't think the protection against the CMV will be equal whether if you use everolimus, because we use thymoglobulin. I'll be more comfortable using a using valganciclovir than everolimus for this. But if there is other indication, probably we can. This will be an added indication for everolimus.
Dr. Vishwanath, any comment from your end?
In
Since
fact,
you have limited time.
More comfortable using valganciclovir, especially in induction patient, and not using it may not be a good idea because of our previous experience. We don't want to have CMV, and the idea is novel using everolimus and CNI. But if somebody whom have used induction, I would be more comfortable using valganciclovir at least for 3 months.
Well, thank you. Since it has been a long day, I thought it was important because this was something which was completely new in this program. Once again, congratulations, Dr. Bahadur, for coming up with this new point in clinical transplantation. And the message for all, if I were to take from you, Dr. Bahadur, is that we should look for TPMT and NUDT variant in all patients who are on azathioprine.
Definitely, sir. Definitely.
And would you recommend that even for those who are put on valganciclovir?
So as soon as I find that there is a downward trend which is happening in our TLC counts, just I would like to add one small thing based on my clinical experience ever since this NUDT 15 thing. If homozygous variant is there, we will find the WBC counts going down in the first 3 weeks, which happened in this case. If we have a heterozygous variant, we will find these counts going down approximately 6 to 8 weeks later when the patient is actually in the OPD. So we need to be cognizant of the fact that if in the follow-up at 2 months, my counts are 3,000 something, and generally we are giving prophylaxis for 6 to 9 months of Valgan, depending on whether it's an ABOI transplant with whatever. So I would be very, very cautious, and I am doing it. Right? As I say, I have done about 52 patients whom I could detect from my literature who had counts less than 3,000 at any time. And this happened, and we would be coming up with a paper on that. And it does show that, yes, we definitely should do this if a patient is on Valgan, and we find counts coming down 3,000 or less.
With permission from Dr. Bharat. Dr. Bahadur, what is the cost of the testing roughly?
Yeah, in Metropolis, it's about 7,000 to 8,000 rupees.
Where do you do it, Bahadur?
Sir, see, Metropolis, Lal, both of them do it. Their cost is 7,000 to 8,000. But with arrangement with Hinduja, they are doing at 2,700.
Okay.
So they are doing
and for TPMT?
So if the two things add up, it is 16,000. It's the same. It's
okay.
7,000 to 8,000. So 14,000 to 16,000 is what it would cost.
But it would be worthwhile when you are taking up a transplant which is going to cost this much. Yes. It will help you in planning your immunosuppression properly. Yes. And maybe if you find someone who has that variant and you don't want to use valganciclovir, like you said, you would want to go with a safer immunosuppressive combination. So point well taken, and I think a big change in our clinical practice of transplantation. So Dr. Ray, it is all up to you now. It is fag end of the day, but I think it was a good topic.
I mean, two things. You always moderate well. Dr. Biswanath has added a lot of points, and Bahadur comes surprises all the time with your ideas and your experiments. And here, the people have been very hospitable. Know what you have lost. So next time when they do it in partner, do come. Thank you.
Definitely. Thank you very much, sir.
Thank you all.
Thank you.
Thanks. Over to you, Harsh.
Thank you, sir. Thank you for that wonderful discussion which we had, and thanks a lot. Thanks a lot for joining. So, by this we come close to the conference, and before we leave, I can see the people from the pharmaceutical right now sitting behind us, and I would really like to thank all of you. You have been a great support for this conference, and really appreciate your effort. I would also like to thank all my nephrologist colleagues who are with us, who have stayed till last with us. And there's a small request, if can all of the members of the organizing team can come on stage, we can have a photograph. Thank you. Chandan, you also come. Gyan, Prem, Santosh, Deepak, Sir, Om Sir, Hemant Sir, please come. Pritpal, Ramesh boss, please come.
आप लोग बीच में रहिए, हम लोग इधर रहेंगे, तो लंबे हैं हम लोग। To Dr.
And everyone, sir. Everyone, for all of us, sir. And I would also like to thank the audiovisual people, the hotel staff, and last but definitely not least, Ankit and his team, RX Events. Thank you. Thank you. Very